Good morning. Hello, everyone. We are going to be starting our program very soon, so I'm going to encourage you all to find seats. I have a feeling people ran into the same thing I ran into, traffic. So hopefully more people will be here. We're expecting a full house. Thank you all for being here this morning, and our program will start very soon. Help yourself to coffee and to some breakfast items, and we'll go from there. Thank you again. Good morning. Good morning, everyone. Thank you all so much for being here at the 2023 Washington State Mental Health Summit. I'll let everyone get a chance to find a seat so we can begin the program. Full disclosure, we are starting just a few minutes later because for some reason, people don't know how to drive in the rain, myself included. So we'll give them a few more chances to get here, get their parking, and find a seat, but we will be starting the program very, very soon. Good morning. Hello. Again, welcome to the Washington State Mental Health Summit. My name is Roberta Romero. Please, everyone call me Bert. I'm not wearing a name tag. My children wear name tags, so I'm very grateful that you all are wearing them, so I'll know who you all are. We have an incredible lineup of guest speakers and topics. There's going to be more than 350 people in this room once everybody gets here, with another more than 300 virtually. So we have a very large audience all gathered to listen to these incredible lineup of guest speakers and topics. I'd like to start with the land acknowledgement. We acknowledge and honor that we stand on the land of the Coast Salish peoples, land which touches the shared waters of all tribes and bands within the Duwamish, Suquamish, Tulalip, and Muckleshoot tribes. We acknowledge that this is a very small but important step towards truth, reconciliation, and healing for the people whose land we live and work on today. Thank you. I'd like to share a little bit about me. I am the executive producer of the Facing Race unit at King 5 News. Before that, I worked in the nonprofit section, and before that, I was a television reporter at King 5 for more than 20 years. Yes, I'm old. 20 font people. So I'm also a board member of Chad's Legacy, very proud of that, and I've long been an advocate for mental health. Even back when I was growing up in Albuquerque, New Mexico, and that was when we were never supposed to talk about mental health. I was told, don't talk about your feelings. I'll give you something to cry about. You should always be happy. Why aren't you smiling? Lots of that growing up. And can I tell you where that landed me? In a treatment center in Kirkland, Washington for alcoholism and addiction. At the time, I was a wife, a mom to 3. I had a son and twin daughters. I was a career woman, and I was so sick. It was there that I learned about mental health and co-occurring disorders and how to take care of myself. If all goes well, this January, I will celebrate 20 years of sobriety. And I share that with you all today, first of all, because you're my people. You understand what it means. And because there is no shame and stigma with it. I refuse to hide who I am. You now know me. This invites intimacy and vulnerability into the room because I want you to know that. I'm not afraid or filled with shame any longer. I can stand up. And we need to talk about mental health. I am proud to be in this room with you all because I know you talk about it. We are in a crisis, but we are also here because you're the people who are looking for a solution. Thank you. So we would like to take a few minutes to thank all of our summit underwriters, without whom the Mental Summit would not be possible. And I told you I worked in the nonprofit world and I did fundraising. Thank you to every one of you who donated and helped supported this. I deeply appreciate it. We're going to start with our pinnacle partner level, recognized as statewide mental health champions, the Washington State Healthcare Authority, I know it well. The dedication and commitment to bettering the behavioral health system for all Washingtonians is exemplified in the support and commitment contribution from our friends at the Washington State Healthcare Authority. Thank you for being a pinnacle partner. At the transformation leadership level, sure, we can clap. The Cambria Health Foundation, the Kaiser Foundation, and the Providence Wellbeing of Trust. Thank you. And we would like to thank all of our underwriters, Washington Allied Health Center of Excellence, NeuroStem TMS, Community Health Plan of Washington, Molina Healthcare, and the Northwest Mental Health Technology Transfer Center, University of Washington Smart Center. You can also find them all on your Hubilo app and on the agendas that are going to be over at the far desk in check-in. You can find some more agendas if you're looking for them. Now, it is my honor and privilege to introduce you to Todd and Laura Crooks. Dear friends, and dare I say my heroes. Laura Crooks is the co-founder of Chad's Legacy Project with her husband Todd Crooks and the CEO of Yakima Children's Village. Yes, she has a heart of caring. She is a national leader in bringing compassionate healthcare to the forefront and has been instrumental in bringing youth mental health first and into the mainstream beyond the Seattle area. Laura also participates on the Washington State Mental Health Summit Advisory Council. Todd Crooks is the executive director and co-founder of Chad's Legacy Project with his wife, Laura Crooks. The two were awarded the 2018 Hero Award by the Washington Council for Behavioral Health for their comprehensive work to improve the Washington mental health system. This is hard work, and they're doing it, including the inception of the Washington State Mental Health Summit. Among other mental health education and advocacy efforts, Todd serves on the advisory board for the Mental Health Literacy Collaborative, a national organization dedicated to advancing mental health educations in schools. And I'd like to welcome them to the stage now.
Welcome, everyone. I'm going to start because with a little bit different than what I had on my notes, because I got stopped by somebody who is here, who said, I don't really know your story, and I think that the story is important. So Todd and I, while we have other things that we do, we are a mom and dad in front of you. And you'll see a picture of Chad at the end of the day when I come up. And I'm going to get a little teary, and you're just going to have to deal with that because we have to be vulnerable and we have to be real in this space. So I am who I am. So we're a mom and a dad, and Chad was our son. My cousin Anita is sitting at the table over here. Anita is Chad's godmother. We have 4 kids. We have Chad, and then we have triplets, Corey, Grady, and Macy. And our daughter Macy also works in the behavioral health space. And when Chad was away at college at Montana State, he started having problems. And he came home and was going to take a break for a year from college. And then he came to me one day when he was coming home, after he came home from work, and disclosed that he had been hearing voices and that he was scared and he didn't know what to do. And he asked me to go into our bedroom and to talk to me privately about this because he couldn't let anybody else know. A couple months after that, Chad had a psychotic break, was actually treated here at the University of Washington, just right down the road, and asked us not to tell his brothers or sister where he was or any of his friends. And that was hard. And he got diagnosed with schizophrenia, and just 6 to 7 months after he was diagnosed, Chad went around the corner from our house and jumped off the bridge that we look out from our kitchen every single day and died by suicide because the system in which he was treated by really well-meaning people was broken. And there were lots of reasons, none of them due to the people who work in the system. So after we lost Chad, we started asking, what can we do? We're parents and we don't want this to happen to anybody else. And so here we are. Because we listen to people who have these great ideas about things that could happen in our state to make things better for everyone, and yet they were only in their little piece. Just touching the people that were right around them. A prime example, and Maria is here somewhere. A prime example is Chad was treated here at the University of Washington, and at Harborview, they were just starting the Peer Bridger program, which connects people who who are newly diagnosed with someone who's been through it. And in Chad's note, and I have the last words that he ever wrote right here on my arm, and I hold it when I talk. And in his note that he left us, he said he had lost hope. And I know that if he could have connected with somebody else, maybe something would have been different for him. And so we want to make sure other people are well connected, and that the Peer Bridger program is everywhere, and that other programs that you'll hear today are everywhere. So thank you for being here. Thank you for those of you who are out there in the virtual world, because you matter. And so do people who are living with mental illness and struggling with behavioral health issues and addiction, substance use disorders. They matter too, and that's why we're here. So I'm going to... I thought as some of the opening, it would be helpful for you to understand, how do we come up with this initiative process? Like, how do we pick 6 who get up here in front of all of you, and that we're going to ask you to be a part of what they're doing, to sign up for something that they're doing. And so I'm going to go through how we select our initiatives. So this is the process. This year we had a record number of initiatives that were submitted, and so we can't have everybody up here. We'd be here for days and days and days. So the whole focus of the summit was to pick a few things, do those really well in our state, and then move on to the next things, which you'll hear about some past initiatives that are moving forward and what's been done with them. And we figure if we could focus some of the efforts, then everybody could get access to some of these things, and then we can move on to the next thing and do that really well in our state. So that's the whole reason. The initiative is an 18-month process. At first we were thinking it was going to be a year, but it takes about 18 months to get things really going. And so we put out a call for initiatives. We put it out on the summit, we put it on the Chad's Legacy Project, we asked people to spread the word. After that, it's reviewed by our committee members, and our committee members are Todd and I, but also Elizabeth Perry, who's there's Elizabeth, Melody McKee, Kara Tal, and Rebecca Sladek. Which Rebecca's running around here. She's running around. Rebecca's busy, she can't sit in here. So we review them to make sure that they're complete, that they meet the mission of the summit. And then this year we actually came up with a rubric for selecting initiatives, because there were some really important things to us, such as equity and inclusion across the state and diverse communities. So that was added to the rubric that we did, and I'll show you that in a minute. Then it was reviewed by the Summit Advisory Council, and I'll show you a slide of who those people are at the end of this. And then the final selections were made for who was chosen to be able to speak today. This is our scoring rubric. There are 5 categories. There are on the initiative proposals, 16 questions that people have to answer, and those 16 questions were fit into this rubric. Some of the rubric items are scored more heavily because we feel like those are really key for who we want to touch and for the readiness for the programs. So those, I can't read it on here, so I have to look over here, are how much impact this will have statewide. So there's a lot of services here in King County. Todd and I used to live in King County. We know that there's a lot of things here. On the state, on the other side of the state, it's a little bit more sparse. So we wanted to make sure that wherever you lived, you could get access. The benefit that the summit brings to these efforts. So are you ready for other people to sign on, for other people to help you? Not just about money, but actually action, bringing it to different organizations, having new minds at the table to move things forward. Consideration and accessibility for equity, diversity, inclusion, making sure that we are touching people from lots of different backgrounds, from lots of different abilities, and from all different mindsets, so that we can do the right work here and we're not leaving people behind. Effective use of technology and process innovation for presentation and future initiative success. So we want to make sure that people are actually ready, that they know that they can connect with people. Are they ready to bring this forward to people who they can speak in front of, that they've got a story that they can tell, so that people will get inspired by what they're doing. And then That's the last one, preparedness to make an impact and presentation to inspire participation. Meaning we want all of you and all of you out there in the virtual world to sign up for something. We make this free for people, and we say you can't just put a butt in a seat, you have to have action. I'm going to ask you that at the end too. You need to take action. And this is our advisory council members. So I just want to thank them. We have Sue Birch from the Healthcare Authority, Lisa Callan, one of our representatives, Todd, Manka Dhingra, one of our representatives, our senator, David Johnson, who is the retired CEO of Navos and a practitioner, Stefanie Lane, who's with Peer Washington, Susan McLaughlin, who's with the Behavioral Health and Recovery Division of King County, new position for Susan, so go Susan, woohoo. Jim Polo, who is the medical director at Carillon, and he used to be with Regents. Mike Schneider with this Military Family Cares and the Veterans Association, and Jürgen Unützer, who's the chair of psych here. And we want to thank them for helping us, for understanding the importance of bringing people together to be able to move things forward in our state. And now I'm going to hand it over to Todd because I've talked enough.
So I'll pick up the ball and I'll talk a little bit about participation, but it starts with the mission of the summit. And the first line in the mission statement is that the intent is for this to be an inclusive event for all stakeholders in the state. Part of the grant that was gifted to the summit last time from Kaiser Permanente was to try to find ways to improve equity, diversity, and inclusion in the summit. And that learning process was a process. And Jill Patnote, I'm going to talk about you for a second. In the conversations that we had, and I was kind of the administrator of the grant in talking to Jill about the whole question of EDI, I was thinking, yeah, you know, what we really need to do, we need to reach out and call somebody in the Native community. And we need to have a voice from other communities of color. So we need to find somebody from the Black community and all these other things so that we can have all these voices together. And there was a pause on the phone, and Jill said, yeah, Todd, maybe before you do that, you might want to maybe get some EDI training, maybe a retreat for your leadership. And I learned through the retreat process that what she was really saying was, Todd, if you do that, you're going to tokenize a lot of people and you're not going to get where you want to go. So it is a learning process, and it is a process where you don't flip a switch and it happens. But I wanted you to know what the intent of the summit is. We want the summit as an organization, as an event, to be inclusive to every voice. And so I would invite you, if you feel like you have a voice that would be good for us, our intent is to bring you in and have you help us and have you work with us on making this event look like everybody who would want to come here. So that said, the overall arc of what I want to talk about is participation. This is not your run-of-the-mill conference where you come, you learn about some really cool stuff, and then you go away energized and hope that all that stuff gets done. The reason you're here is because you're a mental health stakeholder. And you are the people that can help get the things that you're going to hear about today across the finish line. That's what this event is about. This event is about turning things into final products. So your mission today it's kind of like speed dating for projects. You're going to look at these initiatives, go, you know what, I have a unique ability to help in this area, in this specific thing. Or I could help get this across the goal line with a bill that I could help sponsor, or whatever the case may be. We've got a broad spectrum of stakeholders here. But I challenge you to choose something to walk away agreeing to participate with. You're going to hear next how all that happens. But number one, I wanted to just impart the equity, diversity, and inclusion intent that we have and that we're trying. We've added several things to this event in help desk for the app for those who aren't so comfortable with technology. We have incorporated EDI into the scoring rubric for the first time for these initiatives so that we're looking at it under that lens. But we have a long way to go, and we recognize that, and we're asking for your help. And then secondly, we're asking for your help with these initiatives you're going to hear about and participate and help them get across the finish line. With that, I want to introduce a dear friend of ours and the co-founder of the summit, Dr. Jürgen Unützer. He was not able to be here, and he'll kind of explain, but we do have a short video that he recorded for us to play. So we're going to do that. You'll hear from Jürgen briefly, and then we'll bring Roberta back up to the stage to get us rolling. But thank you so much for being here. Thank you to everybody at home or in your office, because we know that today we'll probably have close to 600, maybe 700 stakeholders part of this event. That's powerful. So let's keep the power rolling. Let's start with Jürgen, and we will make that happen. The video rolls from you. Okay.
There it is.
Good morning, hello, and welcome to all of you. My name is Jürgen Unützer, and I chair the Department of Psychiatry and Behavioral Sciences here at the University of Washington. I remember very well the day that Laura and Todd Crooks from Chad's Legacy came to me, and we conceived this idea of holding a statewide summit on mental health. We envisioned this as a gathering of those of us who have loved ones struggling with mental health and addiction problems, those of us who are providing clinical or social services for individuals living with mental health or addiction problems, for government officials and policymakers who are working together to develop healthier communities, and for all who care about the health and well-being of those of us who are living with mental health and addiction challenges. We envision this summit not as one more forum to get together and decry the terrible state of our mental health care system, the limited resources we all have to help those in need, and the terrible and persistent stigma that is still associated with mental illness and addiction. We've all experienced these challenges, and we could spend way more than a day sharing our frustrations about them. As we conceived this summit, we wanted to create a positive day, a hopeful day, a day where we gather to exchange new ideas about new initiatives that could help us all improve the lives of those who live with mental health and addiction problems. And when I look back at the last few summit meetings and the first few summit meetings, I can honestly say that many of the ideas that we heard about during those meetings did just that. We learned about creative ideas and initiatives. We helped kick off partnerships and collaborations, and we walked away with a renewed sense of hope. And today, we hope to build on that tradition. You're going to hear about some really exciting updates on initiatives that were launched at prior summits. And then you're going to have most of the day to put your heads together and think about some exciting new initiatives. Initiatives for returning veterans, for students, for those of us who are struggling with cognitive impairment and dementia, partnerships between mental health and law enforcement professionals, creative ways to expand and strengthen our mental health workforce, including a new Family and Caregiver Academy that we hope to launch as part of our brand new $250 million Center for Behavioral Health and Learning here at UW this coming year. So lots of great stuff to come. Welcome to today's Mental Health Summit. I am sorry that I can't be with you in person today. I'm in California helping my mom who's having surgery today. And I really look forward to hearing what you all will accomplish today, and I hope you have a great summit meeting.
Thank you. Thank you so much. What I'd like to do now is go over the agenda. We're a little off, but don't worry. I'm a reporter. Deadline. So we'll get this going. So we will have our keynote speaker, Dr. Matthew Goldman, coming up next. At 9:50, we're going to have updates from the 3 past initiatives. Make sure we're on the agenda. There we go. Please hold my hand as I walk into the 21st century. Wait till you hear the Hubilo app. So 10:45, we're going to have the first 3 of our new 6 initiatives. At 12:15, we're going to have a 1-hour lunch break, and it's time to check out the North and South exhibits, and we're going to have a lot of great stuff. We encourage you to go out there. 1:15, the 4th new initiative. 1:45, community leadership panel discussion. We'll have a break at 2:45, the final 2 initiatives at 3, and then the wrap-up at 4 o'clock, and a call to action. Now, here we go. Hubilo, which I just barely downloaded. I'm full disclosure. It was note to self, do it before I get here, but let's go over the Hubilo app. We want to encourage everyone to download it, so if you go to your app store, you'll be able to find it. You can see also the QR code there. Just point your camera at that, and you can get into it very easily. The app is especially important for those attending today because you're going to use that app for participation. You'll be able to ask questions. You'll be able to connect with other attendees. You'll be able to talk to some of the panelists. You can reach them directly. So it's a really great tool for you today. To ask a question in Hubilo, let's see if that comes up. Oh, well, let's navigate. To ask a question in Hubilo, make sure you're in the current session, and then if you look at the slide, you can click Q&A at the bottom of the screen to add your question. Let's see if am I close to this, Elizabeth? Am I matching the words? Okay. You can see the QR code. We've already got that. Next sheet. Hubilo will provide the opportunity for folks in the room and our virtual attendees to connect with the initiatives being presented today with each other. As I said, you can participate in the event chat by clicking on the live chat button. I'm going to go to the next. Okay, let's go here. We encourage you to use this because it's really going to make it efficient, even though I'm not very efficient at giving you these directions. I'm hoping that you're a little ahead of me when it comes to this stuff. I'll go over it some more if you like, and there's help desks, which you will see me at. There are help desks that you can go and ask for help as you navigate this, but it's pretty intuitive and you should be able to follow it. And with that, we do have a tight agenda, but I'll stumble up here for a while to extend it. We really want you to get involved in initiatives. Todd went over that really well, and he explained how it's going to work. This is really an opportunity to make a difference, and we can't do it without data, as you all know. This is the data that's going to drive some initiatives for us and get people to know what we're doing well, what we want to work on. So it's really important that we get your participation in this Hubilo app. And there is a call to action. Oh, there it is. And that's what you're going to be looking for when we ask you to give your feedback. If you're having any issues, again, there's going to be a help desk that you can go and talk to. And with that, I would like to welcome our keynote speaker, Matthew Goldman, to the stage. I'll have him come up. Dr. Matthew Goldman is Medical Director for King County's Crisis Care Center Levy Implementation Planning. He is a clinical assistant professor in the UW Department of Psychiatry and Behavioral Sciences. Now, prior to joining King County earlier this year, he was the medical director for comprehensive crisis services in the San Francisco Department of Public Health. He knows what he's doing, trust me. Dr. Goldman has many leadership and advocacy roles, including serving as a board member of the American Association of Community Psychiatry and sitting on the expanding First Response Commission for the Council of State Government Justice Center. Dr. Goldman is also a physician scientist. He has studied mental health and substance use crisis services and suicide prevention in 4 states. With grant funding from the National Institute of Mental Health, the Robert Wood Johnson Foundation, and the American Foundation for Suicide Prevention. It is my honor to welcome Dr. Goldman to the stage. Thank you.
Thank you so much for that introduction, and good morning. It is really quite an honor to be here. So thank you. I will advance the slide. Great. So it's wonderful to be here representing King County. It's also great that I just recently joined faculty at University of Washington in the Department of Psychiatry and Behavioral Sciences. So sort of have two very exciting professional homes now. And I'll be speaking today on the crisis continuum. There are indeed boom times and so much happening in this space. And I'll share a bit with you about this today. I do want to share just a couple disclosures. These are sort of disclosures, but I like to be extra cautious about it, that I am a paid consultant on some research and policy work for these organizations, and also have that National Institute of Mental Health RO3 grant that I mentioned. So this is a photo of New York Presbyterian Hospital in New York City, Columbia Medical Center. This is where I did my residency. And in 2014, I started my residency. I was an intern in psychiatry, just starting a new career. And in October of that year, my roommate died by suicide. I was like 2 months into intern year. My roommate, Sean, was a medicine intern, so we were both basically spending all of our time in that hospital. And for us, it was different from Chad's story. We didn't have any warning signs. It was just sort of out of the blue, and clearly there was something happening. There must have been, but it was an experience that for me, as I was like a baby psychiatrist, like I didn't know what to make of it. I didn't have any expertise in the field. It was just like a huge thing that totally rocked my world. But I had an opportunity to be in the field in that very early stage, and to get to try to process what happened and think about how do we change the world in ways that are going to move us to a better place where things like this will happen less. I was in a very fortunate position to get to start to learn what some of those opportunities might be. And so fast forward 2 years, now I'm a third-year resident in psychiatry, and I started moonlighting on a mobile crisis team in New York City. New York was one of the earlier cities to have mobile crisis, although some have had them for decades. And so my catchment area was from Harlem through the South Bronx, and I loved that work, going out into the field, like the experience of meeting people where they're at. There was one experience that I had where there was a young woman in her early 20s who was hearing voices and starting to demonstrate some symptoms of psychosis that were just starting, and to go to her home, to get to meet with her mom, and then meet with her in her home environment. You know, she actually seemed okay, and if I was seeing her in the sterile fluorescent lit hallway of an emergency room, I might not have been able to make much of it. But being there with her in her home and seeing that her room probably wasn't in a state that she would have really been happy with or comfortable with had she been in a healthier place, being able to connect with her and her mom in a place where they felt comfortable enough to share about what they were experiencing just made all the difference. I mean, the power of getting to meet people in those types of settings was huge. And so with that inspiration, I really got into crisis services as maybe this is a path. Some good news is that society is catching on to this. There are headlines in the news all the time recognizing the urgency of this situation. New York Times headlines saying a mental health crisis is not a crime. Coverage from CNN on New York mobile crisis and other major news outlets. And there in the middle, you see our executive, Dow Constantine, here in King County, giving an announcement on the Crisis Care Centers initiative, which that's my day job, is I'm the medical director for that initiative, and I'll share more about that exciting work towards the end of this talk. So there's clearly a societal recognition that there needs to be more progress in this space, and there's truly a need for that progress. I know that Jürgen said that we shouldn't have too much downer content, and this should be a hopeful day, but I do want to start with some of the recognition of just how challenging the landscape is right now. Our behavioral health systems are failing in many ways, and inequitably so. Increased suicides and overdose deaths, criminal, legal, carceral involvement of people with mental health and substance use conditions, emergency department boarding, where people are spending hours and hours, even days, waiting for care, and inadequate access and capacity to those long-term services that people need. And at the center of this are major disparities. These issues are not impacting people equitably right now. So some examples from out of state. In Maryland, suicides from during the pandemic halved in the white population, but doubled in the Black population. People identifying as Black account for 41% of those who receive mental health services in the LA County jails, even though they represent only 30% of the overall population. There's longer emergency department wait times for non-Hispanic Black versus non-Hispanic white populations. And there was a study that showed significant disparities among people identifying as Black, Latinx, and Asian compared with the white population in terms of use of any mental health care, outpatient care, and any psychotropic medications in the last year. And I also just last night, preparing for this, looked up some of the recent stats in Washington state. In 2021, 1,229 people died by suicide in Washington state. And our rate of deaths per 100,000 is higher in Washington state compared to the national average. And that increased in 2022. Suicide risk among children is quite surprisingly high. The 2021 Healthy Youth Survey found that 19% of 8th graders considered suicide in the past year, and 9% actually made attempts. And there's disparities there too. Among Washington's 10th graders in 2021, over half, 51.6% of young people identifying as gender diverse had contemplated suicide, and 22.7% attempted suicide. These are sobering numbers. Overdose deaths, of course, are on everybody's radar. And in 2019, there were 827 deaths from overdose. In 2021, that number almost doubled to 1,619 people dying from opioid overdose. And access to care, according to the National Survey on Drug Use and Health by SAMHSA, found that in Washington in 2021, 1.1 million people in this state had a substance use disorder, 1 million of whom did not receive treatment. And 1.6 million people had any mental illness, 300,000 people had a serious mental illness, 39,000 adults attempted suicide. And of those 1.9 million people, only 1.2 million received treatment. So there were 700,000 who did not receive treatment. So access to care remains a real challenge. So I share these figures as, grounding us. And there is a lot of work to do here. And the stories from people who are experiencing difficulties related to these experiences are very much real. I want to ground us now in crisis services. So what do we mean when we say crisis? What's the history? Where are we today and where are we going? In 1968, the first call to 911 was placed from the floor of the US Congress when 911 was authorized as the way to contact emergency services. Prior to that, you just called your local fire department or emergency room or police force. In 1987, the crisis intervention team model was born out of Memphis, Tennessee. It was originally called the Memphis model. In the aftermath of the police shooting and killing a young Black man who was having a mental health crisis. That's when CIT was originated, and now many of you are familiar that CIT is a model adopted by police forces across the country. In 2005, the National Suicide Prevention Lifeline came into existence, funded by the federal government through SAMHSA, the Substance Abuse Mental Health Services Administration. And that was the 1-800-273-TALK number that many people were familiar with and later became 988, as I'll get to in a moment. But where 988 came from actually originated really in the suicide world. And so this is, I think, interesting and important. It was in 2011 where zero suicide became recognized as a national model coming from the Henry Ford Health System, where they were able to actually bend the curve on suicide deaths, which otherwise is extremely challenging to do by doing a top-to-bottom health system intervention. And they codified that as this zero suicide model. But in the aftermath of that work, they realized, well, we're recognizing all these folks have suicide risk, but we don't have anywhere to send them. We don't know who to connect them to. What do we do when we recognize that? And so that's what then informed in 2016 the National Action Alliance for Suicide Prevention, developing the Crisis Now model, which was really the foundation of that someone to call, someone to come to you, somewhere to go kind of idea that's now the foundation of the SAMHSA crisis guidelines that were then published in 2020. In 2021 was the publication of the National Council for Mental Wellbeing's report called The Roadmap to the Ideal Crisis System, which is a very important piece of work that I encourage everybody to check out. And then, of course, in July 16th, 2022, the 988 Suicide and Crisis Lifeline became the new access point for that 1-800-273-TALK number. And in 2023, there continues to be a tremendous amount of energy and expansion. I want to note that Washington State has played an important role in each of these steps. So in 2020, when the National Suicide Hotline Designation Act was signed into law by President Trump, what that did is it authorized states to pass laws that could collect a 988 cell phone fee in order to fund crisis line and mobile crisis programs, among others. And Washington State was the first in the nation to pass that law, HB 1134. On the heels of that, HB 1477 expands that work into mobile crisis. And then just more recently, SB 5120 this year is now creating a whole new foundation for 23-hour crisis relief centers. So a lot of important work done here in Washington State as well that's important to acknowledge. So when we actually talk about the crisis continuum, what are we talking about here? The idea is you have a person who's starting in crisis. And I should start by saying big shout out to my colleague Margie Balfour, who created this diagram, and we published this in a publication in Psychiatric Services. So the person all the way on the left side there is experiencing a crisis. The idea is that a crisis line is available to them. And in Arizona, 80% of calls that reach a crisis line are able to be resolved telephonically and not require additional follow-up services. But some do need more help. And so there's an opportunity to dispatch a mobile team which can respond and then resolve 71% of those crises in the field without needing to send somebody to a facility. And there are some folks who might then need a facility, and so they then have crisis facilities that are specialty behavioral health settings, where 68% of people can be discharged to the community. And after receiving those services, 85% of people in Arizona are able to remain stable in community-based care. All of this means a decrease in use of jail, emergency department, and inpatient resources. There's important inroads in collaboration with law enforcement where 911 calls can be transferred to crisis call lines. Police officers who might be encountering somebody who's in a mental health crisis can request a mobile team to come rendezvous, and then police can leave the scene if appropriate. And police can also directly drop off at a crisis facility. And so all of that means pre-arrest diversion. And overall, what this whole model allows for is really serving people who are in crisis in the least restrictive and least costly environment possible. And so this is the foundation for what we mean by the crisis continuum. I'm going to share a little more on each of the components here. So call centers. So the transition to 988 has been a huge deal. There's been increased call volume nationally. There's also an expansion of the role for crisis call centers. So by expanding what was a 988 National Suicide Prevention Hotline, mostly focused on suicide, to a suicide and crisis lifeline, that means that there's now a greater need for triaging calls, determining if there's a need for active rescue for high-risk calls, increase in capacity like mobile crisis dispatch, bed registries and monitoring of bed capacity. There are some folks who might be fine with hotline support only, and so that work, of course, continues, and then following up after an initial call. There's great focus now on 911, 988 interoperability, on interface between 988 and local programs. Geolocation is an important topic that's to be determined and still being worked out by the Federal Communication Commission. And there's a major focus on equity and access as part of this work. And that diagram on the right, you can see there, just 3 million of the estimated overall calls of related to behavioral health crisis in the United States were going to the suicide lifeline prior to 988. There's a lot of calls that are also going to local county and state crisis lines, and a huge number of calls that are going to 988. And so there's a lot of work still to be done to really pull all these pieces together and get every call to the right place. There are many flavors of mobile crisis, and some research that's been done on these. So single site quasi-experimental studies, meaning observational studies that were not done in a randomized controlled way, but still had important findings, mostly have focused on post-crisis service utilization. There's been a decrease in hospitalization, as well as increased community-based mental health services observed where mobile crisis teams have been implemented. Co-responder models have been found to decrease the use of force and involuntary transportation and increase the referrals to care. A study that I did in San Francisco found that a quarter of attempted field visits by a mobile team was not completed, and so there's definitely more work to be done around workflows and optimizing efficiency of these types of services. There's also a study that looked at reports of crime related to a co-response model being implemented out of concerns. Well, is there going to be more crime because mobile crisis is responding to calls instead of police? And they actually found that there was a decrease in less serious crimes like trespassing, public disorders, resisting arrest by over a third, but there's no detectable effect on more serious crimes. And finally, there have been studies also focusing on cost savings, and there have been significant cost savings, mostly due to diversion from more expensive inpatient settings. There are also many flavors of crisis facilities, and also a bit of a language challenge with crisis facilities where, the term crisis stabilization unit can mean something very different in every state and every jurisdiction that you look at. So some of the examples of these models, there's psych emergency services, comprehensive psychiatric emergency programs, and the empath model, which are typically hospital-based psychiatric settings. There's 23-hour observation or crisis receiving centers. This is closer to the 23-hour crisis relief centers that were authorized under 5120. And these are shorter term, less than 23-hour type assessment settings. Both of those are able to serve both high and lower acuity folks with a full range of symptoms and needs. And they can typically accept police drop-offs, both voluntary and involuntary type settings. Crisis residential settings are more intermediate, long-term, and living rooms and peer respites are sort of the shorter-term analog, where there's stabilization offered in a home-like setting, and mostly peer support specialists being the staffing there, where those settings tend to be lower acuity without an imminent risk of self-harm or risk to others or behavioral distress, and those are usually voluntary settings. But importantly, there can be movement between these settings, and again, there's quite a lot of variation in these details. The final piece I really want to emphasize is post-crisis follow-up care. There is a risk that building all of these access points to crisis services become a bridge to nowhere, where all these different ways of getting into care, but then nothing to connect somebody to on the back end. And so the role for post-crisis follow-up is essential. That is the piece that's really going to keep people flowing and moving through to the services that they'll ultimately need long-term. Crises last longer than 23 hours and 59 minutes. So linking people to long-term care, avoiding reutilization of crisis and other acute services, preventing future encounters with law enforcement is a huge role here. Addressing social determinants of health, so acknowledging that there's many intersecting factors and that providing social service resources and referrals is a very important function of a post-crisis follow-up team. And promoting engagement with peer bridgers and navigators. I mean, I think to the point that we heard earlier that, if Chad had had that peer to connect with, might there have been hope in a way that otherwise wasn't available to him. We have seen such important results from peer bridger programs locally and nationally, and that's absolutely a core part of post-crisis follow-up. We've also heard a bit about equity today, and I want to share a quote by my colleagues, Dr. Vincent and Dr. Dennis. Understanding a problem is a prerequisite to addressing it. For the mental health care system to play its role in remedying the incarceration of a population that is disproportionately Black and Latinx, the extent of racial inequities in this population's mental health treatment must be fully characterized. However, the system's current functioning does not support such understanding. So sort of saying, you gotta measure it to manage it. And that applies in equity work. You have to understand what those inequities are and measure them and monitor them and stay on top of them to understand if you're actually addressing root causes of inequities and reducing disparities. And there's a really good example of that in the paper that I want to share with you. So equity analyses that stratify measures by race and ethnicity, so meaning sort of break down the reporting on different outcomes, they're needed to examine those impact on disparities. A study of a co-responder team, this is based out of Indianapolis, where there was a clinician and a police officer model that was implemented, they found that there was no change in overall long-term risk of justice involvement. But they stratified their outcomes by race and ethnicity. And they found that incarceration was significantly reduced among Black recipients of the co-responder team. And so by identifying the effectiveness for disproportionately impacted subgroups, that can then justify program and policy decisions. If they just looked at the overall program, they might have said, meh, not working. But by looking specifically at that Black subpopulation, they were able to say, well, wait a minute, this is actually one of the groups that we want to prioritize. This could even be considered an anti-racism intervention, right? Addressing those underlying patterns. And so by providing concerted trainings on best practices to collect sociodemographic data in the setting of a crisis, and by ensuring that disparities and equity are tracked regularly and rigorously as part of quality and evaluation efforts, that's a path to moving this work forward. And I also want to call out that work has to be funded. That doesn't all happen for free. I'm not going to go through the details of this slide, but it's just to say there are more questions than answers at this point in terms of crisis services research. There is a ton of work to be done to learn more about crisis call centers, mobile teams, facilities, and post-crisis follow-up care across all these different types of levels of accountability, finance, capacity of services, clinical best practices, and not to mention all of these important cross-cutting topics. And so just to say there's a lot more work to be done, I'm going to share with you just a couple studies that I've had the opportunity to be involved in, but then want to really point to what are future directions and research needed to advance the crisis services field. Escalation in crisis services by episode, looking at Arizona data. So I worked with folks with the Access Medicaid program and Arizona State University to do an analysis of 126,000 Medicaid claims in Arizona. And what we did was we looked at transitions from mobile crisis to crisis facilities to EDs to inpatient settings within a 72-hour period. So meaning if you had a subsequent care episode at a higher level of care within 72 hours, we considered that part of the same episode because you're moving from point A to point B as part of something that's happening in a person's life. And what we found was that 41% of these Medicaid claims in Arizona were delivered in a crisis-only setting, meaning that 41%, because of Arizona's investment in crisis services and the model that they've implemented, they're able to really move people into these, they're able to serve people in lower cost, shorter stay, less restrictive type settings and not have them then escalate into the more emergency department and inpatient type settings. In San Francisco, where I was medical director for crisis services for the city and county there, I had the chance to support the implementation of a street crisis response team, primarily serving people experiencing homelessness in San Francisco. This is a 911 dispatched co-responder program with a clinician, a paramedic, and a peer specialist. And we did interviews with folks who had received this service. So we talked to 20 people who had received this street crisis response team intervention, were experiencing homelessness, and asked them, what did this team do for you? How did it help? In what ways? And we did a whole rigorous qualitative analysis, used the socio-ecological model to describe, person level, relationship level, organization and community level, and society and policy level impact on that person's life. And we found those blue arrows at the bottom are where I want you to put your focus. we found that there were sort of two different types of factors that they described. There were the factors that were within what street crisis response team could reasonably impact. There are a bunch of factors also that were outside of what street crisis response team could actually impact. SCRT was not going to immediately get somebody housing, but housing was often really the thing that somebody needed. And so I share this to say there's such opportunity in crisis services and so much chance of impact, and crisis services won't solve all these problems alone. There's so much else that needs to be added to the equation, and so want to just acknowledge that this really has to be moved forward in partnership with a lot of other resources. There are many additional studies in progress that I mentioned. I am not going to go through all of these just in the interest of time, but so there's some work happening and much more work that still needs to be done. And what I want to highlight on here is the need to advance crisis services research, and I'm sharing this here a little bit strategically, knowing the University of Washington is a co-partner here, and I'm sure other academic institutions, I hope, are represented here to identify what some of those needs are. So there's a need to develop a crisis research agenda. There's so many unanswered questions. We need to advocate for mandates and funding for evaluation in federal and state bills, identifying strategies to engage academic partners in seeking grant funding, sharing best practices for implementation science methods to be able to study those real-world models well, sharing best practices for obtaining, linking, and analyzing complex multi-sector data. Crisis services are hard to study because there's such complex data, but there's ways to do it and pathways to be able to do those analyses, and we just have to share those methods more. Aligning research with quality improvement data. So a program evaluation happening internally can then use a lot of that same data to inform more rigorous research that can then inform the field, and that's part of the idea of this learning health system model. Leveraging big data for artificial intelligence analytics and population-based approaches. There's all kinds of opportunities there. And expanding health services research funding opportunities, grants, conferences like this, and journals as well. So with that, I will, again, not subtly transition to the Crisis Care Center levy as an opportunity for doing some of that work and understanding more about what we're both doing here locally, and then also being able to expand our knowledge in the field. So the Crisis Care Center levy is a very exciting opportunity here in King County. This is a tax levy, a property tax levy that was approved by voters in April of this year, and will draw down significant resources in order to invest in these three major purposes. The first is to create 5 new regional crisis care centers, and I'll speak more about those in a moment. There are 2 other important pieces to this initiative, though. One is to preserve and restore the loss of residential treatment beds in King County. There's been a reduction by over 1/3 of the residential treatment capacity, and so there's a major investment to re-expand that capacity to serve people who have residential treatment needs. There's then a huge focus on the workforce. I'm sure many of you are familiar with the challenges of the behavioral health workforce. It is hard to stand up new programs because there's just not enough people to do all the work. But there are opportunities, there are strategies to expand that workforce. We are working on a range of approaches to increase the recruitment, retention, and importantly, the representativeness of the behavioral health workforce in the county. And that will support both the crisis care centers, but also the entire behavioral health network in King County. A bit more on the crisis care centers. So we're going to stand up a regional network of 5 crisis care centers. 4 of them will be located in these crisis response zones, with the central zone being Seattle plus Vashon Island, and then also the northeast and south zones. There will then be a 5th crisis care center dedicated to serving children and adolescents, a youth crisis care center. What is a crisis care center? Well, hopefully it looks kind of familiar based on all the other stuff I just talked about. So this is, drawing on our understanding of best practices and models here, where there's going to be a 24/7 urgent care front door. There will be a 23-hour observation unit, a 16-bed stabilization unit, and then a post-crisis follow-up team. This is a no wrong door model meant to be able to serve people both who are walking in and also dropped off by first responders. It's meant to serve co-occurring needs, so mental health and substance use needs, as well as promoting integrated physical health. There needs to be a multidisciplinary staff, and peer specialists are a key focus of the workforce in the crisis care centers. There does also have to be access to an on-site access to a designated crisis responder, meaning that a DCR can come into a crisis care center if there's concern for need for involuntary type services. There are many other things I could say about this, but what I just want to highlight is with this model in mind, thinking back to that slide on the Arizona crisis continuum, what this allows for is today, most people who are in a crisis like this, whether they're found by law enforcement or self-present to an emergency room, are going to sit in an emergency room for a while. Most likely, designated crisis responders will be involved because the option is sort of inpatient or outpatient, and there's not anything in between there, and they're not in a specialty setting where they're able to get that behavioral health support that they really need. And so what this model allows for is it becomes a destination for people to bring themselves or to be dropped off by those first responders and actually get that behavioral health treatment from the moment they set foot in the door. And that decreases the likelihood of needing that designated crisis responder involvement and helps us, just as I've been describing, shunt care much more towards those less restrictive and more person-centered approaches. The implementation planning timeline, so where we are at with this process, this initiative again was just passed in April. We're currently working on the implementation plan, which is like a strategy and budget document that will guide the levy over the next 9 years. King County Executive Dow Constantine will transmit this plan to the King County Council by the end of the calendar year, and then the council will adopt that plan with potential modifications early next year. And so the levy term from 2024 to 2032 is right around the corner, and excited to see this all actually come to life. There are many opportunities to get involved, and so just sharing this link with you here, as well as a QR code to be directly involved in the process if you're interested. We also have a website with more information, and definitely invite involvement. But I want to finish on this note, which is, I'm new to Seattle. I just moved here in January, and so I've learned a lot from a lot of you and have a lot more to learn, I know. There is just so much happening in this space. It is really boom times and exciting times. And thinking back to Sean, thinking to my experience of getting to work clinically in a mobile crisis setting, the opportunities in Washington State between the state legislation that's been passed, between what's happening here in King County and many other initiatives, I'm sure, locally and statewide. This is, the window of opportunity is wide open. Like, everybody's in, and the incentives are all aligned in a really amazing way. And so I hope we can keep that window open together. I hope that we can continue to partner, so just really appreciate the opportunity to share with you all today. While taking any potential questions, I want to put up here a slide on resources that are available for people who are in crisis. And so if anybody was, feeling some kind of way while I was giving that talk, there was a lot of intense information, and also just as a resource slide, want to make sure that you all have access to these resources. But again, just really thank you so much for the opportunity and your attention today.
There we go. Thank you, Matt. We have two very quick questions before we move on to the next part of the program. And the first one might have as much to do with some of the legislators in the room as it does with you, but you showed the map of where the centers are going to be located. What would it take to scale this, and has there been discussion to scale this to the rest of the state, to go further into rural areas and have this be a no wrong door model all the way to the Four Corners?
Great question. Probably above my pay grade, but what I'll at least acknowledge is just this Senate Bill 5120, the 23-hour crisis relief center. That's a huge opportunity. The Department of Health is currently doing their rulemaking process, and then afterwards, I know HCA is going to run with it and figure out how to get those services paid for. But you know, that really, my understanding is that's the sort of road to getting this to happen in more places. And we're right at the beginning of that journey. So I think there's a lot more work happening there.
Another question was, with all of the work that you're doing in this crisis moment, one of the biggest frustrations for family members is that there aren't a lot of resources for them to support their family members when they're in these care paths. Is there anything in this model that provides resources and knowledge base and supports for family members of people in crisis?
Yeah, that's a great question. So that post-crisis follow-up program, I think, is one of the best places for that to happen, but it should happen across the whole continuum, where, you know, including family members, especially for youth, so thinking about family members and other caregivers is essential. Like, you know, people are not living in vacuums. You got to be able to build out those support systems. And so the role for the peer specialists in the youth crisis care center, there's going to be, we're planning on there being both youth peers as well as family supports. So, you know, family members who've had their own lived experience of a child having a mental health or substance use related crisis, who will then be able to support other family members and caregivers in that setting. And just more broadly, you know, peer specialists being able to engage families, I think, is a core part of that work.
Thank you for that. Final question.
Yeah.
And perhaps, well, hopefully not the hardest question. What are you most hopeful for?
You know, I think right now, so many people are suffering in silence and feel like there's nowhere for them to go. It's the hopelessness itself that I'm hopeful will come down, and that as these doors are opened, I mean, like, the pandemic was a big deal for just normalizing mental health struggles, right? Like, we've all been there now together. I think stigma is reducing some, but we have to have the actual infrastructure to be able to respond to that societal shift. And I think that, you know, with these resources, with these programs, with the growing expertise in how to do crisis services well, I think that's creating that resource so that somebody has someone to call or someone who can come see them or somewhere to go. Like, that model is just so compelling because it means somebody can, you know, get the help they need in that moment of hope.
Thank you so much. Dr. Matthew Goldman, everybody.
Thank you all. Appreciate it.
Thank you, Dr. Goldman. I appreciate how you pulled everything together and took us on that, where we can actually see what has been happening, and you made it very easy to follow as well. And I want everyone to know that these slides are going to be available at our website, so you don't have to worry about trying to capture that. They're going to be right there, so thank you for all that hard work as well. And a reminder to our virtual attendees, please exit out of this event and move to the next event in the Hubilo app. So I'm going to remind you out there in cyberspace right now. I would like our next three guests to go ahead and come to the stage for our first presentation, and we're delighted to welcome back some folks who they presented initiatives in previous mental health summits, and we're going to get an update. So are we really making some difference, and what's the impact? That's how long we've been doing this. Who knew? We're going to start with Dr. Anna Ratzliff from the Expanding Washington's Behavioral Health Workforce with Bachelor-level Behavioral Health Support Specialists. Dr. Anna Ratzliff is a professor in the University of Washington Department of Psychiatry and Behavioral Sciences, where she is also the director of the UW Psychiatry Resident Training Program, co-director of the Ames Center, and director of the Behavioral Health Workforce Expansion and Lifelong Learning Program. Dr. Ratzliff is a national expert on collaborative care and specifically on training teams to implement and deliver mental health treatment in primary care settings. And we'll welcome you to the mic. Thank you.
Great. Thank you so much. Very excited to be here and give an update because I think that the project that I'll give an update on was actually presented at the very first mental health summit. So it's pretty exciting to be able to give that update. Okay. So I'm going to talk about our behavioral health workforce initiative that was around this bachelor's level behavioral health support specialist. And I really like to start with reminding all of us why we were interested in this area to begin with. So one of the things that we saw in the workforce is that many people are needing access and wanting access to therapy. And this figure here, actually, it was data that was taken during the pandemic, looking at the kind of a population sample of who needed mental health services, specifically therapy services, and who wasn't able to have access for them. And you can see that that is broadly true across the United States and also true in Washington State. So there's a real need for access to therapy. Unfortunately, when we talk about workforce, if we need more workforce, it can take a long time to have a new provider actually be available online and ready to see people. And there's a big gap between some of our peer workforce and, you know, the next level up for the most part for licensed providers is a master's, which, you know, typically is at least a 6-year pathway for people to be able to get access to care. So we looked around and saw opportunities with an example program from the UK where they really created a level of workforce kind of right below that master's level. People who could deliver service and treatment, therapy services, and we think that because this is only a 4-year degree, that will allow us to more rapidly expand the workforce. We also hope many of those people will go on and get those master's or doctorate level degrees, but at least to start, this would be really helpful. So what would these people do? What would that look like in practice? So I'm going to give you an example. A patient would present with depression or a common mental health disorder. These folks would not have within their scope of practice to diagnose, so a patient would initially need to be seen by either a behavioral health or a medical provider that had that scope of practice, and they could diagnose depression and recognize that that person might need some low-intensity therapy like cognitive behavioral therapy. That person would then meet with that BHSS or bachelor's level folks. This could be in a variety of settings. This could be in primary care. It could even be in community settings. It could be in a community behavioral health setting. And that patient would then receive those low intensity, less, long-term, shorter-term services and actually get regular measurement to make sure that they were actually receiving improvement. Then there would be kind of two pathways. Many patients we think would actually get better with that extra support, and those folks would go on to go back into the community settings. Some people, and one of the reasons why it's important to measure if that's working, might need higher levels of services, longer-term services, maybe more complex therapy approaches, and those folks would be connected then to somebody with that full scope of practice. So in order to do this, to start a whole new workforce, we needed to do kind of 3 things at once, which I think is always a really interesting thing to do. And fortunately, we received funding from the Ballmer Group to actually fund the work that I'm going to describe. And this, we had to build out a curriculum. How do we teach these folks how to do this work? We need educational partners to actually provide basically a year of curriculum embedded within a 4-year degree. And then we needed to make sure we had training for actual skills. We needed to develop the practice for this role, so job descriptions, making sure that there were places that would want to employ these folks, and then also during that training they'd need something called a practicum, which is where they would go out and practice those skills while they were still in school and really learn to be able to deliver them to be effective. And lastly, we needed policy. So we needed to actually make this a licensed provider type so that we can bill for those services, and we'll eventually need to work on billing and payment. So this was a lot of stuff to do, and we're very grateful to receive funding because this is a couple of full-time jobs to do this. And I'm very excited to talk about the updates. So last year, this is a picture of the bill, Senate Bill 5189, that was actually signed into law, and that's Senator Trudeau and Representative Slatter, who's in those pictures, along with Bill O'Connell, who is my partner in this work at University of Washington, and Kevin Criswell, who is actually a partner from EWU. So this has really been a collaborative effort. This is a new type, and we're in the middle of rulemaking, and if you have opinions about that, please go and look at the Department of Health, because we're having weekly meetings about how to actually establish this licensure type. We've also been working very hard on developing what the curriculum will be looking like, developing some educational partners, behavioral health community partners, and of course that work with the rulemaking with the Department of Health and down the road with the Healthcare Authority. These are some of the current partners, so I wanted to give an update. These are the institutions that we'll be working with. The way we really are thinking about this is not a workforce that will only be at one university. What we really wanted to consider is that our work is to catalyze this work. So we are partnering with any four-year degree granting institution, and you can see we have a variety of educational partners that have really committed to us. And these include some of our four-year universities as well as some of our more community colleges. We think that's really important to have access to this pathway for a more diverse group of students than may have been able to consider going into behavioral health before. What they will do is basically offer about a year of curriculum embedded in a four-year degree, like a psychology degree or a social work degree, so it varies. And what we're actually doing is defining what those meta competencies are that those institutions have to be able to provide. So those are listed in the box. So health equity, helping relationships, cultural responsiveness, team-based care and collaboration, screening and assessment, care planning and care coordination, the actual behavioral interventions, and then law, ethics, and professional practice. So really defining what this person needs to be taught to be able to be effective in their role. And finally, we still have a pretty bold vision. We are hoping that we will have 50 providers trained and 40 providers in practice by July 2026. I hope we actually exceed this goal. And in some ways, that legislative piece was a huge piece, and we got a lot of support, and I really, we presented this last year at the summit as well, and I think that was very important to help that. I put people all over the Washington state because that's really my goal, and our goal in this work is that this is a workforce that really can serve all of our state, and I'm really excited about it. If you have questions, we're putting the email address up there. Myself, Bill O'Connell, and Savannah Tidwell, who's actually here in the back. So there she is. If you guys have questions for any of us, we are happy to answer them.
Thank you, Dr. Ratzliff. Wonderful work. Next up is Stefanie Robinson from the Behavioral Health 360 Initiative. Stefanie Robinson is the Chief Operating Officer of the R Prime Foundation. That is an organization that brings communities together to solve challenges. She has more than 15 years of operational and strategic expertise across a variety of industries, with her greatest experience being in the life sciences. She was the Chief Production Officer at Seattle Children's Research Institute, where she was responsible for strategy, business analytics, and research IT. Welcome to.
Hi, I'm Stefanie. I'm the COO at our Prime Foundation, where we leverage cutting-edge technology and apply it to civic purpose in the hopes of driving in-community change. BH360, or Behavioral Health 360, is the second iteration of our 360 platform. We have a 360 platform active with UW Autism Center that was developed in partnership with Seattle Children's and UW that helps families navigate clinically and culturally relevant resources for navigating their autism diagnosis with their kiddo. Behavioral Health 360 is applying that same methodology to behavioral health needs across Washington state in partnership with a variety of organizations that are present here today that I'll mention throughout the presentation. It is not lost on anyone in this room that we are in a youth behavioral health crisis. The pandemic has only exacerbated the challenges that our youth and teens face, and we've seen an increase in depression, anxiety, and suicidal ideation. Many will tell you that we still have not yet fully realized the impacts of our youth from the pandemic itself, and so this will continue to unfold as time continues on. Historically marginalized and economically impoverished communities are typically those that have heightened need for some of these services and can be the furthest from reach. And so part of our goal with BH360 is to really work with these communities first and foremost to develop the platform to service their needs in the hopes that then it will service all. There's limited access to providers. We've heard that a lot today. There's an enormous provider shortage, and this is not a switch that can be flipped on. This will take an enormous amount of time to get us to a state where we can actually service the amount of demand that we have in the state. And in my opinion, I don't know that we'll ever be able to service the growing demand with the number of providers needed. And so we need other resources and other tools that can help families navigate their care pathway. And lastly, as a parent, I'm one myself, parenting is incredibly overwhelming. And when you start to layer on complex needs for your child, if you go online and you Google behavioral health resources, Washington State, you'll get 2.38 billion responses. So as a parent who's already in a state of paralysis, how do I understand what would be most beneficial to my family given our circumstances? This slide shows a little bit what that experience can feel like. And typically at this point in the presentation, I have someone come up and share their lived experience and their story to help underscore what that experience is. However, I'm going to take this opportunity today to amplify some of the voices that we've heard from over the last 15 plus months in a variety of meetings. So we've had meetings monthly for the Parent Portal meeting, which is open to anyone who wants to attend, just a little plug. And we also participate in many of the Washington State initiatives. So at a recent Child and Youth Behavioral Health Work Group Strategic Planning meeting, that is a mouthful, there was a question posed to the group, which was, what gaps do we have in our system? Some of the responses were, the system is not only about the treatment and services for children, but all the supports needed for families. Our silos in care create large gaping holes for any transition point in care, and families inevitably fall through the cracks. The gaps in services are also enormous, but so is the education and stigma reduction that's required to help normalize access to supports at large. And some of this can be summarized in a quote that I gathered from one of the parents who is an advocate in our BH360 work and is actually part of the impetus behind why we are where we are today. And she relayed, if I had had connection to other parents with similar experiences, guidance of helpful, evidence-based resources and tools, and a resource map to what was available to me, we would have potentially saved our family from police intervention, multiple hospital visits, and post-traumatic stress for multiple members of our family. And so we've built the vision for BH360 using a lot of that information that we've heard from families over the last several months. I may have mentioned we're still in a prototype state for this, but this encompasses what the full platform will look like when it's developed. This looks linear. Anyone who has been through the process of navigating behavioral health supports for your child knows that that process is not linear at all. And so we're intentionally building the platform so that families can have multiple entry points. So whether you're at the awareness phase and you're just starting to recognize that there might be some challenges that you want to get some support for your child, you might come in early on, or you might come in later when you need to understand what your legal rights are as a guardian so that you can help advocate for your child in the most appropriate way. The idea is when you come in through the awareness phase, our platform follows a 3-step process. You'll answer a series of screening questions, and based how you answer those questions, we then personalize the information that we provide back to you. And that's geographically sensitive as well. So we'll provide back to you some psychoeducational content across a few different potential diagnoses, because we're not a diagnostic source of truth. But you can start to read into those diagnoses, understand common signs and symptoms, contributing factors, and what are some evidence-based interventions that you as a parent or caregiver might be able to start taking with your child while you're waiting to find the right provider. Once you get into that intervention phase and you're going to start looking for a provider, we have a provider list that will be encompassing both public and private providers across the state that you can then filter. So you can filter to understand if they accept patients without insurance, which is also very important for many families in a lot of these communities, what ages they support, what areas of specialty they might have. But finding the provider is only half the battle, if even that. You have to find a provider that's the right fit for your family. And so we help provide caregivers with some tools to do that by way of some provider fit questions. What are some questions you might want to ask that provider to assess if they're going to be able to help you and your family? All of this is tailored to be really culturally relevant, and so the intent is to work really deeply with those families and those communities to understand what is the right kind of language to use that feels comfortable and familiar so that we're not overwhelming, and again, we're trying to reduce that stigma. As you get into the community engagement phase, again, you'll have the ability to understand your legal rights and advocacy rights. We'll provide some school-based resources, as well as some local health resources, because in many of these communities, mental health is only a component of what's happening in the household. There might be some other services that could be needed. So we'll be asking some questions on social determinants of health so that if there's food scarcity, we can also connect them in with food banks. If they're a refugee that's new to the area, we can connect them with some refugee community support groups. And then lastly, as we get into that ongoing support phase, it's about how do we really learn from our users over time, right? So as we have people engaging in the site, we can learn what's effective for those families, and then we can start to tailor more acutely how we provide the best fit to users as they come in. And what's more important as well is that we're trying to really help the state move from a reactive state to youth behavioral health supports to a proactive state. So can we start to de-anonymize a lot of the data that's happening in our system, look at it in a macro view and say, are there pockets of certain age groups that are really struggling? Are there certain communities that are really struggling? And how do we stand up programs to help address those needs? This shows you just a little bit more tangibly what you can expect on the site. I spoke to this a little bit on the last slide, but I wanted to highlight here that a lot of the resources that we provide are not only caregiver focused, but we'll also have youth focused resources and information. And the idea there is if you are a teen, for an example, of a certain age and you can go on and navigate this yourself, it reduces some of that stigma of having to raise it to your family or to your friends. And so you can start to go on and understand, okay, some of these signs and symptoms seem very similar to what I'm experiencing. Perhaps I should seek some help. This map showcases how we're thinking about our partnership model. BH360 at its best is an ecosystem map of what's happening across Washington state. There are some really wonderful resources that are available to families, and families don't always know how to find them. So we're really trying to connect those resources to those families in need. And the example that you see on here is for Kent on the right-hand side. And then you see many of the organizations on the left-hand side are more statewide resources that can both be an entry point into our site. So as an example, if a student comes in or if a parent comes in because the student's guidance counselor indicated that they might want to check out BH360, there's some disruptive behavior in the classroom, that parent can go on the site and then get connection in with all these other organizations. We too are building a bridge. I heard that term earlier today. So we're working very closely with Washington State on this initiative. Washington State has provided us some funding to continue the development of the site. It's not the full funding that we need to bring BH360 to fruition, so we've been having many conversations with some private donors and some philanthropists in the area to help partner some private dollars to help support the full development, with the aim of having this be operationally supported long-term by Washington State so that we can continue to provide this meaningful service to families. I just want to finish with a really quick shout out to the amazing team that I work with. There are some really wonderful people on here who work for great organizations that are also providing services to youth in Washington State, including Washington State Community Connectors, PAVE, Healthy Minds, Healthy Futures. And then I also have two key partners on this initiative, Priya McLennan, who's a licensed clinical psychologist and a clinical innovation consultant who's really helping the strategic direction and content for the site, and Jackie St. Louis, who's a licensed therapist and equity and social justice leader in this community, who's helping us to really prioritize those in those underserved populations first and foremost. So thank you all. Please feel free to reach out. I think that my email will be available. So thank you.
Oh, I think I have to go one more. Next, we'll have Todd Crooks come up, and he's going to be talking about mainstreaming mental health advanced directives. Welcome, Todd.
Hello again. We presented this at the last event, and essentially the Mental Health Advanced Directive work was about creating a self-determination of care where we don't really have any right now in the midst of a crisis moment. If you can imagine being completely disabled in a crisis and having to explain in that moment what your preferences are, what your needs are, it doesn't work that way. So the Mental Health Advanced Directive is designed to, in the moment of stabilization, create those preferences on a document and have those preferences available to providers, first responders, and anybody in that path. That's been law since 2003. But what we presented on was the fact that the heavy lifting that was necessary to bring everything together so that it was a well-utilized tool wasn't done. As well-meaning as the legislation was, there was a lot yet to be done. So 20 years have gone by, and we have a good working document, but we don't have a good working system. So what we talked about was that because of that, providers are hesitant to use it for a number of reasons, including the conflict between what an individual says they want in that moment, in that examination room or wherever they may be, or on the street with a first responder, versus what the Mental Health Advanced Directive actually says. So you have a conflict there. It's very difficult to find a Mental Health Advanced Directive right now, unless that 8-page document is folded up in the individual's back pocket. So there needs to be better access to the document. There were basically 4 key ingredients to making this work going forward. And the first was that we needed to create a list of best practices, some recommendations for not only when you bring this up to somebody who may benefit from a Mental Health Advanced Directive, but who brings it up and what measures go into actually filling out the document. The other aspect was that there are a lot of questions and concerns for providers with regard to using the document, most of which can be answered in a training. And so the second component was to create a training resource targeted to each community that might be the audience for that training, whether it was a peer group that was studying to become agents for individuals to help create the document, or a provider that's going to be executing that document in a moment of crisis, to first responders and everything in between that might come into play. And then we need to talk about where that document is. It's great to have fabulous training. It's great to have recommendations on how it all unfolds, but it also needs to be accessible. So we're talking about a repository. We're talking about perhaps electronic medical records or leveraging the 988 system. I'll go more into that in detail in a moment. But then the fourth issue is, of course, we'll have legislative asks to do that. And we had legislative asks to get these things started. So the vision of the Mental Health Advanced Directive is to build a system where it is a widely used and accepted tool that injects self-determination into a situation where there is none now, which leads to a shortened distance between the onset of crisis to a positive outcome of a recovery. And we'll talk about that too. I'm not just throwing that out there. After the last summit, we undertook several different projects. One was we started developing a collaboration with the state of California and those that were working on a system. They call them psychiatric advance directives there, but they were working on a system to build some pilots for that state and figure out how they were going to do a repository and what their best practices were and all those other items. And so we in our work group meetings oftentimes had a representative from California in our meetings, and we learned a lot from that because they were just a little bit ahead, given that the fact that they had a lot of money to work with. So the next thing that we did was we started quickly building a legislative ask for the 2023 session. And essentially what the goal was is to take our learnings to date from the beginning or the end of last year and roll it into a legislative work group for the HCA to take what we had and carry it closer to the finish line. The finish line initially being perhaps some pilots here in Washington State, like the 7 pilots that are about to roll out in California. Senate Bill 5660 was created to do that. Unfortunately, not everything that's a great idea in Olympia, as you know, passes in Olympia. And it missed some things in Ways and Means and didn't happen. What we were capable of doing, though, and what we were asked to do was to continue carrying the ball this year, moving it forward so that we could create a new ask for 2024. This issue is far too important to just let it sit and ask for the same thing next year. So we went to work and we did a few extra things that normally perhaps the HCA would have done at this stage. And we're very, very fortunate. You've heard the name Elizabeth Perry at Principal Allies as one of our organizers here. I keep hitting this. She was instrumental in co-leading with me and created an environmental scan to see what was out there, not just in the state, but even beyond. Because what you don't want to do is you don't want to duplicate work that somebody else is doing. That's the whole point of the summit, is to collaborate and work together to find the shortest distance to where you're wanting to go. So this environmental scan pulled out a lot of information and tools that we can reference as we move forward and guide us. We also threw out a survey that I think the survey went out to 200 specific stakeholders, but then was also made available to a lot more other stakeholders in the community should they find that the Mental Health Advance Directive was applicable to them. And we collected a good number of responses on what the reality on the ground is right now, because the reality we wanted to make sure was either the same or we knew what was different from when we started this 2 years ago. So the survey was very important. And then we went to work on figuring out what that repository might look like. And in talking to California, they looked at various different aspects, and they determined that 988 was a good resource, but they wanted to build their own application that would be available for first responders all the way through the provider realm. And so they've created an app that they're working to roll out to the counties. We looked at what they were doing, and we have kind of we're ready to sort of recommend that we don't really want providers to have to do a whole nother management of records when we're dealing with the Mental Health Advanced Directive. We don't want to make them duplicate their work by putting things on an app, by putting things on Epic or Cerner. We want them to work with what they're working with. And we think that it might work better in Washington State to have them put it into an EMR like Epic and have that bridge to the 988 system. So that's kind of what our recommendation is, but we're fine-tuning that because we haven't made our official ask. And I know that our friends at the HCA can't tell us that's what they want to do, but we're going to ask what's possible, and then we're going to move forward and have the legislature work with us on that. So forming an ask of what's possible. Discussions are underway. We're looking to create an ask now that is much more developed than the ask that we did for the 2023 session. The 2023 session was, let's just make this an HCA work group. Now, we really have a pretty good idea as to where we stand on what the recommendations are. We have looked at all the different models in the country. We're aware of a fabulous study that was even done in France. We know that even so, Washington State is still one of the leaders in this work. Texas has a couple of really good pockets that have developed some great things around peer counselors being part of this system. California has a robust plan to build these pilots, but then there's Washington State with this work that's been happening, and I think that we're going to be at the forefront. And between us and our friends in California, we're looking to try to create something for the West Coast, while ours might be a little different, can kind of learn from each other and create a system for the whole West Coast that might introduce self-determination for everybody on an opt-in basis. We're expecting, because of this, to grow in our work group. Right now, we are a work group of about 80 contacts. We have been the Washington State Hospital Association has been generous in providing their training toolkits that we're working on adapting for the rest of the communities, but we need program developers to join us once the legislative ask is complete in 2024 to create those new aspects. So if you'd like to get involved, your contact information is there. You can get a hold of me with the Hubilo app. And I'll leave it at that. Hopefully we have some time for questions.
Thank you for these important and great updates, quite frankly. We do have time for some questions, and we're going to go through our Hubilo app. And I think Melody and Cheryl are going to, they've been calling questions if you've put some in there, and they are going to ask some questions of the panel.
Okay, first question, this is for Stefanie, I would say. How can this resource be brought to youth and young adults experiencing homelessness? Is there plans for connecting with community-based providers to facilitate use of the site?
That's a great question. I don't know if this is on. Okay, there we go. That's an excellent question. We do want to work with community-based health centers as part of an entry point to the site as well. We also intend to have the site be available in a lot of different domains, right? So you can have it on a phone, on a tablet, on a web-based platform that you can access, including if you need to go to the library to look things up. And so the intent is really to try and democratize access so that we can get to those communities that we really hope to have impact in.
In addition to the questions on Hubilo, I believe the people who are here in person are welcome to ask questions. So feel free to line up. Feel free to line up at the microphone if anyone has a question who's here.
I think we're going to take Hubilo questions right now, and then we'll do the lineup a little bit later.
Beautiful. Okay, so Dr. Ratzliff, there's a question. How would someone with a BA degree become a health support specialist?
Yeah, that's a great question. So what I described was probably more than people who are currently enrolled in programs, but we are anticipating that there will also be basically like a post-bac program that would be a year-long program that would, you'd need to do an assessment of what you had met in terms of some of the prerequisites in whatever degree you already had, and then if you needed to take additional courses, you could do that. That would really be the educational institution that would be offering that one-year program sort of after your baccalaureate degree. They would help you determine what courses you need to take. Then they would be able to still take that year of coursework and do that practicum. So we have some programs that are interested in thinking about already developing that as a one-year sort of post-baccalaureate program as well. So we hope that this, you know, one of the interesting things is as we have put this out there, I've had a lot of people who maybe are thinking about a second career or later in their sort of lifetime of career opportunities and saying, gosh, I'd really like to become someone who can be part of that helping profession. I haven't had the opportunity to do that before, and this seems like a pathway that seems more accessible than that longer pathway of like a master's degree or something like that. So I'm excited that that might be a really important part of the workforce that we can grow as well.
Stefanie, I'm sorry, Dr. Ratzliff, I'm wondering if you can tell me, are you seeing students interested in doing this?
Yeah, so Eastern Washington University is probably a little bit ahead of some other people, and they already have students that are pursuing this right now. So we are seeing a lot of interest in it. I think what we're really, excited about, and one of the things that we're doing is trying to build out basically like a library of curricular resources to really help those educational institutions be able to offer this quickly without having to do all that development themselves. So we're pretty excited that the other institutions, part of the reasons why we needed those competencies out is so that they can start to request to add this to their curriculum, and we're anticipating that by next fall, this program will be offered in all of those institutions that I listed on the slide.
Melody, do you have a question?
Yes, this is for Dr. Ratzliff. How is the BHSS different from the current agency-affiliated counselor license for bachelor's level folks?
Yeah, I think that's a great question. So I think they have a lot of overlap, actually. So agency-affiliated counselors, for those that don't know, are folks that often have a bachelor's level degree who are working at our community behavioral health agencies. They have to have direct supervision, much like the behavioral health support specialist requires as well. We really see this as giving additional training, some additional training in specific skills that sometimes, that usually is for agency-affiliated counselors something they get on the job. So this would be preparing people a bit before they went into that workplace. And then also that this would be able to be available in non-community behavioral health settings. So especially settings like primary care, primary medical settings, because that's often the place where people are also accessing care. So really trying to open up the doors that people could go to and actually access service. So a lot of overlap. Some of the BHSS might go on and serve actually as agency-affiliated counselors or, in community mental health settings, we hope, as well as maybe in a broader range of community settings.
Cheryl?
BH360 is wonderful. Where is the help for all the parents/families with adult children with SMI, many who live with us? We are not trusted to give and receive information during crises.
It is part of our plan to extend the ages that we support with BH360. The first iteration of BH360 would be focused on youth roughly age 5 to 18 or so in those early years. And then the idea is that we would create some supports for both younger groups and older groups to make sure that we have a wide range and can help support through those transition phases, especially into adulthood, because we recognize that that's another gap in our systems where people can fall through the cracks.
Todd, I'll get you involved in this conversation. I'm curious, when we're talking about legislative needs, what are some tips that we can do to help support you in that? Because I feel like if we want to get these bills passed, that there's some support that really people here right now can do, like contacting their legislators, now, or should we wait until the legislative session starts in January? Any tips on that end?
Yeah, I would say that if we were to connect on the Hubilo app, or you email myself at simply toddcrooks@comcast.net, we can get you on our distribution list. And when it's time for testimony, or it's time to do any networking within the legislature, if you're in there, we can kind of get you going then. There's not a lot in that respect to do right now, but we will need some experts as we go forward after the session. Hopefully the session will be successful.
And it looks like we're hitting our break time. So we'll let everybody take a break. We'd love to have you back in your seats at 10:45. But thank everybody for this, for the panel. Oh, and go to the exhibit halls. Exhibit halls if you want to take some time there as well. Both sides.
Kind of like student data, sharing and discussing my work experience. To one sessions with
At this time, I'd like to invite our next panelists to the stage. Thank you. Wow, ask and you shall receive. Thank you. Shall we get started, everyone? If you can please find a seat, we will return to our program. I'll give you a few minutes to wrap up conversation and get back to your seat for our next discussion. Thank you. Just a reminder that folks who are joining us virtually, be sure and exit this one and go to the next event. It's very important that you have switch out so you're in the right room. You can also submit those questions. Please do. We appreciated those questions that you gave us. Keep them coming. We're also at this time going to be able to invite people to the mics when the Q&A starts. So if you do have a question in the real world, you can actually come to the mic and really ask. So there we go. We're going to do our best to get to all the questions. Don't forget that Hubilo. Okay, our first initiative today is Mental and Somatic Health Services for Veterans, presented by Amy L. Almond-Schmid and Catherine N. Gaffigan. And they're on stage with me now. Amy is the Executive Director of the Returning Veterans Project. Amy's career has been dedicated to serving the needs of military personnel and their families. She is a passionate advocate for integration and referral of resources and services concerning the well-being of veterans, service members, and their loved ones. Dr. Catherine Gaffigan is an Army veteran, thank you, and is the board secretary of the Returning Veterans Project. Dr. Gaffigan is grateful to be able to give back to those who have served our country during times of war, whether they are service members, veterans, or their families. It's incumbent upon us all as citizens to serve those who have served our nation and ensure they get access to the confidential care they need and deserve. So with that, the panel begins. And you know how this works? Thank you.
Sure, I can figure it out. Thank you so much. All right. Hi, I'm Catherine, and I'm going to kick us off, and then Amy, who is our executive director, is going to take you through most of the discussion. So we are the Returning Veterans Project. Our mission is to provide free, confidential mental and physical health services to post 9/11 veterans, service members, and their families. And we do that in Oregon and Southwest Washington today. We've been in existence for about 18 years now. Our founder was a licensed clinical social worker named Carol Levine. And Carol, she would say that she comes from the Vietnam generation. And when she saw our service members, Oregon National Guard specifically, coming back from Afghanistan, her comment was, "Never again." And so she got a bunch of her LCSW friends in a room and convinced them to all donate an hour of their time to support a returning veteran, service member, or family member. And that's why we are here today. That was 18 years ago. It has so far been focused in Oregon and Southwest Washington. As many of you know, the Vancouver area is kind of a Portland metro suburb, and so we've been focused on the Oregon area and then Southwest Washington for the last 18 years. I feel privileged to be a board member for this organization. I have been now for about 8 years. I'm a veteran myself, but pre-9/11. My brother is a post-9/11 veteran. And I think one of the important things we'll talk about here in a second is that whether you're a veteran, a service member, or a family member, there are many cracks in the system, holes in the system, right? It may be that the veteran can actually access the VA, maybe, but the family can't. One of our top referrals is actually VA for family counseling. So it doesn't exist within the VA system, at least not in the Oregon area. And so, for us, we are filling a gap that we think is really important, both on the mental health side as well as on the somatic side. We probably won't focus on that as much today, but we have a lot of chiropractors, acupuncturists, massage therapists who also support this effort because, again, those are services that folks can't get from the VA and or maybe they're a family member and not, they don't have the same coverage. So that's why we're here, and we're excited to tell you a little bit about our story and the impact. And we're going to start that by actually having a video run of one of our clients. I want to just emphasize one of the most important things about this is it is confidential and free. So we don't know who our clients are unless they tell us. The only way that we actually know that we are serving them is because our providers fill out a form every year and tell us tell us how many hours they are providing and to how many clients. But it is truly and utterly confidential and free. And so we're grateful for those clients who do choose to tell their story because it takes a lot of courage, but they're our best ambassadors. So with that, we'll go ahead and play the video. Thank you.
If I kept going down the path that I was going down, if I did not seek help, seek treatment, I don't know where I would be. When I got out of the military, I had no support. As sad as it sounds, no friends, no family members.
Veterans returning without support can often suffer in their relationships, can feel isolated. Often for many veterans, their injuries are invisible and not necessarily something that people understand.
When I was in the Navy, they tell you where to be, what to do, but then when you get out, nobody tells you anything. It's the exact opposite. In the civilian world, you have to kind of create your own mission, and if you don't do that, without a vision, people will perish. Well, when I first moved to Portland, I thought it was going to be, full of adventure, basically. It seemed like a really good, fun place to kind of start fresh, you know what I mean? My life looked pretty good. At least I thought I was kind of handling the transition from military life to civilian life. When the pandemic began, it basically removed what little social interaction I did have, which is something I felt like I was just starting to rebuild, a sense of community.
Many veterans, when they're not able to access support, experience more isolation.
When I was at my lowest, I would say that life felt pretty much meaningless. What's the point of getting up out of bed in the morning if there's nothing to reach for, nothing to work for, nothing to strive for? I still got up, did what I had to do, checked all the boxes, but I did not feel fulfilled on the inside. And I did that for a very long time,
Some of the challenges veterans face getting the services they need might be long wait times, accessibility. For many people, the cost of care is prohibitive.
So I would say I knew I needed to reach out and get help. There's no way I could afford it by myself.
What I love about RVP is it's a way for veterans to be able to access their own care with autonomy.
I searched for a provider that met my schedule and that was open and accepting clients, and then from there I reached out personally. The first session itself was very, very challenging. I was still very closed up. I did not know how to act in that situation. After I did meet with Sarah for the first time, I felt relieved. I felt like there was kind of a light at the end of the tunnel.
In an ideal world, veterans returning home would be welcomed with services and support and community to help them bridge that transition.
That's what's good about the Return of Veterans Project is they do have the resources and the tools to help you get back on track. I feel a little bit easier. It has helped me reestablish a sense of clarity and purpose and meaning in my life.
Donating to RVP gives returning veterans an opportunity to connect and feel seen and take care of their own needs for health and support. I really see the Returning Veterans Project offering hope.
You never know what you could accomplish or do in your life. You never know how many lives you could impact if you just live another day.
Hello, friends of the mental health community. It's so nice to be here. I am Amy Almond-Schmid, the Executive Director, and Come November, I will be celebrating my 24th year in service. So I'm an active duty veteran, a reserve veteran, I'm a wartime veteran, and now I'm here as an executive director of a nonprofit. I feel very Hair Club for Men, and I'm not only the president, I'm also a client. So thank you. I feel like I'm speaking not only on behalf of myself and my family, but my extended family of service members, my brothers and sisters in arms, and I am so grateful for this opportunity. I'll be honest, when we learned about this initiative, we thought we could come and speak about our model and tell you about what we were doing in Oregon. I really didn't understand the breadth of what this community could do and the reach. So again, really, really excited to be here and share what we're doing. All right, overview of the problem. As the video and Catherine explained, the need is great. Over half of post 9/11 veterans are not enrolled in the VA. Maybe because they don't want to be, or maybe because they were kicked out during Don't Ask, Don't Tell, and they've not gone to get that designated on their DD Form 214. For some, the paperwork that is required to get into the VA healthcare system is just too much for them, and so they're without the care that they need. Barriers to care. I've heard it here already today. The barriers to care for veterans are great. Fear, stigma, wait times, government programs that present that stack of paperwork, prevent people from seeking care. Additionally, much of our service area in Oregon is rural, so getting to a location that they may receive care is difficult. In our state, you may or may not know, Oregon is without an active duty military installation. Large military organizations shed light on mental health needs of veterans that are in their area. A lot of people retire and move near bases because of the community that it offers. However, in Oregon, we don't have that, and so a lot of times we're having to create the program from scratch, grassroots, which is exactly what RVP did. The VA does not provide many services like Catherine had mentioned, and again, because our state is without a military installation, many of our providers lack an understanding of what service means. We talked about our founder, Carol, and when she sat in an initial meeting with someone who had just returned from Afghanistan, they went on a long rant of what they had just experienced. And when I met Carol, she said, Amy, I didn't know half of the things that they were saying to me. It was a foreign language. And for her, that instigated, I need to educate my peers so that as these veterans walk through the door, they are better able to care for them in whatever their unique needs are. Our solution, so how are we doing this work? We're offering free, as Catherine mentioned, confidential services, both mental health and somatic care. And here's how we do that. We're recruiting. Forever and a day, we're recruiting. We're looking for those who are licensed and insured in the state, and they're willing to give of their time. Then we educate them, so we onboard them, and we offer free continuing education credit throughout the year. Our goal is to offer at least one training each month, but this year we've offered, I think we're at 18 or 23 with our providers that have said, we want to do this work with you, and are offering education that's specific to caring for veterans. We then list these providers in a directory online. And as you saw in Ben's video, the service member gets online and goes through a directory and finds the provider that meets their needs. We, RVP staff, stay out of the HIPAA business, and we allow the service member to make those connections with the provider who has said, I'll take RVP clients. So they're self-referring, and when they make those calls, they say, I found you on RVP, or I'm an RVP referral, and that automatically bumps that service member to the top of that provider's wait list. All of our services, like Catherine mentioned, are pro bono and confidential. What we're doing as staff is keeping tabs or tallies of how many veterans, family members, and currently serving members of mostly the Oregon Air National Guard, Oregon Army Guard, and we have a small recruiting population in the state of Oregon, and then the Coast Guard. They are our active duty component in the state. We're keeping tabs on how many service members, how many family members, and their status, if they're willing to share with the provider, in-house. what we've done so far. Since 2005, we've served over 3,700 post 9/11 veterans, service members, and their families. In 22 alone, we had 2,470 hours donated by health services volunteers. That was 269 veterans, 3 active duty service members, and 35 family members. To continue doing this work in Oregon and Southwest Washington and potentially beyond, we need volunteer providers. We cultivate our provider network. We offer training, refresh and grow our provider network, providing ongoing and relevant continuing education. And outreach. It takes a lot to tell a service member that we exist. That's finding them, going to where they're at, in the VFW, at the VA, at events where veterans are gathered. For those who are still serving, meeting them at yellow ribbon events. Again, in the Guard and Reserve community, those who are on deployment cycles, who go put on a uniform and are gone 6 months to a year and a half, and then come back and go to a civilian job and forget all about their benefits, resources, entitlements as a service member. How do we find them? It takes a lot of travel, a lot of boots on ground. Our vision: an improved quality of life for post 9/11 veterans, service members, and military families. We believe, as it was read in our introduction, it is our collective responsibility to offer support, healing, and access to mental and physical health services for our veterans and military communities. We believe veteran service members and families have the right to mental and physical health services without stigma and judgment. Confidential services are from the provider that they choose, and that it's easy and timely to access. How can you help us? How can you get involved? There are so many ways. First, tell your friends about us. Are you a subject matter expert? Do you have the ability to teach something that would impact providers that might want to volunteer with us? Do you have a room or a space that we could use to bring people together and teach them about this community? Are you a provider? Are you a university? Are you a clinic? We have memorandums of agreements with several of the universities in the state of Oregon. For example, University of Western States is a large chiropractic school in Portland. They created a clinic, and they now offer services free to veterans of all eras. They've expanded their service to veterans because of our relationship with them. So at any point in time, someone can walk in and say, I'm an RVP client, and get free services in the chiropractic school. Now, we do allow for students under supervision to participate in the volunteer program, and all of their hours are routed through the supervision or the school under that MOU. Become a charitable partner, donor, contributor. We are actively serving Clark and Cowlitz County in the state of Washington. And with my board here representing, we're open to new ideas and expansion. We are in a strategic planning year and trying to decide where we'd like to go next in 3 to 5 years. What does RVP look like here along the West Coast? Peruse our webpage. Social media these days is everything. If people don't know about you and they don't know how to find your service, if you cannot be amplified, then the veterans aren't coming in, the providers aren't coming in. We are actively engaged on our webpage, Facebook, Instagram, and LinkedIn. And finally, encourage use of service. If you've got any veterans in your life, even veterans outside of our eligibility criteria, we rely on older veterans to tell younger veterans, here's a service that's available to you, and vice versa. The networking of the military community lasts a lifetime. If you could be a part of that and help us share who we are and what we do, we would be greatly appreciative. Pending your questions, that's all I have for you.
Invite people to the mics, and it looks like they're coming up. We don't have any on Hubilo yet, but I bet they'll be coming. I'll start with this question. Is there a common theme that you're seeing with veterans, especially now in 2023? Or obviously it's private, but I'm just wondering if there's a real need in a certain specific area, because it's so unique to veterans.
I can speak from personal experience. Military families are the greatest request for services. right? So especially in the Guard and Reserve community, when you've got a service member who has a civilian job and then they get called up to go do a thing, they're having to prepare their mind and body to go do this other job in a wartime environment, in a COVID environment. In the state of Oregon, we went and worked in all the hospitals. So here's another new thing. You're deployed, you're technically deployed, but you're still in your home state, or you're still actively working, and you're doing this job and then having to go home and still manage all your home responsibilities. Well, anything that would affect a regular human is also going to affect a military person. However, you add that extra layer of the responsibility of their military job, their military service. For a lot of people who watched Afghanistan and the rise and fall of what we did in Afghanistan, my friends who have been in service at the 20-year mark went, what am I doing? What was the 20 years of my life for? So not only are they looking for mental health care for themselves, but really truly mental health care for how do I continue to manage my family?
Okay, this is from Hubilo. How could this service be brought to veterans experiencing homelessness? Outreach has been mentioned. Would there be teams set up to reach that population?
Yeah, great question. Again, from the 18 years that we've been in business, we are a hub. So because we have such a very specific focus on mental health, we work with all the other nonprofits in our area who are doing other work. So if you're talking education, you're talking homelessness, you're talking food sustenance support, if you're talking insecurity in any form or fashion, we're connecting those veterans to the other 501c3s, the other nonprofits in our area. And we would like to continue to do that as we grow or expand, is pointing them to the subject matter experts in whatever area they're looking to seek services.
We have a new one in Hubilo. Are there plans for intentionally moving further into Washington?
This is a great question. Catherine, as a board member, would you like to talk about that?
Yeah, it's a great question. I lived in Portland for 5 years, and I moved up here to Seattle 2.5 years ago. And one of the things that in general, I'm not grateful for COVID, but one of the things that makes me grateful for some of the things that we learned during COVID is that I've been able to continue to serve RVP because we went pretty virtual, right? It's also, by the way, allowed us to serve from a telemedicine perspective in ways that we just didn't really conceptualize in, say, 2019. So to your question about expansion, I would say we'd love to. That's one of the reasons we're here. It has been a topic for the board for years now. We've stayed very focused and true to our original mission of only behavioral health and somatic physical services in Oregon and Southwest Washington because we wanted to make sure we first do no harm to that particular mission. We really started to look at whether or not there was an expansion model either to Washington or the other thing we've thought about is, do we expand to veterans and families beyond 9/11, post 9/11? And we just didn't feel like we had the financial wherewithal, frankly, to expand that mission. So now that we're coming out of the pandemic, we are in a very strong financial position. As Amy indicated, she's been here with us now just for under a year, so we're kind of in a good spot from kind of a leadership perspective, and we are starting to look at whether or not it's possible for us to expand. We've joked about kind of, is there an RVP in a box type of situation where you almost franchise it, right? Or does the team that's right now based in Oregon and Southwest Washington somehow expand? It would take obviously a huge effort with respect to the provider community, which we have right now, much deeper contact with and experience with in Oregon and Southwest Washington. So I think that would be like the number one thing is just figuring that piece out. But it is definitely on our list. And as Amy kind of indicated, we're in the strategic planning process right now. And I think there's a few of us on the board that are, kind of wondering, like maybe we even, it's going to just depend a little bit on where we are from a financial perspective. But I think all of us, would like to, would love to expand, and Washington would be the most obvious for us. So, did I miss anything?
No.
Okay. We have one more. It just disappeared.
It's an exciting.
Okay. I work with people who are experiencing homelessness in King County, many of whom are veterans. Is it possible to refer these clients to RVP virtually?
Really great question. So our health network manager and I have this conversation all the time. Because of telehealth opens up the opportunity to see people all over the state of Washington. Even though our charter is for Southwest Washington, we don't see the barrier to recommending someone reach out to RVP and seeing a provider that is physically located in Southwest Washington if the client lives somewhere else in the state. Part of why we're here is to hopefully grow providers in our network so that we can do more of that.
Sorry, the podium's in a bad spot. Right? So my question is actually connected to that, and that is, so you're also looking for providers to do some of this work. Are there minimums that providers have to sign up for, or what exactly is that, so that we actually can get more providers to sign up to volunteer and do pro bono work around this?
So as individuals, if you are licensed and registered in the state, you can join our provider network. For those who are students, if you are practicing in a clinic under supervision, the clinic can join RVP under an MOU and practice with us that way. We recognize any licensure or insurance that the state recognizes. So we're talking your traditional mental health therapies and some of your non-traditional, like equine therapy and float therapy, things like that.
And are there minimum hours?
Oh, no. So we ask that you keep one client on at all times, and we build a provider directory, and the provider directory is the provider's, it's their, what am I trying to say? Profile. Thank you, Jen. It's their profile to manage. So if you can no longer care, or you've gotten really busy with your own private practice, you can take yourself out of the directory temporarily and then turn yourself back on when you're ready to take on another client. We ask for one at any given time, but you can take on as many as you'd like. We do, just to add to that, we see a lot of people coming out of school who have availability in their clientele roster, and then people heading into retirement that also have that availability to volunteer. So people in that middle phase of providing will sometimes step back for a while. Thank you for the question.
Hi, I want to thank you, appreciate the program. My question is, and I guess more of a comment, is when you were talking about looking at different places in Washington, definitely needed, but thinking about how we can bring our peer support network in supporting our veterans, and thinking about our millennials that are coming out, right, and the services that they may not want to be directly connected to the services at the military, but really how can they connect with services that may be already existing. So having veterans and peers at some of those community-based organizations and peer-led programs would be beneficial and helpful. So if that's a place where partnerships can happen, I think that would be beneficial too.
Thank you. I agree wholeheartedly. Since I came on board a year ago, that has been my #1 goal, is to connect with anybody and everybody doing mental health work for veterans, or any work for veterans. I want to know them. I want them to know me. I want them to know RVP, so that we can connect in that way and ensure that if I'm not the right fit for you as a veteran, I know the other organization to point you towards.
Thank you. Thank you so much. We really appreciate that presentation. That was such a great video. Thank you. I loved it. And so now I'm going to have Mollie come up, our next person. I would also like to remind you, your call to action survey in the Hubilo app. It's going to be a red tab. Just click it on and you can start filling out these surveys, and we can start getting that data and information. So Mollie Forrester is the Director of Patient and Family Experience at the University of Washington, Department of Psychiatry and Behavioral Sciences, and directs mental health navigation and access programs for patients, families, and providers from across Washington. Mollie is a licensed clinical social worker with more than 20 years of experience in healthcare and housing settings, and she was an instructor at the UW School of Social Work. Welcome.
Good morning, everyone. I'm really excited to be here and honored to be here. It's been, the last time I was here was 2019, and so it's just really nice to be back in space with everyone. So let's see. All right. So I'm here to present on building a family and caregiver academy. And as Bert said, I am a clinical social worker. My name is Mollie Forrester, and I am based right now out of the University of Washington Department of Psychiatry. Before I get started today, I just wanted to review some of the language that I'm going to use. You will hear me refer to people living with mental health conditions as patients, and part of that is just so that I can get through the time I have allotted, but also because some of the practice setting or the primary practice setting I'll be talking about is a hospital or an inpatient setting to start with. When I use the terms family and caregiver, what I'm really meaning is anyone in an unpaid, supportive relationship or partnership with a person living with a mental health or substance use condition. This can be, anybody who's invested in that person's recovery, parents, siblings, partners, friends, children. And when I use the term caregiver, it's a common vernacular, but I really want to be clear that that does not mean that every person who has a mental health condition is dependent on others for their care. We know full well that all relationships are dynamic and reciprocal in nature. And finally, the population I'm going to be talking about as well is adults. So mostly talking about adults, and mostly adults who are living with serious mental health conditions, some of whom may have co-occurring substance use disorders. Okay, and so this is such a interesting thing to be telling this audience the benefits of patient and family, or family and caregiver involvement, but I'm going to. We know that really when we talk about why we want to look at this work, we know that engaging families and caregivers in a loved one's care, just like other medical conditions, they are really vital to a person's recovery. When we include a patient's support network in their care, we're really allowing for a more holistic treatment and recovery. And when families are provided with reliable information about particular symptoms or behaviors that might be occurring, what we're giving them is really an opportunity to understand better what their loved one might be experiencing. We know from the research and from our own experience that that providing families with information about behavioral health conditions can really give them a language so that they can understand what their loved one's experiencing, but that they can also engage in treatment and with treatment providers, and that they can also be empowered to be advocates when the time is needed. We know, too, that engagement programs can teach really important concrete skills, things like, how to positive communication, goal setting, stress management. These can be really stressful experiences. And we know that these types of skills can reduce stress, that they can improve coping, and really foster a home or social environment that is much more empathic and supportive. And we know a lot of times that when we are able to engage families and caregivers, we can encourage them to be involved with one another. This can help people be connected. We know that we've heard this, and we know this from our experience, that having a loved one with a mental health condition can be really isolating. And the opportunity to connect with other people with similar experiences can help folks build their own support networks that promotes belonging and mutual understanding. And then the opportunity to learn about the latest treatment options, medications, and resources can often help replace what can be a very fearful experience with reasons to be truly hopeful for the future. And we also know from the research that when families and caregivers are included and given information, that this has a direct impact on their own health and well-being, which allows them to be a proactive part of their loved one's care. And that when families and caregivers are effectively engaged, they become a really vital part of our behavioral health workforce. There are a lot of benefits for patients too, right? We know that when people are suffering with certain mental health symptoms, that can be really fearful, really isolating, and it can cause folks to withdraw.
They might not understand at all what is happening to them and how to express what they're experiencing, and so therefore can be reluctant to ask for help. But having a support system that's actively engaged can give them that vital emotional support, maintain their sense of belonging, help them feel safe and secure, especially during times of more acute symptoms. And we know that decades of research, again, tell us that an effectively engaged support system can lead to earlier identification of symptoms, can prevent relapse or acute crises. It can really encourage positive and healthy coping mechanisms, and it can improve a patient's overall engagement in treatment. And this all can make a really big difference in a person's trajectory of their life. And yet, despite their importance, we know too that families face a lot of barriers to access to being engaged in a loved one's care. Again, it can be a really scary, isolating experience. I have spoken to countless families in my 20-plus year career that I wish if I could connect them all to one another. The similarity of experiences can be so powerful. We know too that inaccurate and misleading information just perpetuates fear, can reinforce stereotypes and the stigma that we know unfortunately continues to be associated with mental health. We know too that it can be really hard to find reliable information. How do you know how to help your loved one if you don't know what these symptoms mean or what the treatment is that they should be accessing? We also know the reality in our state is that nearly half of all counties in Washington do not have a practicing psychiatrist. We, nurse practitioners, psychiatric nurse practitioners, and others have certainly helped. But what this means practically is that the majority of people with a mental health condition do not have access to a specialist. And that's really different than other types of medical specialties. And this is obviously especially true in rural areas. And despite efforts towards what they call mental health parity, the behavioral health system just does not function like other aspects of healthcare. Insurance policies vary widely. I have had countless families tell me, well, we have really great insurance. Well, actually, probably not when it comes to behavioral health, unfortunately. What services are covered, what kind of authorizations do I need, what kind of wait times are there? All of those things can just serve to further exacerbate a patient's access to care. And we also know that the reality is that for some communities, even talking about mental health is just completely discouraged. And that the impact of structural racism means that there are lots of people in our communities who will just never engage in traditional systems of mental health care. And then there are also systems barriers that exist that prevent effective family and caregiver involvement. This is a service that is not reimbursed by insurance for the most part. We're seeing a little bit of movement right now with CMS that we're obviously keeping eyes on, and there are some pockets of exceptions, but for the vast majority, this is not covered. And as we all know, the behavioral health workforce is really stretched thin, which means they have even less time to engage in what might be unreimbursed work. And when we look at the workforce, when we ask the workforce about what's their experience or comfort level in terms of engaging patients and families, by discipline, it can really vary widely what people are trained to do and how to do this work effectively. And also that within treatment teams, there might be a lot of confusion about, well, that's not my job, that's their job, and therefore it can kind of, feel like a hot potato for patients and families. And again, we've talked a little bit, I really appreciated the conversation about advanced directives. Privacy laws serve a really important purpose, but we know too that in an acute crisis, when a patient really can't give express consent, how this can manifest it is that families and caregivers are just going to be completely cut out of a patient's treatment. And treatment providers may not even know who is part of a patient's care team or home environment, sorry. And we know too that kind of culturally, a lot of mental health treatment programs are focused on the individual, whereas in a lot of cultures, this is a family process, and families and support people are expected to be engaged in healthcare decision-making and treatment. And again, structural racism, we know can really impact people from marginalized populations. And that is something we also struggle with. So, let's see. As we have considered what we can do to improve this reality, we have what Dr. Unützer referenced briefly in his presentation is this new Center for Behavioral Health and Learning. And I hope most people are aware that this is coming. But this is a new 150-bed teaching hospital that will be opening next summer on the campus of UW Medical Center Northwest. And we're very excited about this. This is really presenting us with a special and unique opportunity to reconsider how we engage families and caregivers. The focus of the center will be on long-term psychiatric treatments. It will also have a new center for neuromodulation, so things like TMS and ECT, and then will also include units that are specifically folks who have behavioral health and medical conditions. It's also going to be the home for an interdisciplinary training and workforce development program that will be focused on helping the next generation of our workforce be trained and educated, and that will actually help our entire state. And what's really wonderful about this new center, and they have a website if you'd like to see it, I encourage you to check it out, is that from the beginning, this entire building has been designed with patients, families, and treatment providers' experience in mind. The goal has been to create a non-institutional type setting that's a welcoming environment intended to promote healing and well-being for everyone. And for those of you who've ever been down to Western State Hospital, you might really appreciate kind of the contrast of this program. And given this background, we feel like the center is really an opportunity to pilot a robust, inclusive family and caregiver support program. Which leads to our solution, a Family and Caregiver Academy. What we hope to do with our academy is that it will translate the clinical research and educational mission of our department and our colleagues within UW Medicine into evidence-based skills and training and supportive programming for the families and caregivers of patients in our care. We hope it will be a place of collaboration, of shared learning, and mutual support for patients and families and caregivers, along with members of the behavioral health workforce. We intend to prioritize health equity and establish a program that is inclusive of and accessible to everyone in our community. And we think a program like the Academy has the potential to improve not only the short-term, but the long-term health and well-being for all our patients and their loved ones. And our ultimate goal is that the Academy can serve as a model program where interdisciplinary behavioral health providers and trainees learn with and from people with lived experience as patients, families, or caregivers. So, let's see, wrong button, sorry. So we've really just getting started. So I'm extra excited to be able to present to you all today. We've started to assemble a team of us. Sorry, I keep knocking that pen over. I'm going to leave it there. Andy Uemoto is a member of my department, and she's going to be helping us with strategic planning and project management for the Academy. Dr. Anna Ratzliff, who you heard from earlier, who has moved, I know she's somewhere in here. There she is. She and Alan Goydick from her team, they together have years of experience with instructional design and content development. And so they're going to be helping us build online trainings and helping us take the experience and the information from our department and translating it into really kind of digestible material for families and caregivers. I'm also very grateful for Dr. Ratzliff's partnership because she also has expertise in evaluation of training programs, and she's going to help us lead pilot evaluation efforts. And then finally, we have Charity Holmes, and Charity Holmes is the behavioral health administrator for UW Medical Centers, and she is responsible for a lot of the good work that's happening getting the center open, and she's a real champion of patient and family-centered care. Charity is a big advocate for this program, and she's going to play a really important role in helping us integrate this academy model into the center before the doors even open. We've also been really fortunate to work with some of our internal and community partnerships because we really want to leverage the expertise we already have and avoid redundancies. Most notably, I really want to call out our colleagues in the Spirit Lab. If folks know about the Spirit Lab, Dr. Maria Monroe-DeVita is in the audience. But Dr. Maria Monroe-DeVita, Sarah Kopelovich, and Akansha Vakswani Bai have already developed some wonderful programs. They have a project called Psychosis Reach. And this is a skills-based training for families and loved ones of folks with psychotic disorders or experiencing psychosis. And it's built on a cognitive behavioral therapy model where it really turns it into a caregiver focus. And that's another wonderful program to check out. And also a Family Bridger program that we talked about a little bit earlier that's a family for adults, so family-to-family model that we would love to include. And they've been very gracious in sharing their experience and expertise with us already. Of course, we're going to be partnering with groups like NAMI. They have been at this work a long time, and so we know we'll be partnering with them. And then recently, we reached a little further afield, and we're in touch with some folks at McLean Hospital, which is outside of Boston. They are many years ahead of us, but have developed some really incredible patient, family, caregiver, and community education and outreach programming that's helping us kind of think, aspirationally, like what could we be and what can we be aiming for. So as we build our program, we intend to focus on kind of these foundational components, focusing on what we know families and caregivers have identified as most important to them. We expect that the Academy is going to be available to families and caregivers, and it will function as another way for them to be involved in a loved one's care. So your loved one comes to, let's say, UW Medicine for a treatment, you would have access to these services and this training and education for yourself. We expect that it will offer, practical information, evidence-based and culturally informed skills trainings, positive coping, communication, goal setting, crisis management, in addition to information on the latest in diagnostics and medications. We also plan to build an Academy website that will host not only our training materials, but that will have a library of resources and information that we intend to really be thoughtful about in terms of curating them for scientific rigor, to make sure that they're reliable, that they're written in plain language, and accessible and relevant to a diverse community of users. And of course, we hope that the Academy will provide families and caregivers with opportunities to connect with one another, because we know that those support networks are just unique and so vital. So this is meant to give you kind of a schematic of this pilot that we're going to be launching on. And we're going to be using basically kind of a psychoeducation model that has a lot of great research and has been proven to be effective cross-culturally as well. And so I'll explain some of these terms. So we're talking about what's called an asynchronous training pilot. And so the scope here is what is in blue. So we're going to start, we're going to use input from patients and families and caregivers from the very beginning. And we're going to use some guidance from equity impact tools to build this website and this curated resource library, and also what we're calling the Transdiagnostic Training and Support Materials and Curriculum. And so what this means in the real world is that we're going to start with some online training modules that will be available on demand to families and caregivers, thus the kind of asynchronous idea. And this is opposed to like a live video, and we think that this will allow families and caregivers to access the information on their own time and when it's most convenient for them. We want the materials to also include an orientation to the center. What does it mean to have a loved one hospitalized with us? Kind of a what to expect document, or information, excuse me. And then a focused skills training program. And what we're going to focus on first is kind of some basic communication skills that we know can be just really helpful for folks. These will be skills that we are going to plan to be kind of transdiagnostic, so could be applicable to a family member or loved one with any kind of mental health condition, and so hopefully applicable to a broad audience. And what we hope, too, is that by building this kind of foundation model, is that eventually what we could do is add diagnostic-specific categories, so things like a psychosis reach that are focused on folks experiencing psychosis. And so that's the pieces illustrated there in gray. Initially, what we're thinking is we will be offering this pilot to the first patients admitted to the center. And so what we're going to be doing is kind of the next 6+ months, we are going to be hard at work at getting our pilot built, developing our content and the related infrastructures. And of course, I want to just be clear that we know some of the limitations of this model from the beginning. The online, we know like telehealth has been wonderful for access, but it's not a wonderful access point for everybody. And so we know that that's a limitation and it won't work for everyone. And that's something we're definitely going to monitor over time. And unfortunately, all of our content will be in English to start. But this is kind of what we have with the resources that we have available to us. So as the pilot goes along, one of the things we're going to be doing is we're going to test and evaluate the model throughout the pilot phase, and we want that to be an ongoing process, so we will adjust as we go based on the feedback that we get from participants. We're going to collaborate with our colleagues across UW medical centers, our department, and community to develop that what to expect so it really makes sense and isn't redundant to other resources that are there. And again, this website of curated resources. And then we're going to be recruiting families and caregivers, which we know can sometimes be a challenge, but we're going to recruit families and caregivers to take the curriculum, and we're going to ask them to give us that feedback along the way. The feasibility, we're going to look at the practicality of this training, the utility. We're going to monitor family engagement with the materials and track the number of people who register and take the trainings, and survey all participants to help us understand and learn what other modules might be helpful. And we also want to do a chart review of the patients whose families and loved ones take our training so that we can look at, if there's cost savings in terms of rehospitalizations, that this might be a way to fund the model. So I'm going to speed up because I'm out of time. Because this work isn't funded by insurance, one of the biggest things we're going to do is look at, we've got some pilot funding from donors and research dollars, but we of course hope to get additional funding so that we can build collaborations, we can expand that clinical content, continue to look at models to engage families and caregivers in supporting one another, so peer-to-peer models, and look at ways that we can integrate what we learn into the training for our interdisciplinary workforce. So really, again, helping our patients and families and asking them to educate our workforce. And so in the big picture for our Family and Caregiver Academy, we envision a future where we instill hope, eliminate stigma, and build compassionate, supportive communities through evidence-based education and training for people living with behavioral health conditions and their families and caregivers. So how can you get involved? We would love to hear from people who have lived experience as a patient, as a family member, a loved one, a caregiver, an advocate, a workforce member. We want to hear from you as well. Who should we talk to? Who should we collaborate with? Who can we learn from? Have you taken trainings or participated in programs that you really liked that might be models that we could consider? We want to think about things that are by other diagnoses and that are inclusive and accessible to diverse cultures and folks from all sorts of backgrounds. And if you'd like to contribute, we're definitely interested in finding volunteers who'd be willing to look at our curriculum, at our website, and our various materials. And then, of course, as I said, we're looking for opportunities to help us sustain and fund this academy model in the big picture. Thank you so much, and I'm happy to take questions.
Hi. First question here. Will family members / caregivers who have patients in their lives, but those patients are not in your program or any program, be eligible for services at the academy?
Not for the pilot phase. We certainly hope to expand it. Absolutely. I would love for this to be everywhere. But we think to start with that we're going to focus on a population so that we can make sure that we really start with a good foundation and can kind of do that like iterative process of making sure that we're on the right track. I come from Harborview. I would love to see this at Harborview, and statewide, of course. UW is the largest trainer of the workforce in our state, and so we certainly hope that by being able to spread this model to the workforce as well, that will give us opportunities to share more broadly.
How does the family access current and future family/caregiver support, and how would they even know about it?
Well, it depends on where you are, I suppose. A lot of the hospitals in our system and the clinics have social work providers, so I don't know exactly where that person was, but if someone wants to reach out to me, I'm happy to give them some more information if that's useful. It's a little hard to answer that without knowing a little more information.
Thank you. Thank you. We're going to now move to the third one, and I'll have you come on up. Our third initiative this morning is preparing co-responding mental health professionals to work with law enforcement in crisis response, presented by Susie Kroll. Welcome. This is some amazing work that you're doing. Susie Kroll is a mental health provider and the co-response program manager at the King County Sheriff's Office. She was the founding mental health professional for the law enforcement and mental health professional co-response programs in 7 King County police departments. She is a national educator and speaker on crisis and de-escalation, mental health, and crisis negotiation. And she instructs at the Washington State Criminal Justice Training Commission. Thank you. Welcome.
Good morning, everybody. I'm so happy to see all of your smiling faces. It is a welcome change from our recovery from the pandemic and pure and total utter isolation. So I'm very, very happy to see all of you. Here to speak to you today about the preparation of co-responding mental health professionals for law enforcement. And for frame and context, I stood on this stage in 2018 asking for mental health professionals that wanted to even work for law enforcement. And in the evolution of that time frame, we've seen going from one co-response program that started with the Seattle Police Department and one with Shoreline and Kenmore, and then 3 subsequent departments with 2 mental health professionals working, to over 110 mental health professionals across Washington State and 67 co-response programs that not only encompass law enforcement, but also the fire department. So this is the next iteration of now trying to staff the demand, which I just said all of those bad words of staffing and demand in this room, but at least I have some similarly minded brethren. So if we're going to level set so everybody understands, co-response is defined as embedding mental health professionals with first responders to address calls for service that involve some sort of crisis or social service or behavioral health intersection. And what that means is that a crisis can look like all manner of things to all manner of people, and we want to help bridge those gaps when we have the most buy-in from the person in crisis with the most robust set of resources available. If we talk about first respondership, we're looking at law enforcement and fire and EMS, and now we're also graduating into the process of putting mental health professionals to co-respond with 911 dispatchers, because there are calls that come from 988 that are higher acuity that still need that breadth and bridge. So if we can place 911 dispatchers in partnership with co-responding mental health professionals, we cover many, many, many bases. So today we're going to be focusing specifically on law enforcement and what that looks like. Here is the overview of some of the challenges we're experiencing. I'm going to say the S word, staffing, and trying to find qualified mental health professionals to do the work. And part of that challenge is the cultural integration of working in a first responder role. And yes, that does include race and ethnicity, but moreover, it also includes the culture of an industry that traditionally has some very rigid working parameters, laws that have to be followed, governances, House bills, changes in interpretations for what laws and local, state, and county, and even city municipal codes look like for the working process of partnering co-response with law enforcement. There's also a component to the staffing challenge that has to do with background checks. In order to work for a law enforcement agency and be employed by them, there is a robust background check. And I don't know how many of you would be familiar with that, but the last time I filled it out was 85 pages of online documentation from everywhere I lived as far back as I can remember to today. And that also encompassed a psych evaluation, a polygraph, a physical, and a drug test. And even to work within a law enforcement agency, there's contingencies for types of things that you have done in your past or experienced or been a party to that may preclude you from being able to work for that police department. And that can include felony arrests, domestic violence perpetration, and certain types of drugs and drug use, depending on how recent that was. In addition to that, there is a very, very, very specific set of training protocols that go along with being a co-responder. And it is above and beyond what we're taught as clinicians to do in a crisis setting. When I assessed for crisis, suicidality, homicidality, grave disability at my counseling agency in my office in relative safety, that process looks very different sitting in the midst of a crisis that was precipitated by a 911 call. And so we're looking at proper training for crisis response in addition to those background pieces and that cultural integration. And now that we've seen the graduation and growth of co-response, not just in Washington State, but I've also consulted with mental health professionals starting these programs in Canada, in Australia, and in Ireland. There is the need for proper supervision of those individuals because, again, doing this work in a high-pressure crisis situation looks a whole lot different than it does when I would supervise clinicians in a counseling office doing that level of work for either post-crisis follow-up or that continuation of that recovery in healthcare. So what's our progress to date? We have, in almost, well, just shy of a decade, seen an explosive growth in co-response programs nationally and locally. We're actually one of the forerunners to doing this work and modeling it across the country. What that's done is create local outreach and alliance groups like the Co-Responders Outreach Alliance here in Washington. There's the International Co-Responders Outreach Alliance that is national and frankly international at this point. The first conference I went to with them 3 years ago had 200 people at it. And last year's in Spokane sold out with over 650 people in attendance from across the globe. So there is a huge push for this work. With the cultural integration, more and more trainings are being brought to bear with crisis intervention training. More and more mental health professionals are attending those trainings at the police academy. And currently, a lot of those trainings are also integrated with individuals that have done the work and provide private trainings. And we are trying to nationalize and programize our trainings across the board. What we're also having to deal with right now is the background check process to working with first responders and what that education looks like. But if we look at what that looks like, in addition to looking at crisis intervention training, we do have this space of education happening at the Criminal Justice Training Commission, which is the police academy here in Washington. We do have largely self or privatized trainings that are available. And then the largest amount of training for co-response actually happens on the job. If we can get past the staffing, the education and the clinical supervision and the crisis type work with that cultural integration. So we're struggling, however, with not only the burden of having tons of work and the things that I just mentioned, but also Department of Health requirements. For scope of understanding, when I first started in co-response, I was a licensed mental health counselor. I was working for the second largest behavioral health agency in King County and had 150 employees in the 6 clinics I was in charge of, and I was working as that person and providing therapy to a caseload. And I was approached by a lovely woman who asked if I wanted to co-respond and quit my current job and work for law enforcement and do this work, and I said no. Because it was grant funded with no benefits and no stability, and I didn't want to pray every single year that I would still have a job. Not with 98 grand in student loans just for my master's degree. We've made some poor choices, but we were not going to make that poor choice. So then she offered me more money and asked if I would quit, and I still said no. And then she finally said, you know, we're on this grant, we're on a clock, will you do this part-time while we try and find a full-time person? History being what it is, I am now fully entrenched deeply in the crisis services of King County and with law enforcement. I'm no longer with that counseling agency, though I do miss it dearly. And I've seen a couple of my former coworkers in here that reminded me how much I loved them. But what we're also seeing is that we need to more intentionally reach out for that staffing. And so moving forward, here is what we've envisioned for what this looks like. We would like to start promoting this as an industry for employment in high school, so that we can mark in our young people's minds that this is a possibility for employment, and that you may want to really, really deliberately think about the choices that you're making so that you may not inadvertently preclude yourself from doing this work by having a little bit too much fun at some random party at one point in time in your high school, college, etc. Experiences. We would also like to have advanced training for this type of work to specifically partner with our first responders doing very intensive, oftentimes not the safest, co-response work. And what that entails for us to intentionally lead this as a viable industry is to look at credentialing. And what we'd like to do is actually create a clinical credential for the folks that want to do this work in order to ensure, one, they have the best training possible, two, they can do this really well and safely, three, they can culturally integrate, and four, and most importantly, we can bridge those service gaps when we have the motivation of the person in crisis to do it. And so here's what we're proposing. To have a COR-M credential for a master's level clinician, so you'd have to earn your master's degree in social work or counseling psychology, whatever that looks like, and then have to do an additional core training, co-response training that shows that you have that level of experience. And so then you'd be an LMHC, that's my credential, licensed mental health counselor, plus a COR-M. Or if you're a bachelor's level case manager and doing that level of social work, you get that credential, and then you take core training that shows specifically what you can do and how you can case manage and support this type of crisis response with that bachelor's level education. And three, because we know it's incredibly important for somebody to be able to say, I've been here, I'm around the corner a little bit further than you are. If I can make it, so can you. Partnered with all that clinical expertise with all of your other co-responding MHPs, we need a CORP for peer training so that they can get their peer support credentials and also provide that level of core training so that a peer support specialist has the safety and the training and the ability to work within that sphere as well and do, like I mentioned earlier, the cultural integration, the ability to staff, and the ability to meet our clients at their most vulnerable and provide that level of service. And finally, which sews all of this together so tidy for me, is that we need a COR-CS, or Clinical Supervisor Credential. You need a master's level Department of Health credentialed clinical supervisor status, and then an additional specialized training for what it looks like to supervise clinically our folks that are doing the work. That way we don't have to do what I did, which is maintain a full-time job at a counseling agency to meet my specific licensures hours requirement, and then work a part-time job as a co-responder. That we can get folks from college in their programs, immediately doing the work, meeting the licensure requirements for their credentials, and building a workforce from the ground up instead of trying to piecemeal it and work with what we've got. So taking action. Currently, the Co-Responders Outreach Alliance has legislative support from a lobbyist, Brad Banks. But what we need is more legislative support. What we need is earlier engagement with students to be able to see this field of work, how incredibly vital it is, and what they need to do to pave that pathway forward. We also need some student loan considerations. 98 grand for a master's degree in my world, for my personal experience, is a lot of money. And being able to do this job and co-respond would need a specific type of loan forgiveness potential that I didn't qualify for when I started co-response, but that many new students would be if we had a viable credential and this industry working as smoothly as it is and more smoothly with these advancements. And then finally, we need Department of Health engagement to look at the creation of these credentials. So what's the vision? We would like to build our future workforce earlier, so that we can address any backgrounds and disqualifiers and show that this is a viable career option. And it is an incredibly powerful one to be there when somebody needs somebody to reach out to that has the expertise to partner for public safety, law enforcement, and crisis intervention. We would like to have appropriate trainings for this specialization of work. It is very unique and it is very different. There are functions of me as a therapist that I use in this work, but man, they are very different than what they were when I was sitting in an office with a client doing therapy for a 50-minute session. And we would like to have more MHPs be able to fill these vacancies, and that includes master's level, bachelor's level, and peer support specialists, because they play a vital role and neither can replace the other. We have to work in partnership and tandem. So how can you help? If you can say these things, any one of these things, or maybe there's a unicorn or two in this room that can say all of them. I have legislative influence and can support co-response legislation, credentialing, or student loan matters. I have influence or work with the Department of Health and can assist in the development of a co-responder credential in Washington State. Or I'm a licensed mental health professional, and you just sounded so snazzy up here that now I want to co-respond too. Come find me, we're hiring. If you could answer yes to any 3 of these questions, and let me tell you, if you've got some unicorns, please send them my way. We would be very, very, very happy to engage with you, introduce you to the field of co-response, tell you a bunch of success stories, and help us pave the way to meeting crisis where it happens so that we can better engage all of the services that you're hearing about here and the many more that we will have the opportunity to engage with in the future. This is my contact information, but I figured there'd be lots of questions, so I'm going to open the floor to your questions.
Okay, I can start us off. Hold on. Oh. This is wonderful work, thank you. Are there plans for law enforcement professionals to take the core training, i.e. will they know the limitations, or are there limitations? Also, is this similar to what is being taught in the police academy?
I could answer that question actually with some pretty good depth. So yes, in the core training, if it's co-response, it needs to be led by and co-taught by both mental health professionals and law enforcement. These trainings would be made available, obviously, to the agencies with co-response programs, because it doesn't do us a whole lot of good to have a bunch of mental health professionals prepared to do the work if we don't have law enforcement folk that are prepared to have another body in the car doing the work. And currently at the Police Academy, the trainings that occur are called crisis intervention trainings. There's an 8-hour one that talks about behavioral health issues and verbal techniques to de-escalate. Then there's an additional 40-hour training. And that class is predominantly full of law enforcement, but there are more and more mental health professionals coming across to it. And so yes, there is also an introduction to co-response training for law enforcement currently, but with a COR core training, we would actually be able to expand upon that for not just the social services side of the house, but our fire and our police departments as well.
We're going to take a question. Sorry, too close. Whew. He said close. We're going to take a question from the audience back here.
I just mostly have a comment, but it could be a question too. Did you know there are 7,200 peers that have been credentialed as peer specialists?
Yes.
In Washington State. That's huge.
Yes, it is.
And many of them don't have jobs. So I really want to just open that opportunity for you. And lastly, I had a crisis last fall, and police and fire responded after I called 988, because I think it was so new in the implementation of a national 988 that they didn't really know what to do. So they came instead, and they were amazing. But when I was hospitalized, and I was boarded in an emergency room first, and then I got a bed for about 14 plus days, a peer appeared at my room when I was inpatient, long after the boarding and the inpatient services, and really paved the way for a smooth discharge. They navigated with my psychiatrist on staff, who was wonderful. They navigated with the hospitalist that was coordinating my physical health care along with the psychiatric care. And they worked with my therapist, who ultimately took me home, who I was discharged to and brought home. So I just want to emphasize the importance of the peer role, no matter where they might be. But I can just well imagine, because they are on mobile teams around the country now, the many opportunities that we have and the great training that has been provided to peers who are now waiting for jobs. So Just want to
Wholeheartedly.
put that out there for you.
And that's huge. My first experience with peer support specialists was when I worked for my counseling agency, and they were a vital piece of our care team, which is something that I've carried forward from that agency into this work, and neither can replace the other, and there is some magic in that shared experience, and for sure we would love to engage peers.
Thank you for your presentation, Jude.
Thank you for attending.
My name is Mila Boyd, and I'm diagnosed with tons of disorder, bipolar, multiple personality disorder. I have a question for first responder, because I experienced that. If I have mania, I'm not capable to dial 911. So can we have a solution for that? The other things, when they came, I was manic, and I just started therapy of tapping. So they came to me because I was married when I was young. I was 13 years old when I got married. And I was arranged marriage, there's no love story or anything. So when they did the tapping, I got a very aggressive mania because of just the response. I loved that treatment, it was very good. So when they came, they didn't realize I was manic. They don't know what's wrong with me, and I couldn't speak. So what they did, I love it, I respect them, but they tie me to the bed. So when I wake up from my mania, I was like, oh, I'm dead. Everything is, dark. There is no machine. There is nothing. So I think first responder, they're very nice to me, because when the man come, I was like, you're not gonna do CPR to me. You're not gonna kiss me. And I was like, there's no kiss or anything. It's just I was scared. So I think the question is asking how we can make available for us to call 911 when we can't. We are manic. And the other question, what we can do when we can't speak, we are manic, and they are asking us questions. What medication you are taking? What is your diagnosis? And I have tons of diagnoses. I don't have that capability. So I'm interested to volunteer if you need anyone, because I think this is really important to be addressed.
Absolutely.
Thank you so much.
Absolutely, and I appreciate you sharing what you shared. I wish I had a magic way that we could just communicate with emergency services to get people there. Largely, my calls for service really revolve around somebody calling, whether it's a friend or a family member, a concerned neighbor, or somebody that's seeing something out in the community. And then the second piece of that that's really important ties into what Todd was talking about mental health advanced directives and their accessibilities. And I can see the utility in having access to those documents for when we aren't able to advocate for ourselves, but when we were at a point in time able to be able to set that directive ahead of time. That way a first responder, a co-responding mental health professional, a firefighter can say, hey, Susie's not able to be her best self right now, but I can see that this signed official document says these things, and then we can skip repetitive, inefficient methodologies for treatment. And so it's not a perfect wand-waving solution, but I really feel that the ties of mental health advanced directives can bridge some of that communication gap.
Speaking of.
Here I am again. Laura Van Tosh just eloquently talked about the value of peer counselors and the availability of peer counselors for employment. We've been talking about this for a couple of years now, and in their value, and they're becoming a first line of defense and also a part of the continuum. But there's still a lot of availability with not a lot of hiring. What do you need to have happen for your program to find these peers and actually get them hired? Where's the rubber hit the road on that piece?
For me, the rubber hitting the road is in a couple of different places. One, hopefully in our peers' ability to move past some of the background check requirements, or to have some modification of those background check requirements for law enforcement, fire, and dispatch centers. Two, to actually look and more creatively address the continuum of law enforcement and first respondership engagement. I was recently a keynote speaker for the Misdemeanor Probation Office National Conference. I think that's how you say it. But I found out that probation officers are not allowed to make service referrals. They can't get their folks to counseling or services. They just have to see whether or not they meet probation expectations. For me, that is a very, very perfect spot for a peer. And they were actually very interested in having a co-responding type situation where that probation officer had a peer or a mental health professional that went with them, because they, by their job description, can't say, hey, Bob, you're having this issue, your sobriety's teetering, it's part of your conditions of probation, let me take you to XYZ counseling agency. But that peer could do that. And so for me, it would be background check augmentation, exceptions or modifications to that, and then looking really consistently at the continuum of law enforcement or criminal justice involvement and plugging our peers into those places.
You kind of answered the question a little bit, but I was just wanting to say, like, a lot of peers, especially the good ones, have criminal backgrounds. They have mental health issues and you know, charges or from way back or whatever. And so with all the restrictions, how do you get peers to be hired if we can't pass the background checks?
Right, and that is one of the biggest pieces of that, which is why I would hope that there would be a way to modify some of those requirements, especially if you have longevity in recovery, or whatever you did was when you were 18, 19, 20, and you're now in your 30s or 40s, and you have nothing of that same level of engagement previously, then I feel like a modification to some of those backgrounds is possible, in addition to trying to find those other avenues in that continuum where peers can be utilized. There are exceptions currently for background checks with relation to substance abuse, because in Washington state, marijuana is legal, even though federally it's not. So there's a time frame gap from the last time somebody could have smoked marijuana to being able to do the work. It's a lot shorter time frame than it would be for illicit or illegal drugs, and I don't see why a modification couldn't be made for that, for specific job roles that don't center around being commissioned, but still bring that crisis support service. So those are my three places: that continuum, the modification to a background check, and the longevity of somebody's recovery would partner well to help alleviate that concern.
We have a question from the virtual platform. Where can one find out the types of things that would preclude a person from this type of work before they invest time and resources to become a professional in this field?
Yes. So the standing information for that typically is at whatever department you're wanting to see if there's a co-response program in. They will list out some of the requirements and things that will preclude you or will get you past that kind of application process. However, I will caveat that with that is typically for commissioned law enforcement staff, not for necessarily professional staff or non-commissioned folks, i.e. those of us that are not police officers. So if that agency has a co-response program, it would be beneficial for that individual to find that co-response manager, ask them what the background check requirements are for a non-commissioned individual, and see, depending on, like I said, the distance from, say, past history to today, and what that looks like and if there are exceptions. But there's no federal or local standard across all places, because not all agencies have co-response, and it is still, even though I'm in it, have been in it almost a decade, it is still pretty nouveau.
One of the most significant issues in crisis response is dealing with people that are seriously mentally ill that have anosognosia.
Mm-hmm.
They have complete lack of insight. And that's something that co-responders really need to learn how to deal with. So what in your system or in your training protocol can give responders that level of sophistication to be able to look around the corner and get the necessary information to make a good decision?
I love that you mentioned that. Washington State was the host of the International Co-Responders Alliance Conference this year. We were in Spokane, and our first and most predominant keynote speaker was the doctor that has done the vast majority of the work for anosognosia across the country. And he came and spoke to us for 3 hours about the ins and outs of what that diagnosis entails, how the best engagement can look, books and references for us that were co-responders. And for context, the co-response conference was over 650 large in attendance, and it was half first responders, police officers, firefighters, and half clinicians. And so we are bridging that gap from the clinical side of the house with our partners so that there is awareness of it. And then as we continue to develop the crisis intervention training for King County, that is a topic that can be added to our 40-hour training so that law enforcement that does attend that can get information there as well. Okay. But you hit the button because that was our biggest keynote presentation this year.
We have another question from the virtual platform. How would the co-responder credential holders work with mobile crisis response teams?
When I look at mobile crisis response teams, I know from the work that I've done that every single type of response to someone in crisis has a place in that continuum. Mobile crisis teams I utilize as a co-responder when the benchmark of work doesn't meet a law enforcement criteria or it doesn't meet the intensiveness of my participation in it. And so having mobile crisis teams available to do some of the follow-up and do some of that modified case management is incredibly vital. For me, just off the top of my head, when I think about a co-response credential, since it would include so much about safety and dynamics and spatial awareness and a lot of the de-escalation techniques, it would seem very logical to me to have our mobile crisis individuals that are not responding with first responders also take a core training just to be able to have that knowledge base and familiarity with the system because we're all working in the same capacity. That way when we do those handoffs or they do refer people back to us or we refer our contacts to them, that we're working off the same sheet of music.
Someone on the virtual platform asked about your last slide being limited to interested mental health professionals, and they want to know about involvement of peers and bachelor-level professionals.
Everybody. Here's the contact information. Find me. I would love to engage bachelor's level folks. I would love to engage peers. I would love to engage licensed clinical mental health professionals as well. There's a place in all of our co-response teams for them. And I know that cities are hiring varied levels of service for addressing community needs. So yes, it says I'm a mental health professional, but if you're a peer and you're a bachelor's level or any combination of those things, please reach out because we are building that conduit for helping with staffing.
Okay. Can technology like that for the hearing disabled be used as an idea for those that are having challenges with communicating with first responders, etc.?
Yes, whoever has posted that question is actually hitting on some very specific things. King County in its entirety has language programs, and the King County Sheriff's Office is specifically working with our language accessibility team in order to provide tablets with face-to-face communication, translation, and interpretation that would be sanctioned for either a law enforcement setting or a clinical setting. And so we would have and are rolling out the ability to have a tablet that provides for hearing impaired speaking requirements, language and translation requirements, because language interpretation and translation are very different depending on the setting. And so there is a movement also to have that technology accessible. Right now, the biggest lion's share of that work is grant funded, so we're feverishly continuing to write grants and augment the space because of all of the pathways to being able to provide services and communicate effectively.
One more question?
Got too close. Many counties have a 0.1% tax and sorry, something moved. Sorry, just a second. And in several areas, these funds are being put toward crisis response. How can we help make sure this is a part of what they are allocating these funds toward?
So for those of you who don't know, the mental illness and drug dependency 0.1% sales tax in King County provides much needed funding for a lot of social services entities in King County, and it's fueled dozens and dozens and dozens and dozens of programs for social service engagement. The program that I run for the Sheriff's Office also uses that MID or mental illness and drug dependency 0.1% tax. For Anybody that's looking to start co-response programs in King County, that is an avenue you can pursue and petition looking at mid-dollars. I think the specificity of what you apply for and where that money comes from is the quickest way to ensure that funding is utilized the way that you want it to be utilized, and then to speak to your local legislation and representatives to make sure that this is on their agenda as well. Thank you.
Thank you so much. What a wonderful morning session. It is now time for our lunch break with a few reminders. Remember the Hubilo app? Just hit that red tab and you can start filling out those surveys. We're going to have lunch on both sides, so you can go to either side, and we have exhibitors on both sides. So please take your time. We'll need you back here at 1:15, and I'll do a call out for that when that's time. So enjoy your lunch, everyone. Thank you.
before that, yeah. That's okay.
playing the same little game. I'm only hoping to get to see you, looking around as if I had something I had to try, when all I want to do is see you. I'll say it was chance and ask you to dance, and that will start our romance. And after all I've been through, just to get close to you, I know that you will love me too. It was chance and ask you to dance, and that will start our romance. And after all I've been through, just to get close to you, I know that you will love me. I know that you will love me. I know that you will love me too. same little game. I'm only hoping to get to see you, looking around as if I had something I had to try, when all I want to do is see you. I'll say it was chance and ask you to dance, and that will start our romance. And after all I've been through, just to get close to you, I know that you will love me too. Was chance and ask you to dance, and that will start our romance. And after all I've been through, just to get close to you, I know that you will love me. I know that you will love me. I know that you will love me too.
how our slides show up, but our slides show up here, and then there's a note down. Our notes are down in the corner, right?
Yeah, but we could bring our...
And bring yours, but here in this note section...
Yeah.
And I see you squinting just like I would...
Okay. Hello everyone, welcome back. It sounds like we're having a lot of great conversations, which is exactly what we want. I hope you enjoyed your lunch. We'll give you some time to find your seats, and then we'll return to our program, our afternoon program. There were a lot of interesting booths. I hope you're able to go to both sides. In particular, I wanted to point out Washington Youth Safety and Wellbeing Helpline Program. They're in the North Exhibit Hall. This is a new initiative, and we didn't have time to put it into this program now, but we highly support it, and we hope you got to learn a little bit more about that. Now, we'd like to introduce our fourth initiative, Pro Bono Counseling, presented by Danie Eagleton, Gary Renville, and H. Scott Shurtleff. Danie Eagleton is a licensed mental health counselor and educator at Washington Counseling and Consulting and an adjunct faculty member at Seattle University. She has worked in mental health for more than 16 years. Her former leadership roles in behavioral health include Chief Clinical Officer and VP of Network Management at Wellspring Family Services, and Chief Clinical Officer and Interim President and CEO at Seattle Counseling Service. Danie is passionate about bringing her clinical expertise to increasing mental health services for LGBTQ+ and BIPOC communities. Gary Renville. He is the Executive Director of Project Access Northwest. He has more than 25 years of experience in education and nonprofit leadership. His work has crossed multiple sectors and has included fundraising, strategic planning, nonprofit management, board development, cause-related marketing, membership growth, program development, event planning, and building organizational culture and corporate employee volunteer engagement. H. Scott Shurtleff is a senior program director, also at Project Access Northwest, where he has worked for 14 years. His duties include day-to-day operations and supervision of the Care Coordination Program, Premium Assistance Program, and several pilot projects. Before joining Project Access Northwest, Scott had more than 20 years of experience in the insurance and healthcare industries, so he has walked through fire. So with that, we will let the panel begin.
Good afternoon, everyone. So helping the uninsured and the underinsured individuals experiencing poverty in Washington State receive specialty and dental care that they need, matching pre-screened clients with volunteer specialists to deliver life-changing care and pay for insurance for those who are unable to afford coverage, has been a core of Project Access Northwest since our inception in 2006. Until recently, care coordination really focused on the eyes down, meaning that we were covering everything from vision to podiatry, and typically mental health was not part of that. Our clients are 300% of federal poverty level or below. That means that the average individual makes $43,700 or less per year. They usually have a no-show rate of about 40%. And a lot of that is because they're hourly workers. They prioritize jobs, family, over their health care. Through the work of our expert care coordinators, many of who have been in the field for many, many years or have come from similar populations, our no-show rate averages less than 5% per year, and that is absolutely astounding. We've had a couple of months where it's been less than 1%. So we know that clients are receiving life-changing care that they need from amazing providers who donate those services, all at no cost to the client. So if a client has Medicaid, the provider is asked to bill Medicaid, and if they're uninsured, to donate those services. So we know that there's a safety net for primary care through the FQHCs, the free and faith-based clinics, the family residency programs at hospitals. But we were called on to be the safety net for the safety net. That's what led us into specialty care coordination in 2006 and our pro bono counseling initiative. We received requests from providers and clients. In hearing those requests, we led with empathy and started asking, if you were someone living at or below 300% of the federal poverty level, are uninsured, underinsured, need access to care, need access to behavioral health services to address issues as stress, anxiety, sadness, grief, life transitions, and relationship issues. What barriers do you need to have removed in order to access the care that you need? And we ask providers very similar questions. What barriers do you face, and what do you need to happen in order for you to donate your time and skill? For those of us in person today, we'd like to put the hat on and ask you as a client, what would it take for you to be successful, and what barriers would need to be removed? And for those online, we'd ask you to think from a provider's perspective, what would you need to remove those barriers to see clients at no cost? So we'll take a few minutes and we'll come back in 2 minutes and we'll review some of those answers. So talk amongst yourselves. All right, it's been about 2 minutes. Let's come back. So in our experience working with almost 70,000 clients since our founding, we wouldn't be surprised if some of our responses are similar to what you've seen. So some of those are on the patient side: transportation, language barriers, cultural competency. We also hear that clients need flexibility, so the ability to be seen after hours, weekends, flexible around work schedules, being able to be seen in person, be seen telephonically, be seen by video chat, be seen by people who understand them. And in our experience working with over 2,000 specialists, we've heard very similar things around ensuring that we have a clear understanding of what the client needs, having capacity and space to see clients, making sure that clients show up and are attentive to those appointments, making sure that they're a good fit for those services. So those are some of the things that we've heard over the last several years, and those are things that we've addressed through our programs. Project Access Northwest, we believe that quality mental health care is a human right and can change a person's life, a person's family, and our community. So taking all of that into consideration, We created solutions for both providers and clients utilizing our proven care coordination methodology. And with that, I will invite Danie.
Well, Scott, thank you so much for that excellent overview of the program. Hello, everyone. My name's Danie. Hey. Hey, y'all. What's up? I'm Danie Eagleton, and I am thrilled to be the consultant that was engaged by Project Access Northwest to develop their solution that we are presenting today, namely the Pro Bono Counseling Initiative. Luckily, as we devised our initiative, we did not have to reinvent the wheel. In fact, we found a program in the state of Maryland that is approaching pro bono counseling much in the same way that Project Access Northwest has been approaching specialty care coordination since their founding. We thought it might be best for you to hear from that program, the program that we modeled our work after, and it can be found in this 2-minute clip.
Good morning, Pro Bono Counseling. This is Anna. How can I help you?
The phones are always busy at the Pro Bono Counseling Project. We're inside a small office in Towson, are matchmakers of sorts. They pair people unable to afford mental health services with licensed professionals.
We have social workers, we have psychologists, psychiatrists, psychiatric nurses, licensed marriage family counselors.
Amy Greensfelder is the executive director of the nonprofit that for the last 26 years has created a network of volunteer providers across the state who offer their services for free.
A lot of our cases are depression, anxiety, post-traumatic stress disorder, grief, life transitions, the whole gamut.
You have to have limited insurance, no insurance, limited finances. Immigration status doesn't matter. Everybody's welcome at Pro Bono.
Swaran Dhawan is a retired clinical social worker and one of more than 700 providers across the state who take on pro bono clients. She says treatment lasts as long as necessary.
Sometimes they may just need about 5 to 6 sessions. I've had couples that are going a little longer, depending on their need.
We call clients 1, 3, and 6 months after they've been matched just to check in and see how they're doing. And if there's any issue, they'll let us know.
The Pro Bono Counseling Project helps about 2,000 clients a year. Online testimonials are powerful.
I was in such a bad place, such a dark place, that I'm not sure what would have happened. Wow, if I hadn't found them, I don't know, maybe I committed suicide as I was planning.
When we call clients for follow-up calls, they'll say to us, I never knew how much in need I was until I've made it through the other side. My therapist has been so helpful. I have a light at the end of the tunnel. I can function so much better. I mean, that's really the good stuff.
Jennifer Franciotti, WBAL TV 11 News.
So it's so great to bring Amy and Sherry into the room with us because they were with us at the beginning as we were trying to figure out how to put this together. Whether clients are referred or self-refer, once Project Access Northwest is contacted, they will schedule a phone interview. We want to get to know the person as an individual. Questions are personal but not intrusive and often include the following. How would you like to be addressed? How would you share your pronouns? Why are you seeking help now? Are there any past experiences that you'd like to share with us? What type of therapist would be most helpful? The more we understand a person's background, the better chance we have of finding the right match for them. Similarly, we consider preferences for a counselor's cultural background, expertise, spoken language, gender, therapy style, and other factors to find the right fit. If a person is matched with one of our pro bono counseling partners, they will be provided with therapist contact information as soon as we possibly can. Our counselors are able to meet with clients for therapy in person or over their own secure virtual platforms. Telephone-based counseling is also available. If someone's needs are outside the scope of our volunteers, we'll connect them with other free or low-cost resources near them so that they can get the connected care. You know, the reason we're all here today is to be able to talk about behavioral health or to talk about mental health. We're all concerned, and we're all trying to figure out how we want to be able to help the need. This topic and the need has grown so tremendously, and this project is meant to create more clinical space. When I talk about clinical space, I'm talking about places where people can get whatever it is that they need from that perspective of mental health issues. I get calls all the time from people looking for services. I literally got a call before I sat down, not even making it up. People are in need, and they need help. This is a solid program that I think can help clients, but also those who are trying to help others. And I'm talking about what happens when someone calls you, just like what I was talking about. Who do you refer them to? Someone is in crisis, and we've talked about that. We had that wonderful presentation around crisis. What happens next? What happens for someone who gets out of the hospital and they need additional services? Or they're doing okay and then suddenly they're not. This is another resource for folks. I also think about how mental health services show up in our churches, how they show up in our health centers that have no behavioral health services, and for our college campuses. These are the things that are plaguing us, and these are the things that we are concerned about. And this program is an opportunity for us to build out for what we need in terms of what's needed. So, there you go.
Thank you, Danie. So to support as many individuals as possible, we partner with licensed professionals like you and with student interns, those needing additional hours of supervision before licensures, who volunteer their services on a pro bono basis, ensuring equal access to quality mental health care. For providers, we offer a number of benefits, not limited to thoroughly screened patients. So as Danie mentioned, we will reach out to our clients and ask some questions, make sure they're a good fit for counseling, make sure they're a good fit for the counselor that we're connecting them to. We will also connect them, if necessary, to our clinical director. Our clinical director is a licensed mental health counselor and a licensed clinical professional. When individuals enroll through our website and volunteer to pro bono counseling, they are part of a movement to improve access to mental health care in Washington. We suggest clinicians pledge to see at least one patient per month to address the issues such as stress, anxiety, sadness, grief, life transitions, and relationship issues. Clinicians can choose how many people they wish to see and can choose the dates and times that work for them. Once enrolled, our team will match a potential client to ensure the needs are well suited, and a professional clinician is free to accept or decline any referral for any reason. Providers can also tailor their participation around their areas of expertise. They just need to let us know what cases they'd like, and our staff will match them. The path to becoming a pro bono counselor for students of psychology, social work, and professional counseling work much in the same way. Under the supervision of a board-approved clinician, they will gain experience in conducting intake interviews and documenting services and providing therapy to matched clients. And I will also add that we have a booth over on the north side of the hall here. And if you're interested in more information, please stop by our booth or go to our website at projectaccessnw.org. Thank you.
Good afternoon, everybody. My name is Gary Renville, and I have the honor and privilege of serving as Executive Director of Project Access Northwest. Before I got up to the podium today, I thought I would start with, you never want to follow Scott Shurtleff, Danie Eagleton, all those who have presented before. But I will say it's an honor to follow these folks because of their brilliance, and it's been a wonderful afternoon. So my piece today is to very quickly talk about our vision. Our vision is that everyone will have access to appropriate health care services that include connecting uninsured and underinsured individuals living in Washington with compassionate and qualified mental health professionals who provide care on a volunteer basis, all at no cost to the client. I also recognize that we have a number of champions in the room, and I want to thank them already for investing in this work that we're embarking on, bringing pro bono counseling services across the state. Folks like Senator Manka Dhingra, folks like Representative Nicole Macri, organizations like Kaiser Permanente, like the Healthcare Authority, like MJ Murdoch Charitable Trust. Those are all champions of change and all champions of access to appropriate care, health care for all, and we still need help. We're looking for volunteers as providers who are already licensed clinicians who want to volunteer with us. We're looking for volunteer as providers needing additional hours of supervision before licensure, and they can get that supervision through our program. We're looking to recruit additional partners and providers similar to existing partnership with city universities like Seattle University, City University, and the Washington Mental Health Counselor Association. We're looking for legislative and philanthropic advocacy leading to continued funding and program expansion, and we're looking for you to share your ideas and expertise that can help us to scale and sustain pro bono counseling in the state of Washington. As an aside, I'm also looking for help with assessment and evaluation, client referrals, and how you think we might tackle the workforce development challenges in ways that we haven't yet explored. So I'd love to hear your creative thoughts on that as well. Thank you all so much. Are there questions?
A question from online. Do you have peer resources and or a peer lens for these clients if they desire?
What I will say, What I will say to that is we have lots of resources and we have the ability to be able to help anyone. So if it means that you might need a therapist, or if it means that we are also trying to find peer-led resources within the community, we have the ability to do that. Okay.
What do people get wrong about Project Access? Like, where do you feel that kind of like education part, especially when somebody's coming into this, and you're preaching to the choir here. We have a lot of that knowledge, but what would you tell that person who doesn't quite get it? Why it's so important?
Boy, what a wonderful question. So for the first 30 minutes, I'll say that I think that what folks might get wrong, not necessarily the folks in this room or the folks who are joining us virtually, is that everybody has access. It's just easy. Just go in, get the help that you need. I think that there's lots of misunderstanding about the barriers to access to healthcare that folks might either forget or not understand, right? Those things that are about building trust, those things that we all have from our own childhoods laid on us, those things that are brought on from experience that we have in our own life, those things that might keep us from the care that we need. And so organizations like Project Access, I think, exist to be that safety net of the safety net, as Scott talked about, but to also help to dispel those myths.
I think the other thing that I would also add to that is, prior to even talking about this project, I didn't know that much about Project Access. And then once I found the organization, I was able to use it for a family in need that with a with a parent who had a lot of medical challenges, and I was able to contact Project Access and to have them helped. And the issue with that is that many people need help to be able to go through the system. So they need someone who will stand with them, make sure that they get what they need. And Project Access does that. So how exciting to be able to think about, could we do that for behavioral health or for mental health care?
Yeah. And not only for behavioral health, mental health care, not only for the specialties that we provide, but we're also that connector agency to other organizations, leaning into the Unite Us platform, for example, and making sure that folks are connected to other social determinant of health needs and having those taken care of as well.
And I would say from the care coordination perspective and operations, we always need providers, more providers. Because the more providers we have, the easier it is to spread the wealth, so that fewer providers are feeling burned out, fewer providers are feeling overwhelmed. And I think one of the things that should be shared is a lot of the work that we do is around the care coordination piece, making sure that the referral is appropriate, making sure we have all the medical documentation, making sure that we have everything for the specialist before the patient gets there. It increases efficiency, it reduces the no-show rate, and it leads to better outcomes.
Great. I think maybe along the similar vein of this question, how can this work provide data to the state about unmet needs so that these services can be funded properly without relying on volunteers?
Yeah, right? Yeah, that's a great question.
It really is.
Yeah.
Yeah, I think that's one of the things we called out too, is I said, oh yeah, and another thing, and that's because I heard it from others, we need that help with assessment and evaluation, and so we call on those folks who are in the audience that can help us to do just that. Without taking away the need for, of course, folks who are in the workforce and getting paid for this as well, without taking away for the opportunities for folks to also give their time, right, and to volunteer their skills and expertise as well. I think that the two can be complementary to one another.
I think the only thing I would add about that is that I love data. I'm not so great with numbers, but I like data. And the fact is that we have an opportunity as we look at data for this project to talk about who we are serving and the populations that we're not looking at and that we're not capturing. And we have that opportunity to do that, and I'm excited about that because I do believe that we just don't have as much information as we need to when we start talking about various communities of color.
Yeah.
Thank you. Oh.
Thank you so much. Sorry for the weird transition, a little abrupt. We do have an interesting next panel. It's going to be a panel Q&A. And so I'd like for them to come up who are going to be participating in this, and I will be doing the introductions as you get up to the stage. We are going to be talking about the future of mental health care, what it may look like given the huge need, as we all know, and the shortages in people going into and staying in the field, and the opportunities that exist for how care can be provided differently. So with that, I will introduce Bryan Hatcher. Can I have you raise your hand? There we go. He is the Vice President of Behavioral Health at Yakima Valley Farm Workers Clinic, where he is working on a strategic approach to significant expansion of the behavioral health services offered to those who receive care at the farm workers clinics. He has more than 20 years of experience in behavioral health, including serving as president of Caregiver Counseling at Wake Forest Baptist Health in North Carolina, where he oversaw a statewide outpatient behavioral health program with 37 locations and 100 clinicians. Laura Hopkins is the executive director of SEIU Healthcare 1199 Northwest Multi-Employer Training Fund, which sponsors the Healthcare Apprentice Consortium. Prior to joining the Training Fund in 2018, Laura held numerous leadership positions at colleges and apprenticeships programs, including the positions of Vice President of Instruction at South Seattle College and Executive Director of the Aerospace Joint Apprenticeship Committee. Her diverse expertise brings the Training Fund wide-ranging leadership experience, sound knowledge of the community college system, and expertise in apprenticeships with unions in management. Bipasha M. has been a volunteer crisis line counselor for 25 years and is a person with lived behavioral health experience. They currently have leadership roles on Washington State's Crisis Response Improvement Strategy Steering Committee and the Lived Experience Subcommittee. Additionally, Bipasha was a youth advisor at the Indian American Community Services youth program, where they advocated for centering the youth voice and worked on destigmatizing behavioral health issues in the South Asian community. As an immigrant and staunch activist, they tirelessly champion social justice and equity in all their endeavors. And Dr. Bill O'Connell is an associate professor in the UW Department of Psychiatry and Behavioral Sciences, where he is a director of the Behavioral Health Support Specialist Clinical Training Program. Dr. O'Connell is a licensed mental health counselor and a national certified counselor with experience providing mental health, substance abuse, and criminal justice services. He has 30 years of experience preparing new professional counselors. And Dr. Keri Waterland is the division director at the Washington State Healthcare Authority's Division of Behavioral Health and Recovery. Keri has an impressive career in Washington state government, including working for the state Senate's Human Services Reentry and Rehabilitation Committee, holding a variety of clinical and executive administrator positions with the Department of Social and Health Services and the Department of Corrections, and interning at Western State Hospital. Keri holds a doctorate in forensic psychology with an emphasis in public policy and law, as well as master's degrees in counseling, forensic psychology, and organizational behavior. Thank you all for joining us. I'm sorry. Thank you. So we'll start with the first question, and we're looking at Laura and Bipasha to answer these questions. This is the first one. What do you think is the most impactful upstream innovation we could do to influence how care is needed, provided, and experienced?
You go first? Okay, all right. Well, there are so many things. If anybody knows me, I like to envision a very different future from where we're at today. But I'll stick to one that I'm passionate about at this moment, which has to do with assessments. I really do think that if we could figure out how to accurately assess people's skills to what they actually are competent at, so that folks did not have to take education that wasn't necessary, that would be a huge move forward for us. People learn skills all through their life in all different ways, and right now, overall, we require people to start at the beginning and finish at the end. And the thing that I'm trying to figure out is how can we actually, and specifically around behavioral health, how can we assess somebody to know what their competencies are so that they don't have to start at zero and they can jump in part way if they already have some work experience or home life experience, that sort of thing. I'll stop there because I know I have to keep it short.
Okay, I'm a person with lived experience, so and I'm an immigrant from India. I think one of the biggest things we could do is if we could work on destigmatization on every aspect of behavioral health. Because like you said, I work on the crisis line, I answer calls from people, and I come from a community with a lot of stigma around accessing care. And I always think of how, in the 50s, everyone smoked, and the United States government kicked in, and there was a big campaign on educating us about smoking and its hazards, and very much fewer people now smoke. It had an impact. I think the government can do that. Keri? I think we could have an amazing campaign on educating people that behavioral health is a cornerstone of life. It is bigger than mental illness. It's bigger than substance use. It is an important factor for a good life. And then if you happen to deal with mental illness or substance use, you should be able to access help. But I think if we could build a campaign to really teach people about behavioral health, I think we would go a long ways in helping people be willing to get help.
Thank you. Our next question is for Bill O'Connell. Young people are looking to meet their mental health needs when they need them, to experience care that includes technology advances, and to have an active say in their care. So those young folks, how are we addressing it with them?
Sure.
I'm going to answer this question from a lens of one of my roles in my career, which is as a school counselor. And so my role in schools was as providing primary prevention. So I've done a lot of work that way. So when I think about it from that lens, I'm thinking about the fact that youth are, of course, always engaging, just as adults are, with technology. And there are opportunities to obtain information online. And one of the biggest fears for parents and caregivers is often, what are they looking at? Or what are they having access to? And how is it really helping? And I think that's a legitimate and justified fear. At the same time, there's a body of research that really suggests that youth are also benefiting from their online experiences in terms of social interaction. And I think earlier today in the morning, I know one of the presenters commented on one of the biggest concerns is isolation and being cut off from relationships with other people. So I think there is the capacity for technology to bring people together. So there are examples where I think this works. There's a website called 7 Cups, which is a website that offers immediate contact with someone who can provide emotional support and listening, and then provides a lot of information about mental health issues, also provides services for youth. And this is just one of a myriad of available services that are available online. I know there's folks here today from our own local Crisis Connections, which Teen Link is a part of. And I know some of my students have talked to me about how much they've benefited from that themselves. And so part of what I think we have to pay attention to is what youth want, which is they want ease of access to what they need. They also want to feel welcomed and included in the environments that they're in. And also to know that they can trust what they are interacting with. And so I think as leaders or adults, we need to pay attention to those spaces and the spaces that youth are in, both physical and virtual, and really bring our outreach to those spaces as well.
Thank you. Question 3, answered by Bipasha and then Keri. Many people first experience the system of mental health through forensic mental health or incarceration systems. Do you think that will change? What can we do to impact the dynamic where people are incarcerated but care is limited or even non-existent?
Okay, I'll just confess my expertise in this question is very limited. But I will say, since I am a lived experience person serving on the CRIS committee, I think the whole 988 process is, I'm hoping, going to be a game changer. I think the intention was to divert people away from emergency departments and law enforcement interaction. And so if we can, as we know through the 980 process, the 23-hour center bill was passed, and if we can build out those hubs, I think if people can call, so I'm talking about before you get to the point of contact and end up incarcerated. I think that's where we can basically play a role in actually reducing. I do want to say one thing which was very interesting to me. One of my colleagues, Michael Robertson, who's also a lived experience person on the CRIS, is a person who has been incarcerated many times and has been homeless. And he works as a certified peer counselor now. And it's very interesting when he said, you know, Bipasha, when I was out there dealing drugs or, you know, using, there was a lot more emphasis on putting people in jail. Because of that, it has reduced. He himself feels like there has been a shift. And it made me happy to hear that from his perspective, he feels we collectively as a society have become more aware that maybe drug use is not something that needs to be punished, but that people need care for it. And I'm just happy to hear that, but I'm gonna have the forensic expert answer the rest of the question.
Keri?
I think there's something to be said about kind of learned expertise when you go to a school, and then there's something to be said about we all as human beings, we know, right, the power of just connection, right? And so to answer the question really, really, really shortly, if I hope that something changes, or I hope there will be a change where folks who have behavioral health needs that are addressed or unaddressed kind of get that first interaction in the system by the criminal legal system, I sure hope that that changes. I think is just the very blatant answer that I can tell folks. As a forensic psychologist, I absolutely hope that it changes, and here's why. I think as we continue to challenge ourselves, right? I remember when my grandmother, and I was driving up with a friend that I'll give a nod to in a little bit, but my grandmother would whisper things like she had cancer.
Mm-hmm.
Do you guys remember that? Right? Okay. Cancer is really well funded right now, right? The research is out there. We know about it. We're looking at different things. I'm not saying we should stop funding cancer, everybody. I'm just saying, like cancer research, I'm just saying it's not whispered anymore, right? That's where I want us to get with behavioral health. It is, whether you want to call it a brain disease, whether you want to call it a behavioral health need, whatever you want to call it, the fact is, last I checked, I can't separate my head from my body. And any interaction that I'm having, any behavioral health need that I'm having, really needs to be treated like the brain disease that it is and not criminalized. And so what we can do is continue to normalize, continue to destigmatize. And just as Bipasha said, even though she's saying she's not an expert, she is because she's a person, is let's start early. For God's sake, can we not wait until somebody is arrested or has a diagnosis? Because there's so much we can do before. So I think I've used all my time on this question. I'm just going to stop and say, I sure hope it changes because we can change it.
Thank you. And question 4 for Bryan and then Bill. How will we change the dynamic of people going into the field of mental health to meet the needs of the individuals requiring care, but also the needs of those who are providing the care? What changes do we need to make to keep people in this field?
First things first, to my new best friend, Danie Eagleton. We haven't officially met, but I'm going to claim that. Thanks for saying hi, y'all. My North Carolina ears and my soul had a moment of familiar comfort. So that was a good thing. What I'm going to say, you've already heard up here today. First is, let's start early. Training the workforce, but also just training human beings. I would like elementary schools to teach active listening skills and resiliency. We have models where that has happened. Graduation rates soar. Their productivity in life after school grows. It's a no-brainer. Let's just do this. Advocate. You've heard it already. Let's normalize this. Let's destigmatize this reality. Let's just make it part of who we all are, because we can't separate head from soul, head from body. It's all one thing. Do it. Do it for mental health care in general, but let's also do it for healthcare professionals. There are paradigms of care. This happens often in emergency rooms. It happens less and less the further away you get from emergency rooms. After significant events where they sit down and process through what just happened. They debrief. This is simple stuff. It's straightforward. But if we talk about what we're experiencing, we're less likely to hold on to it and for it to become a mental health cancer, if you will, and grow and metastasize. And then finally, things are driven in our world by policy and money. Pay us well enough to do the job and pay our folks well enough so that they can live a reasonable life. Have policy that matters.
Thank you, Bryan. I would agree with Bryan's comment of starting early is really important in terms of life skills and how to take care of one's own mental health, if you will. my thought would be is that as we're building workforce, really thinking about, I think it's similar, Laura and I are working together on some things. I'm actually going to borrow one of Laura's comments too in just a moment. But thinking about what skills are we preparing people with to be able to do the job that they need to do. And I think when people, there's a relationship, if you think about the work of Bandura on self-efficacy, when people are confident in the kinds of skills they have or what they need to deliver, they tend to be more satisfied in their careers and in their work. So are we really working to focus on the kind of preparation we're doing and helping people to feel confident as they move into spaces with very complicated situations. But also thinking about that we're creating, as we're thinking about a stepped model of care for patients and clients, also a scaled model of induction into the field. One of Laura's comments that I love, I've heard her say this at other talks, is to be careful about putting the least prepared people in front of the most complex patient situations. And so I think that that's really inspired me to be thinking about how can we better create a supervision and education pipeline that really is preparing people developmentally and helping people to move into those spaces as they're ready. I can say in my own development, I have worked in very healthy organizations with tremendous supervisors. It exists, or it has existed and it does exist. And we need to capture that and keep building on that. And I think to your point, Bryan, it does cost money. And I think that's one of the issues we have to keep working on. But I'm hopeful that we can continue to do that.
Thank you. This is for Keri. As people age, their care needs change, their mental health issues also change. What do you think the future of mental health looks like in the aging population, particularly given this is such a quickly growing population, and are there creative ways to impact their mental health that need to be expanded or changed? And I'm very closely listening to this because I'm in that age group.
I'm actually really excited that I got this question. I have parents who are kind of, I think, struggling with some disconnection, right? And that's really impacting some mental health in them. That's, feelings of loneliness and anxiety and some depression. And I think it's all of these things we've talked about before, right? Human beings are human beings no matter kind of what age we are. And so some of this stuff just works with human beings, like being connected, like having a community, right? The opposite of addiction really is connection. We know that. And the same applies to the aging population. But I think what we know is that there are kind of these touches of brilliance that already exist in the physical kind of side of the house for our aging population. And how many of you, by show of hands, and you don't have to, but have aging family members, right? That could be you if you consider yourself an aging family member. Raise your hand. But I think, that's everyone. It's just like the conversation of how many of us are impacted by substance use disorder or family members and loved ones who have mental health needs, right? It's all of us. It's all of us. And so I think it is a recognition of, yes, we're all human beings and some of this stuff works, and it doesn't work for everyone, right? We're not going to give the same kind of social skills training that we would for youth in elementary schools as we would to individuals who are currently in an aging population, right? It just doesn't work. But we know that there are currently gaps in our system. We know that folks are living in adult family homes and they have behavioral health needs. And so what we really need to do is challenge ourselves, I think, as a state to get creative, which is look at our continuum of care and figure out where are those gaps in our system. And in my mind, if there's a need for an N size of kind of 1, we need to figure out what we're going to do to fill that N size of 1. So that can be done through continued integration, continued acknowledgement that right? Our head and our body can't be separated no matter what age you are. And I think it is just really that continued look at, as we have the aging population, it is more critical to educate around community, and it's really more critical to also educate around our technology that's coming up, right? There's a way that that can be used to connect our aging population together, and there's a way that it can also drive some wedges between our aging population and the rest of society. So I think there's all of those things, and the last thing I'll say that I am really excited about, and I'm looking at our peer services team over there, is wouldn't it be great knowing that community and connection is where it's at, that we really lean in on how can we have certified peer counselors who are in the aging population right now, who are there to help folks as we're all experiencing this. So I'm going to challenge us, team, to lean in and see what we can do to foster peer supports around the aging population in Washington State, because I think that that's kind of that connection, that brilliance in where we get to destigmatize and we just all come together and support each other as human beings. So that's what I would say with the aging population, is that creativity, plugging those gaps for the specific things, and lastly, peers, specific peers for individuals who are aging.
Thank you.
Yeah.
Question 6 for Laura and then Bryan. What are the biggest changes that will positively impact the field of mental health in the next 3 years and then the next 10 years? Think big, baby.
Wow, 3 and 10.
Yeah. I don't know, random.
Well, so I'm going to answer your question, but I just have to say this one thing about what you just said. I grew up in Japan, so I'm always tracking what's happening there. And just in Japan, they've actually started a program where they hire preschoolers to go live and play amongst the elderly. They actually pay them, and the money goes to their college accounts so that they then can go to college. So just out of the box, there you go.
I'm in.
I've solved your problems. It's great.
Everyone at the table's like this.
Yeah, so there are solutions out there that are
Problem
innovative.
solved.
But that's, okay, so to answer your question,
Yes.
I have to talk about behavioral health apprenticeships because that's what we do at our organization, and I'm really proud that we've been able to get those up and running, and I'm super excited about where we're going. The best news about our behavioral health apprenticeship programs is the employers currently, like in our substance use program alone, we have 22 employers participating. And the most exciting thing to me is that those employers who've participated in round 1 have signed up for round 2. So that means it's working. Like to me, that's the measure of success. We definitely have a lot more opportunity to get people engaged. And when we think about the behavioral health apprenticeship programs and getting our workforce trained up for people who don't have all the resources that others might, this is specifically a way for people to not walk away with huge student loans, potentially no student loans, and still have a degree. And to be able to come in with whatever barriers, they're actually getting to work. They get paid while they're learning. It's a really beautiful model that works. So when I look to the next 3 years and the next 10 years, I look to expansion of those programs beyond where we're at today into things like the assessments, where if we have folks who have experience, they don't have to start from the beginning, we can jump them in. So that's an example. We'd put them in partway through. Another example is some of the work we're doing with Bill, one of the projects with his BHSS program, being able to have the apprenticeship programs articulate directly in. My big dream, which I've talked to Bill about many times, is that we have a master's degree apprenticeship program. And this is a way to really address the loan issues, the diversity issue. I mean, there's so many things that get addressed if we can make this happen. So I'm excited about the future of workforce by thinking creatively to find solutions outside of our traditional way of doing things.
To build on the theme, I've talked last night at dinner and earlier today, if I could hire grandparents to hang out with children, so somehow we've got a thing going on here that would help all of us a good bit, so that's a good thing. First, I want to say I've been in Washington State just a little over 6 months now. Things like this are making a difference. Don't think this is normal, please. This doesn't happen in other states, maybe some. I've had the privilege of consulting in many places across the country. This is an unusual thing. So this conversation will change what happens not only in the Pacific Northwest, but across the country. Thank you for that. I've also had the privilege to talk to a few community college folks around. They are building pipelines as well and helping with folks in local communities to serve their friends and their families by doing the kind of work that you all do day in and day out. That makes a huge difference. On a bigger level, adverse childhood experiences caught my attention a few years ago. Ongoing research around that, it has so evolved from where it started back in the 90s, but that initial groundbreaking research was tremendous. And out of that, of course, trauma-informed care. I like to push that a little further to say, let's not just create care systems, let's create a trauma-informed culture, which feeds back into the advocacy and those kind of pieces. I'm going to name this with a little fear and trepidation because I know not even enough to answer your questions that I know I'm going to trigger. But research that's coming out around vagal nerve, there is something there. There is something there that is going to make a difference. Social determinants of health. First of all, I hate the term. I heard in another event not long ago, someone shifted to systemic drivers of health. Because as in our opening comments, it's the system that's broken. And I don't believe anything is determined. They get driven. We also need to recognize that poverty is not an illness, mental or emotional. It's just a state of being. It just is. Now, being in poverty can lead to things, so we need to manage that, but there's a mindset there. On a very pragmatic level, Medicare finally is realizing someone other than physicians, psychologists, and social workers can take care of the growing elderly population in our country. 25 years ago when I became a licensed clinical social worker, I was in, this is good, and I suddenly realized, oh my gosh, I'm one of 5 people in my community who can do this work. We need everybody else. So I'm glad that has opened up. I'm starting to sense there's a revamping of psychopharmacology, and that needs to happen. I believe that it is happening, and good things can come out of that, so let's hope there. My list is long, but my 2 minutes are up.
That was fantastic. So with this last question, I'm going to have all of you answer. We'll start with Bipasha first, and it's a very straightforward and not simple, but hopeful. What are you hopeful for?
Okay, so I don't think I was genetically wired to be very hopeful. Just to be honest. My first suicide attempt was when I was a tween, several across 2 continents, India and here. And here I am, sitting and talking to you all. What gives me hope is that I got help. I got it without going bankrupt, without being houseless. I had the privilege of doing that. And so that's what I try to represent wherever I go, which is that if we get people hope, a lot of people's lives can turn around. They can be at different tables, maybe not here, other tables, educating people about their abilities and what they're good at. So that definitely, I also feel there's a change. I've been doing the answering calls for 25 years. I think in the beginning we used to not really be able to say that I'm a person who's I'm a kind of a crisis counselor, but I also am a person with lived experience, and I'm feeling that movement is changing towards accepting. And I'm asking, since there's a lot of professionals here, if you have the privilege of being a professional and the privilege of owning your own lived experience, please start doing that, because it's going to make a big difference. I keep feeling that there are these walls of people who need help and people who can provide help, but real life does not work that way. We're all very intimately connected, either directly or through someone we love, to the issue of behavioral health. So that's the other thing. The other thing that gives me hope is behavioral health is a non-political issue because everyone on any side of the aisle has experienced it and believes that people deserve care. So that gives me hope, given, you know, all the political stuff in other arenas that goes on. So.
Yeah, woo! Yes, Bipasha. Okay, so I'm going to say this because you threw out a challenge. I have a diagnosed anxiety disorder. Just wanted to throw that out to everybody. And I have, thank you, Bipasha, for encouraging me to do that. Yay! Right, and I think what gives me hope, right, is I'm going to get woo-woo on you for a second and give a shout out to a friend of mine who I was driving up with today. And Rashi Gupta, who is on her second day of working for University of Washington, coming from the House. She is now coming and working at University of Washington. And she said, what are you going to say for your hope question? What are you going to say? And I got like 2 words out. And she was like, no, that's what I would have said. And it's this. It's the young generation, right? And I know I'm not going to be the only one that says it, so I'm so happy that I'm sitting here and not down at the end of the table. But it's this young generation who is saying, I'm feeling sad. I've got depression. I have anxiety. I have schizophrenia. Man, we used to whisper cancer, and now we've got youth who are just coming right out and saying, this is me, and if you don't like it, I don't really need to have you in my life. That gives me hope. And for that, I'm thankful, and I'm super excited to also step out of the way. So that gives me hope as the younger generation.
I can't repeat. Okay. Again, the list is long. I'll keep it reasonable. I find great hope when folks who've had to work hard to claim their story are willing to sit in front of a group and tell it. That is, that's hope not here, but it's hope that's deep and residual. So thank for all of those who've done that today. Thank you. I also find hope in an organization that has declared behavioral health isn't a side note, it is central to well-being. Please come and help us spread this so we can care for all of our patients. That gives me hope that it really matters. There's a lot of work between here and there, but at least we are claiming that. I have consulted with the Carter Center. Those of you who have hair's the color of mine will know that Rosalind, way back in the day, did not whisper mental health. She said it. And while those are days well gone by, it takes somebody willing to say it so that a generation later it can be real. So I'm hopeful for all the prophets in the world.
Yep, you said it. But I'm gonna put a little different bent on it. So we have 3 children, but 2 are gone. I've got 1 left. She's 16. And when I look at her and her friends, and I talk to them about what they want to do, we're having a lot of college conversations. And it's amazing to me the number of people at her age who are really, really interested in behavioral health. And they have been living it. For them, it's not some far-off thing. It's something through the pandemic, through all that. They've lived through all this. This is the conversations they're having daily. And so watching them, I will say, I hope this can turn into a hopeful thing. The one thing, like when I'm talking to my daughter about what she wants to do, she's interested in behavioral health, but she's also looking at that wage scale. Yeah. So I just got to tell you all, we got to figure out a way to address this wage scale issue. Yep. Because there are a lot of people who are interested, who at her age, who are just saying, I want to, and okay, wait, I probably should do this more pragmatic thing. So we got to figure out a way to address that. But definitely 100% youth all the way.
I'm hopeful that we can improve access to care. I mentioned before, in both in physical spaces and in virtual spaces. And I think Keri's comment about youth, I would echo in that I was invited last spring to guest lecture for a class at UW Bothell campus, and the course was Introduction to Mental and Behavioral Health. And it was an elective course for any student on the campus. And it filled up, I think, within the first 10 minutes of going up on registration, 50 students. And I was just really impressed with the diversity of the classroom and why people were there. And they just really wanted to learn for different reasons. Some were there because they were interested in the field or the career, and some were interested because of a family member, and some were interested because of themselves. But whatever reason was there, they were so invested in the course and really wanting to learn about how to be healthy and well. And so I think it's really promising, and I do believe that the new generation coming up as well will be just excellent in delivering care.
Thank you all so much for your vulnerability and your thoughtful answers. We are now going to open it up for questions. This is a great opportunity. Looks like we might have someone virtually.
Yes, thank you, everyone. So Lori, you touched on this, but of course open to everyone. What needs to change to legislatively and among social norms for us to move to competency-based curriculum and licensing?
Yep, that's where I'm trying to go with this assessment thing. So, it's really tricky. Our higher education systems traditionally have shied away from competency-based education. So they're definitely, at some point, higher ed has to get on board with this notion, and that can happen in a variety of ways. And I'm speaking that having come out of the community college. So I love higher education. But there's change in the air, and I think that there may be a requirement for some forced change, because in order to get some higher ed to move, they don't move swiftly, I'll say that. So sometimes it requires forced change, which is you will do this, you will create a program that has this kind of education. So I definitely think there's opportunity for legislation around that piece. And I'm saying that knowing I'm going to get lots of harsh words afterwards from my higher ed partners. But I do think that there's room for that. And it was legislation, and what was the second piece? Social norms, yeah. And that's just a matter of, I have to say that when we started to build the behavioral health apprenticeship programs, it was a challenge. People were fighting us. I mean, it's like my son always used to say, I'm going to fight you. And that's what it felt like. Like, oh, wow, okay. And that notion that both things can exist simultaneously and the world is not going to fall apart. And so getting all of us used to that notion of competency-based education is something, let's figure it out. Let's do it together and make sure that folks have those skill sets that they need. And so the social norms, I think, are really just about people taking the time to wrap their heads around this. Just because somebody's getting an education through this, testing to make sure that they know what they're doing, doesn't negate from your own experience of what you learned and what you gained in getting your PhD or master's, whatever it is. We need to open that up. If we're going to have diversity at the table, we have to open that up. And diversity is absolutely key to one of these things. Is we need caretakers who reflect the populations that they serve. And in order to do that, we have to open that door. Sorry for speech.
How do we deal with supervisors, managers, coworkers who have accepted that our system is the way it is, or whose only solution to burnout is self-care, instead of changing the system to be better?
Who's going to tackle that?
Everybody sits back.
Wow. What do you think, Bryan?
Move across the country to a better system. For those who have hope, don't lose hope. You have to be if you're the only voice declaring the hope, just do it. And when folks become cynical, they're going to be there. So I don't know that you're always going to convince everyone to turn around, but just be the model. We're on the forefront of that journey to all of healthcare becoming a better place for those who spend their livelihood there. And those who get it, those who are doing it well, just don't stop. Just don't stop.
Yes, my thought about that is that I know that as a supervisor and a clinician, I actually left academia for a few years, went back into just clinical work and supervising, and just recently came out of that. And so your day is very full. However, I think it's really also keeping in mind that we have professional associations that work on advocating at federal levels and state levels. And I think what I sometimes see in that is that there's actually the memberships in those organizations are fairly low compared to the number of people who are licensed. So I would really encourage people to think about getting more involved in their professional association, which is part of how you can advocate for that kind of systemic change. And they do accomplish tremendous things. Bryan mentioned earlier adding different provider types to Medicare. So I've been a counselor for 30 years. I was never able to work with Medicare clients until recently. But so, you know, just things like that. I belong to the American Counseling Association. They've been working on that for 30 years. It takes a long time, but it does, change can happen.
I'm just going to add something to that. So I'm a brown person, I'm an immigrant, but even I, for a long time, my approach tends to be very personal. I always try to see what can I do different. That's how I will talk to friends. What can you do different? So I've had to learn about systems and the impacts it has on all of us myself. I'll just name it. It's not a white person thing. That's all. I'm going to say that. We all have to realize that we are all products of a system. Each and every one of us. There's no exception to that rule. We've all been sort of, you know, taught messages, and we don't even consciously realize we're absorbing those messages. So I feel to that hopeful question that was asked, I think we are much more aware of the word system. I mean, 20 years back, I didn't hear that word systemic changes as much in the general consciousness. Obviously, there have been people who've been doing that work, especially Black populations have been doing that work for centuries in this country, but I think it's become more well-known. So that's where I find hope that we can really look at that balance between what needs to change. I think as an individual, I feel like we all want to say, oh, what can I do different to make my life different? It's a natural thing. You look at a kid and they will want to do something to make their situation different. It's a normal human instinct to want to change your life. So there's that balance between what can I do as a person within my small community and what does the system need to do so I can also thrive. And we have to kind of maintain that balance. I think saying if every system changed, we are going to be fine. That's not, because we all make personal choices also. So what's that balance between I make a personal choice informed by a system that I wasn't even aware of, and the system is still, you know, do you understand what I'm saying? It's very complex, and I never want to, when I talk to a client, I don't want to say you can't do anything to help yourself feel better, because that's not a very hopeful statement. So I will always acknowledge what they can do while also acknowledging how the systems they're in are basically holding them down and making it difficult to do that. So.
And all of us leaned away from our microphones when the questioning came up, right? Now I'm like, oh, now I want to answer this. Because of everything that folks have said, and I think I just want to point out this one thing, that this is hard work, right? We're all involved in behavioral health, mental health, substance use disorder. I know this is mental health. But you don't come to this because you like not making a lot of money, because you like working with folks on their most challenging day in front of you, right? You don't just think like, I'm going to do that because it's easy and fun. There's something that draws most of this to this work. And I get burned out because it's really hard work. It's hard work. It is exhausting, right? And in my mind, that kind of means that you're doing it right, and we need to re-engage and remind ourselves why we started to do this in the first place. So when we get burned out, maybe reconnecting with someone who is not burned out yet, and go back to the source, go back to your heart, And why did you start doing this in the first place? And that's maybe going to be a good beacon to getting unburnt and unstuck.
There's a great representation of the system up at this table, from a large provider to an FQHC to a healthcare administration. And over the past 5, 6, 7 years, there's been a lot of evidence out there that some of these new things that have been brought into the system for mental health are showing that they're promising. And part of the lack of that evidence was the original excuse for not reimbursing for mental health care. Now that we've onboarded a lot of evidence to show what we want to do can work, what are your thoughts on how we finally achieve parity in physical and mental health care and create new robust reimbursements within the private payer system for mental and behavioral health? I'll hang up and listen on the radio.
I'll do really quickly because I know that my peers on the panel will probably have something else to say. And now, Todd, how funny is this? Your question just left my head, so I'll have somebody else answer it now. Short-term memory issues just now. Todd, I really did forget your question, so I'll let my peers answer it now that I just jumped right all over you. Please, Bill.
Okay. I guess my experience is working in a value-based care system for providing physical, medical care along with behavioral health care. And so I think, we were definitely able to demonstrate to CMMS that we could lower the cost of care over time. So when you take on someone who's chronically ill and not healthy or well, it can take months, years to help that person start to stabilize both physically and emotionally. And so often, we're in a world where everyone wants things to happen immediately, and it doesn't. That's not the way humans are built. So I think part of the concern is looking at what payers' expectations are and what we're capable of doing. But we can show improved outcomes and lower cost of care over time. But I think it's hard for those models to be sustained for a long period of time. So I'm not sure what the answer is, but I would advocate for continuing to do that integrated model. I really believe in it with my whole heart. And I think that that's definitely what we want to be putting our energy into. Yeah.
And now I did remember. Thank you so much, Bill. Really good helping me remember. I think if we can, when I hear mental health parity, we all know what that means, but I also think, why don't we treat mental health just the same as physical health, right? I would not wait for a stubbed toe to turn into a broken toe, right, before I got a reimbursement for it. Now, the broken toe would not get reimbursed at the same rate as the stubbed toe. But right now, it's almost as if, just wait until your mental illness gets to a serious mental illness state, and then we'll go ahead and deal with it. And by that time, as Bill is pointing out, the cost effectiveness of that intervention is out the window. It's easier to treat people early, right, when you can get to that person, when that person might also be very willing to come through your door. And so that's the other thing, I think, is us having a conversation of how can we back up reimbursement so that we can start to provide services before there's a diagnosis even in place. So that's something for us to think about.
Wondering if anyone can speak to the fact that Washington State is engaged in a strategic planning process to re-envision the behavioral health system.
Oh, there's so many things. I'm looking at some elected officials out there too that I'm just going to make sure I'm not getting anything wrong. But I think there's a couple different avenues that are happening. There is the CRIS committee that is really looking at revamping the crisis response system. There is also a JLEC, which is a joint legislative committee that will be looking at a kind of long-term strategic plan for the behavioral health system proper in Washington state. And so there's a couple different legislatively driven things that are happening. The CRIS has a couple years under its belt. And the JLEC committee is kind of starting. They've just had their first meeting. There are a couple other meetings and work groups that are really focused on youth. We've got a children and youth behavioral health work group that also has a Diana Cockrell, who's at the Healthcare Authority table, is co-chairing the strategic group for prenatal to 25 and family services. They're included in that. And so I think right now we have a couple different interventions, and the golden ticket is to be finding that golden thread so that we can really look at a strategic plan for the entire continuum and everybody who resides in Washington, or in my mind visits Washington, who needs services. So I think those are a couple of the interventions that we're seeing that the legislature has, through their wisdom, really said we need to get some groups together that are involving all sorts of stakeholders. Bipasha is on a committee, lived experience. We've got, I think, many voices, or the intent is to get as many voices around the table for these committees as possible to get a strategic plan that's really going to be all-encompassing and all-inclusive of pretty much anybody who may need services in Washington. We're not there yet, though, but we're working.
I just want to add to what Keri said, which sort of echoes what she said in her previous responses. We meet as the Lived Experience Subcommittee every month. And yes, the CRIS is charged with the crisis, the continuum within a crisis, but everybody without fail says, what happens when I'm past the crisis? And so what I have sort of said, postvention and prevention, that if you draw a circle, if this is crisis, this part, if we don't pay attention to that, I think anyone who works in crisis, and I do, I would like to be out of a job if it's possible. And that's the challenge I put out to everybody, that make sure that, realistically that won't happen, but if we could just put a lot more resources into prevention and supporting people get out of a crisis, I think that would address the crisis system. I don't know how else to say it. It would actually address the crisis system. I'm just echoing what the lived experience community keeps saying over and over again. So.
Hi, thank you for this opportunity for us to, ask some questions. And that's exactly, 1 ounce of prevention is a lot better than 10 ounces of intervention. Totally agree with that. And my question is, I'm wondering about in this profession, whether we are actually looking into like holistic psychiatry and how that approach can actually deliver miracles. Because we have been using all these approaches for all these years, and it sounds like it's not getting better. So I'm just curious about that, how about the future, whether holistic psychiatry, or, even though like using all this natural approach and diet that can actually change our brain chemistry, and how that can actually move our future into a more brighter future, I guess. Thank you.
Before you leave, could you just describe what you mean by holistic psychiatry, just so we respond to that?
Okay, yes. Holistic psychiatry, I think, is more like instead of using a chemical-based approach, talk therapy is, one of them, definitely. But there are currently so many studies out there on how food can actually impact our, whole system in our brain. And actually our brain is actually in our gut, not really in our brain. And so I think it's just from that approach, more natural, biocompatible type of substance to take care of our brain rather than using the conventional way.
Okay, thank you.
Yes.
I guess my thought with that would be that, and I'm not a psychiatrist, but the efforts like collaborative care, as an example, or primary care behavioral health models, or opportunities to have psychiatry involved in medical care really help provide those avenues for holistic medicine, because it gives an opportunity for a provider to provide choices to patients. And I think that's the key thing that people are often looking for, is what are my options and how can I care for my body and my mind, my person. And so I do think that the models that we have in place, I'm very impressed with some of the collaborative care models that I've learned about that are going on, as well as our primary care behavioral health models, where the psychiatry is really consulting with other healthcare providers, but it gives the healthcare providers of the PCPs, many who advocate for holistic approaches, to be able to provide choices, in addition to medication, other ways that one can improve their health. And so continuing to build on those models, to me, would be really important.
Thank you. Thank you all for this terrific discussion. So much depth and great content. So lucky to have your expertise right here at our fingertips to answer these questions. We really appreciate you being here this afternoon. Thank you. So we are now going to take a short break. I'm learning at the end to finally move the slides. So from 2:45 to 3, we're going to have a short break. And for our next panelists, if you can be up here at around 2:55, help yourselves to snacks and waters. And they're still up there in the exhibit hall if you want to take a look at some of the exhibitors that are out there. We will see you at 3.
videos on it and it wasn't formatting. I don't know.
Yes. Oh. What time do you have? Oh, hello, everyone. It's 3 o'clock. Welcome back. It is 3 o'clock, and we're going to get ready for our next presentation. If you can please find your seats. We'll be returning back to the program. If everyone can find their seats, thank you so much. Jennifer, we've met several times. Oh, yes, of course. Yeah, the pickleball champions. Yes. Yes. Yes, you found each other, I think, at Mexico. But you live in the neighborhood. Yes, or one. But Fiona was a baby. Yes. So mutual friends. But I've supported you for yeah, I appreciate that. And I've been to an event here for Forefront. So, but I like it when I get to sit. Oh, happily. I love it. I do like sitting down on this. Hello, everyone. We're going to go and get this program started. If you can find your seats, please. Our fifth initiative, we're getting close to the end. Our fifth initiative is Workforce for Student Well-Being, Conditional Scholarships, Training, and Building Networks to Develop the Field of School Mental Health, presented by Jennifer Stuber and Eric Bruns.
Depends on whether you're in the old country or not.
I'm in the old country. Jennifer Stuber is Associate Professor of Social Work at the University of Washington and core faculty member of the UW Smart Center, and also, I am very honored to say, the founder of Forefront, a nonprofit for suicide prevention. Dr. Eric Bruns is a professor in the University of Washington Department of Psychiatry and Behavioral Sciences. His research focuses on public child-serving systems and how to maximize their positive effects on youth and their families. His two primary areas of interest are intensive care coordination models for youth with serious emotional and behavioral challenges and school mental health services. He is Associate Director of the UW Smart School Mental Health Assessment Research and Training Center, where he leads the center's Technical Assistance Corps and directs its postdoctoral research training program. Thank you both for being here, and I will let you take it away.
All right, thank you all so much for being here so late in the day on what's turned out to be a beautiful day. So what's really wonderful is to just keep coming back to this event. And thanks, Todd and Laura, for the inspiration for it. Every year, with a little disruption for a couple of years there, you get to come together in person and see so many old friends, new friends, collaborators, parent and youth advocates that you've worked with. It's just been a fantastic day. So 5 years ago, I believe it was, weren't we both together up here, stood on this stage and talked about how we were in the midst of a youth mental health crisis. And that was before we entered a global pandemic and all of the disruption to our young people's education and lives that ensued. So 5 years ago, we stood on this stage and asked you to support the cause of building a statewide system of behavioral health in schools in our state. So my boss, Dr. Jürgen Unützer, this morning asked us to focus on the positive, and that's not difficult to do when it comes to school mental health in Washington State. We have done a lot of things since then. We established a school behavioral health and youth suicide prevention legislative subcommittee. There we go. We launched, in response to the pandemic, we were able to move very quickly, thanks to the wonderful work of our partners at the State Education Agency, several behavioral health COVID response initiatives, several of which have been sustained with state dollars. Todd and Laura Crooks and Chad's legacy launched a mental health literacy program inventory, which was linked and is linked to Washington's learning standards for social, emotional, and behavioral learning. And that project continues and is expanding to this day. And maybe most important, our legislature passed a bill reducing staff ratios for staff that were critical to the cause of school behavioral health. So thank you to our legislators for that, yes. So this allowed districts to hire more school counselors, school social workers, school psychs, school nurses. It's progress. These are all pieces of progress, but there's so much still to do. Our state still really needs a clear lead agency for a holistic, comprehensive strategic plan for school mental health in our state. We got amazing leaders doing that work, but we could really stand to have a real clear lead entity in the state. We need to find a way to assure Medicaid funds can pay for school mental health services for all students. And luckily, I learned today, we have folks at OSPI and HCA who are working on that, and even went to a conference recently where they were learning about strategies they can use. So there's lots to do, but today Dr. Stuber and I are going to talk about something that the UW Smart Center is focused on like a laser right now, and that is the school mental health workforce. So let's see, where do we need to go here? So we're talking about the Workforce for Student Wellbeing Initiative, which we're launching with the help of many, many, many partners. If we're to fund more positions, okay, as the reduced staffing ratios might allow, we need to have more school social workers, more school counselors, more student assistance professionals who have bachelor's level training in doing this work. If we're to use effective evidence-based strategies across the school mental health tiers of universal, social emotional learning and prevention, to early intervention, to targeted, we need the school mental health workforce to be skilled enough to implement those kinds of strategies. If we're to provide culturally and linguistically responsive services, we're going to need a more diverse workforce. Right now we know that our student population in Washington is majority BIPOC, and our mental health workforce in the state overall is about 80% white, right? So we need more diverse, and we need better skilled workforce in order to make this happen for our kids and address the youth behavioral health crisis. So recognizing all these needs, we at University of Washington Smart Center, but working with OSPI, working with the Washington Association of School Social Workers, with WASA, with the Washington Association of School Professionals, submitted and got a $6 million 5-year U.S. Department of Education grant to do just that, work on our statewide school behavioral health workforce. So today, Jen and I are going to describe what our current Workforce for Student Wellbeing initiative is, which is building on that Department of Education grant to provide conditional scholarships to work in high-need schools in exchange for dollars to assure that these future members of our workforce are not saddled with the kind of debt that we've heard many, many panel members so far today talk about, the downsides of actually joining the behavioral health workforce, and talk about how we can use this as a start to building a comprehensive school behavioral health workforce strategy with everyone in here's help, okay? So I'm going to start with just a little summary of the grant and the rationale for it, and Jen's going to talk about the details, because a lot of the details of this project are based on some incredible work that the School of Social Work has been doing now for several years. So the overview of the problem, I think we all have probably appreciated this at some point in time or another, that when looking at some of the report cards out there, Washington ranks among, in the lowest tier among states for youth mental health in terms of higher than average prevalence rates and lower than average rates of access to care, okay? And this is for youth mental health in general. But schools, we believe, hold the greatest potential to address the youth mental health crisis, okay? Youth spend the majority of their waking hours in school. It's the most common place where mental health care is delivered. The UW Smart Center conducted a meta-analysis of dozens of research studies of where do youth, what sectors, the sectors in which youth receive care, and number one was schools. We confirmed that through the meta-analysis. We all have had incredible educators, teachers who supported us over the years. School staff, especially if they're prepared and trained to do this, can connect with youth. They can notice when youth are struggling and do something about it. And our educators, that's their job, is to teach. And they can teach skills such as positive relationships, coping with difficult emotions, social media use, right? My 12-year-old right now, I learned, is in her U.S. government class learning about disinformation and how to spot it online. I was so gratified to learn that. Goodness gracious. So we have effective strategies and programs across all the tiers of support for our school mental health workforce and our educators to use. But as was summarized by the Washington State Behavioral Health Workforce Audit, our workforce has got some issues if we're going to actually tap into it across all sectors, but not at all excluding the school mental health workforce. They're burdened by debt that creates barriers to recruiting and retaining the best and brightest. We know from working with folks all across the country in the field of school social work and other fields that school social workers, just as one example, come into schools in their first placement or their first job feeling underprepared for the realities of what it means to be an effective leader of their district or their school's mental health plan and strategies and services. And we know very well, and we've learned this the last 6 months as we've launched this thing 0 to a million miles an hour in a few months, that it is very difficult to recruit and retain in school districts that may need those staff the most. So, too few school mental health providers, few schools adopting effective school mental health practices, or not as many as we would like, and few school mental health providers of color, which is creating language and cultural barriers to mental health services in schools. So we have launched, with this Department of Education grant, something called the Workforce for Student Wellbeing Initiative, and we want everyone to get on board. It's only been funded since this year. But it is creating a pipeline for diverse, skilled school mental health professionals using conditional scholarships and bringing them into a statewide community of practice with their practicum supervisors to learn the fundamentals and specific skills in effective school behavioral health. We're currently focused on school social work, and what we want to do is expand this to all relevant school roles as best as we can in school mental health. Do you want to talk about some of the details?
Sure.
All right, there you go.
Thank you all so much for hanging out with us late in the day. This is the project of my career that I can honestly say I'm enjoying the most, because you actually can just tangibly see it every single day, kind of the impact that we can have and are starting to have working with so many partners. So Eric asked me to talk about the details, like what specifically are we doing? Well, we're working with the 5 schools of social work in the state. And we're actually going to hopefully be looking at adding also Heritage University in Yakima and WSU in the next year. And basically, all the schools of social work are working together to identify students who come from high-need communities, from diverse backgrounds, and who might not otherwise be able to get a degree, an MSW degree. We're bringing them to those 5 schools of social work, uniting them in a community of practice. I'll talk about what that is in a minute, but we're actually giving them conditional scholarships. And what that means is they get funding for their education, and then they are obligated to work in a high-need school district after they graduate. So have you all heard of Teach for America or programs like that? Like, why don't we have something like that for behavioral health? It's like hugely important. And by the way, what we're doing here is not just relevant to schools, although we're really placing mental health professionals in schools or in collaboration with schools and community mental health agencies is a critical strategy for our youth. This has application to behavioral health in general as a workforce development strategy. And so what's really exciting is we have our first cohort of students, and we're able to, with the Department of Education grant, we're able to give out 100 of these conditional scholarships. We would like to double that impact. I'm just going to be perfectly frank, like $6 million, we need to double that impact, because this is just truly a drop in the bucket in terms of what the need is. The scholarships, we've got our first 20 students. We're approaching our first 20 students being recruited. We're pretty much on target for getting the kinds of demographics, first generation, all eligible for financial aid, from communities of color, veteran. We have a single parent on the cohort. And basically, we've hired an amazing social worker. Unfortunately, she was supposed to be speaking today, so you got stuck with me. but she's sick. But she's an incredible woman. She won the teaching award at the UW School of Social Work many years in a row. She's leading the community of practice for these students. She's been working with some of the most high-need students in the Seattle Public School District for years. Her name is Rachel Barrett. She is leading the community of practice for these students and their practicum instructors. We've laid out a really cool 20-week sessions, 20 weeks of coursework, low demand outside of the classroom, but very high touch, to really kind of build this network virtually across the state. Then we'll be bringing them all back together again and continue with them longitudinally to support them, not just while they're in their programs, but also post-graduation, and follow them over time as well to see how the supports have helped them. Hopefully they have helped them. We're pretty sure they will. I just want to say one thing about conditional scholarships. I know there's a lot of people who are nervous about them because, oh, well, what if they don't live up to the commitment? Well, this experiment around conditional scholarships is no longer an experiment. It's been demonstrated that the levels of default are extremely low, like less than 5%. And if you really want to get diversity in your workforce, you have to work further upstream and offer the opportunity to people who otherwise could not avail themselves of it. So conditional scholarships, in addition to loan forgiveness, is a very, very important strategy to build a diverse workforce of behavioral health providers. So I guess really, let me just say a little bit about what's happening. So I said a little bit, we recruited the students, we've developed the community of practice, we're learning as we go. Like we've already started a longitudinal cohort of our students, but also a control group of people practicing in the field of mental health in schools to look at what is it that people need in this field of school mental health, but then also to demonstrate whether or not we're making any difference. So that's also really important. I've said a lot about the elements here, but we really also feel like once people graduate, they've got these close relationships with their practicum instructors. We need to make sure that the practicum instructors and the schools are available to accept these students and know what they're doing, to actually really implement evidence-based strategies in school mental health and know how to accept these young leaders that we are training. And so there's a lot of work to be done both on the school district side, but also on the Institute of Higher Education side. I will say our first cohort is placed all over the state. We've got students in Spokane. What was the name of the place we were talking about today? Calais? Tiny little school district in rural Washington, but still extremely important that we have people throughout rural Washington. Bremerton, all over the state, we've got people placed. We really just want to increase that impact. And again, stay connected, build that network, and then add to that network with more social work students and more other types of school professionals. Again, a model that can be replicated for other areas in the behavioral health sector where they're high need, like the crisis sector, like the community mental health agency sector. So how can you get involved? Well, you've heard a lot of this today. There is a legislative agenda around this. Again, our ask is actually pretty simple compared to some. We want to double our impact in this realm. As Eric has mentioned, we want to make sure that we're not just recruiting social workers, although that's a very important group. But we also want to make sure that the legislation is aligned to accept, different models for people going into schools to work in schools. We need to make sure that, for example, it's not just school counselors who are understood as being needed in this space, school social workers, school psychologists. They are all playing very, very important roles and they need to be working together. But we need to create that environment of collaboration through legislation and recognition of the fact that school districts need funding to be able to hire these personnel. We need more Medicaid dollars to go towards funding school people. Actually, not just Medicaid dollars, commercial. Let's be real. We need to be able to also get commercial insurance into schools and the community providers who are embedded within schools. So I think for me, I just want to also just make sure that we recognize that training students while they're getting their practicums, their internships, whatever, and also when they graduate to get their licensure, that is a very critical transitional point. And if we're really going to do a workforce strategy that starts with recruitment in communities of high need, where people working and living in those communities can make the most difference coming back to their communities. And then we absolutely need to support people all the way through this process, and that includes after they graduate, helping them to attain licensure if that's a credential they need to do clinical practice in schools, and recognize that we can't expect people to do this very, very important, very, in some cases can be very stressful work without, as we talked about, compensation, and importantly, it's not just compensation, it's support and low debt to go into this field. So that's what we're about. And we really believe that there's a lot that we can get accomplished because this federal grant has given us that opportunity for this proof of concept. But we don't want to stop here. We have to build on this momentum. So we're really asking, you've been asked to be on a lot of mailing lists. Everybody hates their inbox being full. I would ask again that you please become part of our mailing list and help advocate for this work going forward. And honestly, who doesn't want to give scholarships to high-need students? I mean, this is not a concept that is foreign, but we're going to couple it with, we are coupling it with incredible opportunity to sustain a really highly trained workforce. So thank you so much for your time and attention.
Yeah, I would also say, and I think Jen kind of insinuated this, no matter where you are in the state, but if you are in a Yakima or a Richland or a Walla Walla or an OMAC, and you know a high school student who might be asking, what might I want to do with myself? Send them to our website so they can consider, maybe I should, think about becoming a behavioral health worker. If you know a college student who's thinking about potentially what kind of career they might want to go to, perhaps this kind of conditional scholarship would be the thing that would push them in the direction of taking on the kind of service that our young people need through school mental health and with respect to this program specifically. But maybe we can build, like Jen said, all sorts of conditional scholarships across the workforce to build it. Okay, questions?
Hello. Why only focus on social workers when we have LMHCs and LMFTs? What about advocating for OSPI to have a designation for school mental health practitioners in addition to school social workers and school counselors?
Do you want to answer
Well,
that?
I can give the short answer, and then Jen will give the smart answer. The short answer is we need all of the above, and the Department of Ed opportunity was asking for specifically LEA, local education agency, hired practitioners. And thus, because we had something to build on that was already in effect in the School of Social Work called the Workforce Development Initiative, which had relationships with the MSW training programs, we built on that as a start. But I think, like Jen was saying, our interest is in building the school behavioral health workforce across all roles through this kind of triple aim, which is more folks who are able to stay in the field because they don't have debt, who are well trained because they're parts of communities of practice and are learning the specialized skills for doing evidence-based work in schools, and are from diverse backgrounds so we can actually meet the needs of our diverse students. So it is not a long-term vision that is restricted to school social work, but that's where we started.
Right, and I would just add, because of our virtual world, we can launch different cohorts, different affinity groups. I think we had funding for a proof of concept, which I think, and we chose to focus on social work, but by no means are we done. Let's put it that way. But Mandy, you had another part to your question that I missed, the second part about OSPI. I hate when people don't only answer part of the question and then you think you're being avoided.
We answered the easy part.
Yeah, we answered the one part. So yes, we want to expand to other disciplines, also to bachelor's level, but again, that's all funding contingent.
Yeah, it was just about advocating for OSPI to have a designation for school mental health practitioners. More of a comment.
Yeah, that's an interesting, I'd love to learn more about that. I mean, one of the things, I wanted to mention is OSPI has what they call an Educational Staff Associate 12-hour certificate program, which is what you need to have that formal designation in a school as somebody in the mental health field. We are actually offering that for free. Normally, students have to take that as part of our community of practice through the Workforce Student Wellbeing. We'll be offering that what we call the ESA certificate as part of it. Again, we intend to offer supports on the way to licensure. But we also want to partner with the PESB, another acronym, and OSPI, and to really ensure that the curriculum that we're building around the community of practice, once evaluated, once looked at by multiple disciplines, carefully, we could kind of move that into more of like some kind of formalization of a certificate or designation. But yeah, we obviously know we can't do this alone, as in the UW doing it alone. We're not doing it alone. We have lots of partners on this. So thank you.
Yeah, so what types of topics are addressed in the community of practice? Will students learn about how to work with students who are involved in gangs, substance use, witnessing domestic violence?
Amanda, you have such wise questions. I love it. The community of practice, so I really wish Rachel was here to speak to it. But do you want to speak about the first 20 weeks, focusing on the systems, and then I'll talk about the practices?
So, this is our first year doing this, so we're going to learn as we go and evaluate as we go and ask the students what they think of the programming.
And the current practicing social workers.
That's right. We're asking folks, what did you not get that you wish you had gotten before you went into schools doing this hard work, and are informing it in the short term there, but we're going to learn from our current students as we go. But our best first guess is to divide it up into two 10-week sections, where the first week is about what is a multi-tiered system of support in schools? What's comprehensive school mental health consist of? From across the tiers of universal school-wide to early intervention to targeted intervention. What's the role of a school social worker in leading the development of a comprehensive school or maybe even district level school mental health strategy? How do you partner with community agencies in a way that really creates interconnected school mental health? How do you bring in parents and students into advising how you're going to set up this system of support? So the kind of basics of doing an interconnected school mental health strategy in your school or your district. Then the second half is going to be more focused on specific programming and evidence-based practices. And I think some of the examples that were just read out are on the list of the kinds of practices that are going to be covered. Everything from chronic absenteeism to disruptive behavior. Yes, to suicide prevention. How do you do safety planning in your role as a school social worker? So, it's only 10 weeks.
20 weeks total.
Right, but I mean in terms of the interventions.
Yeah. And to be clear, this isn't like, we're not going to be providing like certification in dialectical behavior therapy through this community of practice. That's something that could come afterwards as you are becoming licensed, and we could potentially also build in supports to bring in that kind of training, some more specialized training as people are training for their license. But people are going to get a really good overview of the landscape around school mental health and what they need to do to be effective at multiple tiers. And then, if the people want to go into that tier 3 with the highest need youth, then we need to figure out how to provide supports for them to either have practicum placements in community-based agencies or to get additional training. But that's a great question, Mandy. Thank you.
Thank you so much.
Yes.
Wonderful presentation. Good luck. You can tell your boss you knocked it out of the ballpark.
Right,
Very positive. I'm hopeful.
Good. I'm glad.
Thank you. And our final new initiative for this year is Dementia Palliative Care Education, presented by Emily Ishado. I'm also going to remind you again of the Hubilo apps and that red tab in the survey. Don't want to forget that part. Emily, if you can, here you are, thank you. Emily Ishado is the Director of Operations for the Dementia and Palliative Education Network at the University of Washington School of Nursing. She manages strategic development of program initiatives, oversees acquisition of philanthropic state and federal funding sources, and facilitates community and stakeholder engagement. She also co-leads research projects and recently served as a primary interventionist in a study on increasing self-care practices among dementia care partners. Emily is trained as a geriatric social worker and has 20 years of experience serving historically disadvantaged and older adult populations in outpatient, community, and long-term care centers. Welcome.
Well, thank you very much. First, thank you very much to the Washington Mental Health Summit Committee for inviting me here today and organizing such a wonderful conference. I'll say one of my criteria for judging conferences is how's the food, and the food has been wonderful, so thank you very much, A+. And let's see here. Okay. And so, yes, for today I'll be talking about the Dementia and Palliative Education Network and how we're going to transform dementia care through increasing access to trained nurse specialists. And so I'm going to start with just kind of a little bit of an overview of dementia, but before I start, I'm going to set a timer, and once it goes off, I'll let you know what it indicates or what it means. But so first, what is dementia? You know, it is a neurological condition in which there is degeneration of brain tissue, and it can be a result of things such as toxic changes in the brain, reduced blood flow, or brain injury. It is something that is progressive and degenerative, and care and needed support is going to increase throughout the disease trajectory. Some of the common types of dementia are Alzheimer's, vascular dementia, Lewy body, and frontal temporal. So the prevalence of dementia, there is 55 million people worldwide. In the US, there's 6.7 million people living with dementia and 120,000 here in Washington state. There are higher rates of dementia in African American, Black, and Hispanic or Latinx adults, largely due to the influence of structural racism and how that impacts health equity and access, which then can increase the risk factors for developing dementia. And my alarm just went off, and that alarm was set for 65 seconds. And that's because every 65 seconds, someone develops dementia in the US. So within that time that I was speaking, another person developed dementia. And so that speaks to how this is going to double nationally in the next 25 years and triple globally by the year 2050. For people living with dementia, majority do live at home. They're cared for by over 15 million or 15 to 18 million care partners. And these care partners are providing about 18 billion hours of care every year. And we estimate that's worth about $339.5 billion. When it comes to the nursing facility, over half of the residents in nursing facilities are living with dementia. So some general characteristics, or what does dementia look like? It involves memory loss, confusion, some difficulty with executive functioning, so that can be things with difficulty with planning, judgment, problem solving. They can have functional decline of their activities of daily living, so difficulty starting to use the bathroom, eating, getting dressed. And then 90% of people living with dementia experience at least one behavioral or psychological symptom of dementia. And these are things such as apathy, depression, agitation, aggression, disinhibition, and psychosis. And so since we know that majority are living at home, being cared for by these care partners, what does the impact look like on the care partners? And I do want to start by saying there are many positive impacts as well for care partners. They can feel, a sense of satisfaction and accomplishment in being able to care for the person they love. They can feel a more emotional closeness to the person they're caring for, and they, can also have a sense of personal growth or purpose. But some of the adverse effects, to first start with the physical health impact, they report some subjective cognitive problems, feeling like they're forgetful or having difficulty planning or coordinating. A lot of it is due to the stress of caregiving. They have more physical strain because they are taking on more tasks, both personal health tasks and then also household tasks. Can lead to increase in frailty, mortality, increased risk for chronic health issues. And additionally, they're not engaging in self-care themselves as much. So a lot of care partners are really prioritizing the person that they care for. So then they're not the ones going to see their healthcare providers or, just remembering to eat healthy meals, take in fluids, and, take medications. On their behavioral and mental health side, they do have higher rates of depression and anxiety. They experience grief as they're slowly losing or, the person they care for is changing. They do have stress and frustration, some additional burden from the caregiving tasks, loss of sleep, and then also social withdrawal. So what does healthcare look like currently for the people living with dementia right now? So most of them, as they are living at home, they are getting their care in these primary care settings. However, 50% of PCPs are reporting they don't feel adequately prepared to care for someone living with dementia, and they would like to refer to a specialist. However, in the US, we have 5,170 geriatricians and 126 here in Washington State. And on average, doing the math, that would be like one geriatrician per 1,300 people living with dementia. As far as other providers, there's 7% of nurse practitioners and 1% of physician assistants who are certified in geriatrics. And for social workers, there's 4%, and less than 1% of RNs specialize in geriatrics. Additionally, we did do a survey at the UW School of Nursing for undergraduate nursing students, and only 8% stated that they were interested in entering the field of dementia. So there are certainly a lot of people, and it's a growing number, but there's not enough specialists to care for this population. And then on the long-term care side, where over half of the residents are living with dementia, there are various challenges there too: staff shortages, high turnover rates, higher physical and emotional demands. There is less of a desire for nurses and other healthcare fields to go into the long-term field because of stigma or anticipated challenges, lower wages, and a lot of this really exacerbated during the COVID-19 pandemic, so with increased anxiety, burnout, exhaustion during that time. So for, people living with dementia, some of the current health outcomes and what's happening for them, they do have a higher prevalence of hospitalization. So they're two times higher hospitalization rate than compared to older adults without dementia. Medicare annual costs for inpatient care for a person living with dementia is about $7,300 as compared to someone without dementia, that's $2,700. Their emergency department visits are increasing. It went up 28% between 2008 and 2018, and that was higher than compared to someone with cancer, heart disease, and heart failure. They have higher rates of admission to skilled nursing facilities. So 19% of people living with dementia have one stay or admission into a nursing facility annually compared to someone without dementia. That's 4%. They also have delayed diagnosis, so they aren't getting the diagnosis in time and aren't getting referred and access to the appropriate care. And then already kind of talked about dementia care partners, but some more about the impact on dementia care partners. They are increasingly providing more and more personal, household, and complex medical and nursing care. And oftentimes some of these tasks, they're learning it on their own, and they're feeling very unsupported and lost. They're more anxious and stressed over possible errors. They're doing things such as could be even wound care and all those other types of management at home. So, and additionally, as we know that 90% are experiencing behavioral and psychological symptoms of dementia, this does put a strain on the care partner in trying to manage the mental health needs. So now that we know the numbers of people living with dementia are rapidly growing, there aren't enough specialists or healthcare providers in the field, and the well-being, physical and mental health is impacted both for the person living with dementia and their care partners, we came up with a solution, and we started that in 2020. So we began this at the University of Washington School of Nursing, which is a #1 ranked school nationally and globally recognized institution, where we developed the Dementia and Palliative Education Network. And our goal and mission is to revolutionize healthcare delivery for people living with dementia by training nurses to work at their top of their scope of their practice, while providing dementia care in all healthcare settings and really start to fill some of these workforce gaps. So why did we choose nurses? Well, that's because nurses comprise the largest segment of the healthcare system. There's about 4 million nurses right now practicing in the US. And nurses have a really holistic skill set in which they can really address a lot of the different care needs for people living with dementia. And so they can take on a lot of the tasks that are needed. And then therefore can fill these healthcare workforce needs. So our team, we do have an interdisciplinary dementia palliative education network team, which is comprised of a group of professionals that includes nursing, internal medicine, social work, sociology, public administration, psychiatry, curriculum design, and DEI experts. So for our first solution, an innovation that we developed, it's called the Dementia Nurse Scholar Training. And so this is a comprehensive training that targets nursing skills and competencies, and it's based on 6 domains of care in which we are centralizing dementia as the organizing principle of care. It was developed by Dr. Sue Borson. And so the framework that you can see there on the left, it includes domains on cognitive health, emotional, behavioral, and spiritual health, physical health and function, care partner capacity and needs, health-related social needs, or I like what the other person said, systemic drivers of health, and then care delivery framework. And additionally, our curriculum is based on 3 different levels in which we are wanting to train nurses to do problem detection, so screening to understand if there is a problem, how to do a further detailed assessment and understand the extent of the problem, and then engage in care management. Our curriculum, it utilizes a DEI and anti-racism framework, and each module is reviewed by a DEI expert to ensure inclusivity. And additionally, we do have 2 modules that are specifically dedicated to teach about health disparities, the nursing role in deconstructing discriminatory systems and promoting equity, and as well as exploring the nurse's own positions of privilege. We are developing a total of 20 different modules. One of them is listed up there, Introduction to Comprehensive Dementia Care for Nurses, but a total of 20 modules, and each module is anywhere from about 30 to 45 minutes, and it's done asynchronously and through an interactive platform. And we initially wanted to focus on education and training because we know this is an important venue to really expose nurses and clinicians to dementia care and can help improve attitudes and confidence in caring for this population. For our curriculum, currently we are piloting it with Emory Integrated Memory Clinic nurses, and then we're also piloting it with another group, small group of students at the University of Washington School of Nursing. And then for our next program, and thank you to the Department of Social and Health Services and Healthcare Authority and Aging Long-Term Care Supports Administration, we developed the Excellence in Long-Term Care Externship. So our hope with this program is eventually we're going to create a workforce pipeline in which we really expose nurses to this, the long-term care field, and then to enter long-term care. We launched this originally in 2021. We've had 3 cohorts so far, so we're in the middle of our 3rd cohort right now. A total of 19 students have enrolled. And what we did was we utilized a Washington state legislation in which nursing students are allowed to be working as nurse techs and also get school credit. So they are working in these facilities as a nurse tech for 6 hours a week minimum. They also do a 90-minute seminar in which they are going to be getting lessons and input and feedback from a long-term care nursing expert. And we really focus on 17 long-term care nursing competencies and core skills. And as we've been evaluating this program so far, we really have seen how it's changed the attitudes of the students and how they feel about long-term care. They were really able to understand the high skill that is required to be a long-term care nurse. Many students have commented about how they've done so much more in this long-term care externship clinically than they did in all of their other clinical rotations. And additionally, they really were able to appreciate the connections that they're able to make with the residents. A lot of the nurses, I think they're doing rotations in hospitals, so it's an acute and patients aren't there for very long, but they're able to get to see the same residents every week, and so they've really enjoyed that. And it has increased some of the interest in geriatrics. Our hope is that students are going to go into long-term care, but so far students have gone into adult geriatric nurse practitioner fields, and one did enter hospice. So the next initiative is the long-term care workforce, where we're developing a residency. And the reason is because for the long-term care externship, so far none of the students have gone into long-term care after graduation. And one of the reasons that they noted is that they really value this experience of residency and really feel like that's vital for them to transition into nursing professional practice. And so with the support of the Washington State Legislative funding, are going to be working on a long-term care residency program for nurses. This is going to include a virtual online platform where it's going to include specific trainings on long-term care core skills, a mentorship program so that they can connect with other long-term care nurses, and engage long-term care facilities to participate and enroll their new nurses into this program. This is something that we're working on currently from now, and we'll complete it by June 2025. Additionally, we're going to be working on a public awareness campaign in which we're really wanting to do more education and outreach regarding a career in long-term care to attract more nurses to enter this field, using more social media, website, video, testimonials, and this is going to be also completed by 2025. Of note, the picture there is one of our long-term care students who is with her RN preceptor, and it was a really good experience. And then lastly, just want to mention the dementia care technology that we're working on, and it's called Dementia Care Works. And we're using this in conjunction with our training because it's based on the same 6 domains of dementia care. And it's intended to help nurses engage in dementia care practices by guiding them through the screenings and the assessments that they need to do for each of the domains. We do hope to eventually integrate this within electronic health record systems. And as you can see, there's various scoring summaries and visualized data to help the nurses understand how their patient is doing. We have already completed a prototype, and we'll be developing a full system and pilot testing it within the next year. So, to state for our vision, we really want to establish strong and supportive workforce pipeline for nurses to enter the field of long-term care, geriatrics, and dementia. We want to have successful healthcare systems that proactively respond to the needs of people living with dementia and their care partners. And ultimately, we want to improve the quality of life, health, and happiness of people, families, and communities throughout the lifespan and dementia disease trajectory. So for how you can get involved, if you're with a college or a university and want to implement the dementia curriculum or the long-term care externship program, please get in touch. If you're a long-term care facility and want to train students or nurse residents in your facilities, or can lend your expertise about our RN residency program and development. If you're a part of a healthcare system or a community organization and you want to partner with us to train your staff in dementia care or learn about how to maybe integrate nurses into the dementia care team. Additionally, if you have experience in social media, website, public relations, or an awareness campaign, and want to lend your expertise in those areas or executing a campaign such as that, we would love to hear from you and partner with you. Okay, thank you very much.
I'll just say you're getting lots of love in the chat for highlighting work in the dementia area. So first question, is the UW School of Nursing connecting these training opportunities to our community and technical colleges? I think some of these programs, as being great sources for nurses for long-term care facilities, and also seems important for LPNs.
Yeah, no, this is definitely and absolutely something that we would want to really start disseminating to other campuses and colleges throughout, state and nationally. We, do focus this on RN specific skills and competencies, but are wanting to also expand it to other clinicians that are going to be involved. So that would include LPNs, CNA, and adapt the training for each of the types of clinicians. So thank you. Yes. So if whoever that came from, please contact me. Would love to connect.
Hi, I have a question from chat online as well. Jerry asks, on almost every slide, the word dementia could be replaced by severe mental illness, and the data would still be accurate. Why are these conditions managed so differently in our medical systems?
Oh, gosh. Very good question. I don't know. That's a good question. Why would it be, I guess I can speak more to dementia and how that is currently being treated. It's a difficult disease and condition, and there isn't a cure. There isn't specifically right now a cure. And I think that can be really difficult to manage and navigate and negotiate. And it's very complex because it affects every other aspect of a person's health. And so I think there is that challenge in trying to manage care for people living with dementia, especially with the complexities of mood and behaviors, and what is part of dementia, what is part of something else, and it's kind of difficult to figure that out. But thank you, that's a really good question. I'm sorry I can't speak better to that.
Take another one from online. Will there be training on how to use trauma-informed practices to support families, loved ones of those suffering from dementia? Will there be resources accessible for the families and loved ones?
Oh, yes. So specifically for our RN training, so we're training them, with definitely the framework of when it comes to the mood and behavioral issues from a trauma-informed perspective, and what are some things that might be impacting their behaviors today. And so it's really through the nurses that we're trying to disperse this information and provide support to people living with dementia and the care partners. However, I will say, I only talked about a few of our initiatives, and as it had stated, we are doing also, we have done things such as support to care partners of how to communicate and advocate for themselves with healthcare clinicians. And so, but right now, specifically with this, we are trying to disperse that information through the nurses to get to the family member. Thank you.
Hi, I have another question. This one is from Gretchen. Would the education you have created be beneficial for acute care nursing, caring for patients with dementia in the inpatient setting?
Would it be for an acute?
Would it be beneficial for acute care nursing and caring for patients with dementia in the inpatient setting?
Oh gosh, yes, absolutely. So we've been really trying to understand the best way to disseminate this information. And, definitely in acute care, I think nurses, they are trained in there's some models where it's focused on delirium and fall prevention and infection control, but really trying to help them understand more, like when a person living with dementia comes into your facility, what do you need to know in that short period of time? And I definitely think we've been thinking about how we can structure this training to different levels and different sorts of needs. It is quite long. It is 20 total modules, but what would you need in different sorts of settings? So thank you. I definitely think that would be excellent for nurses in acute settings.
Do the graduates typically work in facilities or also in private homes?
The long-term care externship program, it's all in nursing. Oh, sorry, are you talking about after nurses graduate? The graduates.
Unclear.
Oh, the graduates. The graduates from the program of long-term care externship specifically, one went into hospice, and then I think others went into outpatient clinic care. But if talking about for the long-term care externship, it's only in nursing facilities, so they're not going into homes. Sorry.
Besides qualified nursing staff, is there any initiative to have peer specialists qualified for the aging population, integrating our already qualified mental health peers tailored to the aging population?
Oh, I love that question. And that's something, I really appreciate that. And I kind of being here and hearing more about that, I think that's something that definitely we want to integrate and include and think further about. Right now, we had started off with, nurses, and then we're wanting to expand. I mean, there's so many different people that are involved with dementia care. But I appreciate that question. And currently, I think that's something that we definitely should explore. So thank you.
Why do you think students sign up for the long-term care program but then don't go on to work in long-term care facilities?
Yeah. So we do really try to, we engage them through, it is a paid externship. We do offer a scholarship as well. And so I think they're interested in learning more. But I think, as I was saying about the residency part, they are worried about just transitioning into nursing professional practice without this residency. Some have said they did a residency and realized they didn't need it after they did the long-term care externship. But I think, it's kind of, we've done this for 3 years, and maybe, it's kind of a slow growth to get more nurses interested into long-term care. And we continue to evaluate what would have helped them get into long-term care. But one of the reasons is residency.
Thank you. Thank you. People see me coming and they immediately leave the stage. I'm like, not yet. What a number of really incredible initiatives that we heard and learned about today. And now I'm going to remind you again of the Hubilo app. If you can please go to it. There's the red tab. Take the survey. That is incredible information. Also, we were talking about burnout and how we can be hopeful. By responding to those, you're going to make a lot of people on the other end very hopeful and hopefully alleviate that burnout because they know that you care and you're taking the time to do those surveys. And it's your opportunity to sign up to collaborate, join. You can get boots to the ground. You can start working, finding what really hits your heart the most today, where you think your skill set will best serve. So we really encourage you to do that. And with that, I will now pass this on to Laura for closing remarks.
You can tell that I don't want to be up here alone because this morning I was with Todd and now I'm with Bert. So here I am. So first, before I get started, there's 2 people that I want to recognize. One of them I don't see sitting over there anymore, but Latanya and Elise, who was here before, my 2 mother partners in this work, who I met one today and one I have seen before, and the other mothers who are out there in our audience or virtually. I see you and I know you see me, and we matter in our story of our children, whether they're young or whether they're adults. They matter, and we all matter. So mental health and mental illness is not just about being strong. We know this. This is a picture of Chad, my son, with the Hulk. Chad, my goofy, sweet, loving, silly boy, who was at Disneyland in the Lego room with the Hulk. This was taken just before he was diagnosed with schizophrenia. Mental illness isn't a weakness. It isn't about being stronger. We all know that. We also know that there is a mental health crisis out there with more people needing help and not enough help available. We heard about that today. To solve this and to serve those living with mental illness to thrive, it takes all of us pulling together. You are here, you out there are here, and you make a difference. You've heard 6 initiatives today. Pick one. Do something. Help make connections. Sign up for a committee. Bring your ideas to the workplace. Reach out to the initiative leads if there's one that speaks to you. Go to the Hubilo app, pull up that initiative, and say, I'm interested. Make a difference. I also want to thank our Mental Health Summit Committee members again, Melody, Elizabeth, Rebecca, and Cara. Thank you so much. To our Mental Health Summit Advisory Council who helped us pick these initiatives and who helps us always stay focused, thank you. To the Behavioral Health Institute and the University of Washington Department of Psychiatry who have continued to be our partners in this work and help us be able to do this in the hub where we can bring everyone together, thank you. Thank you to our sponsors for today's event. You guys really do make a difference, and we are so grateful. Roberta, thank you for being our MC and for always being my friend and partner. And thank you to all of you. Thank you for being here. Thank you in advance for the work that you will do outside of this room to help push those initiatives forward. And thank you for staying to the end of the day and for being here. You matter.
Thank you. Yes. Thank you all. Thank you for your time. We hope you leave here inspired and ready for action. Enjoy the rest of the day. It is not raining.
Just one other really quick word for those of you who are joining us for dinner. It's at Piatti's, not at Mama Molina this year. So just remember it's at Piatti's in the University of Washington, or the University Village.